Dr. G.B. Shankwalkar Dental Research Paper Award by IDMSB and Dr. Shardinini Dahanukar Best Teacher Award by the MHS Nashik. Sir will join us shortly. Next chairperson for the session is Dr. Abhishek Verma, sir. He has completed his MDS in 2009 from Sharad Pawar Dental College and Hospital, Wardha. He has passed BDS in 2005 from PMNM Dental College and Hospital, Bagalkot, Karnataka. Sir has over 12 years of clinical experience in practicing implant and routine periodontal surgeries. He has demonstrated abilities at teaching, training, and monitoring postgraduate and undergraduate students. Dr. Verma, sir, is presently working as a professor, Department of Periodontology and Implantology, Buddha Institute of Dental Sciences and Hospital, Patna, Bihar. Skilled in ensuring teaching, design, he has strong communication, analytical planning, and coordination and relationship management skill. He has various publications with national and international journals. I welcome you, sir, for this session.
Thank you.
Kurte sir will join us after 10 to 15 minutes. So,
Sure,
sir,
sure.
can we start with the session now?
Sure, as you wish.
Yes. Thank you, sir.
Can we wait for sir or should we start?
Sir, actually, sir will be joining shortly. Yes.
Oh yeah, sure. We'll wait for sure.
Good evening, everybody. Today, I would like to present a paper on evaluation of hematological parameters in healthy and in chronic periodontitis patients, a clinical and a hematological study. Periodontitis is an inflammatory disease that is fundamentally initiated by chronic bacterial infection. The periodontal tissues mount an immunoinflammatory response to certain bacteria and their products. The systemic challenge with these agents also is known to induce a major vascular response. Certain inflammatory cytokines produced during periodontal inflammation are known to depress erythropoietin, thus leading to development of anemia. The aim of this study was to evaluate hematological parameters and clinical parameters in healthy as well as in chronic periodontitis patients. The 60 methodology was 60 patients were selected from the OPD of a dental college. 30 patients out of it were divided into the test group and 30 were divided into control group. Total number of parameters assessed were total number of erythrocytes, hemoglobin concentration, mean corpuscular volume, mean corpuscular hemoglobin concentration, total leukocyte count, differential WBC, platelet, bleeding time, and clotting time. Inclusion criteria: the probing depth, patients having probing depth of more than 5 mm in more than 30% of the sites, and control group included the patients with clinically healthy gingiva having probing depth of less than 3 mm. Exclusion criteria were the female patients, mainly having propensity to develop anemia. That's where they were excluded. Then the patients having any systemic disorder, the patients with any previous history of periodontal therapy in last 6 months, with the patients with having a current or past habit of tobacco smoking or chewing, then patients receiving history of hospitalization or intake of medications in last few months, patients receiving nutritional supplements and having a history of extraction within past 6 months, patients who examined for chronic periodontitis on the basis of the following criteria, that were the probing depths more than 5 mm at the 30% of the sites, clinical attachment levels more than 3 mm at 30% of the sites, along with gingival index and plaque index. Probing depths and clinical attachment loss was recorded at of the both test as well as the control group. After periodontal recording, blood was taken from the patients and the hematological analysis was performed. The statistics as follows. Results of my study: mean gingival index and mean plaque index were found to be significantly higher in the periodontitis group than in the healthy group. Decrease in total erythrocyte count and hemoglobin count was evident statistically, whereas leukocytosis and thrombocytosis was also evident. MCV was found to be slightly lower in the periodontitis group and was slightly significant, while MCH and MCHC were not as affected as MCV. Bleeding time and clotting time were also known to be affected but not statistically significant. Discussion: Cartwright in 1966 postulated that at least 3 pathologic processes were involved in ECD, that was shortened erythrocyte survival, failure of bone marrow to increase RBC production to compensate for this increased demand, and impaired release of iron from the reticuloendothelial system. Pro-inflammatory cytokines are thought to be acting as a mediator in suppressing erythropoiesis from bone marrow, leading to the cause of anemia. Certain pro-inflammatory cytokines like interleukin-1 alpha, interleukin-6, TNF-alpha have been known to have association with suppression of erythropoiesis. Anemic status in our patients in our study is thought to be caused because of the periodontal tissue inflammation. Then one study indicates that interleukin-6 mediates hepcidin increase and consequent hypopherimia. Depressed MCV values suggest microcytosis, which is most commonly associated with iron deficiency. Then erythropoietin is the hormone that is responsible for regulation of the erythropoiesis. TLC was found to be significantly increased in the periodontitis group, and along with that, neutrophils, erythrocytes, and leukocytes were found to be increased. Higher number of leukocytes in the blood rheology make the cells more viscous. More cells adhere to the endothelial cells lining the blood vessels, thus decreasing the blood flow. The reduced blood flow could play a role in relation to the cardiovascular diseases, especially in narrow or partially blocked arteries due to the atherosclerotic plaque formation. Bacteria activate thrombocytes and cause reactive thrombocytosis. In our study, the plaque and gingival indices shown significant increase in the periodontitis group, which indicates that inflamed sulcular epithelium, due to its effect of bacterial plaque, forms an easy portal of entry of the bacterial plaque into the sulcus, gingival sulcus. Thus, the bacteremia that is produced in periodontitis is reported by oral examination, and certain periodontal pathogens are identified in the atheromatous plaques. Also, bacterial components such as major outer membrane proteins and endotoxins are found to be disseminated. The pro-inflammatory cytokines are once they elevate, they are dependent and they result into the severity of the anemia. Limitations of this study: the comparison of post-therapeutic blood parameters in patients suffering from chronic periodontitis would add to our understanding with regard to the changes in the blood parameters in chronic periodontitis. The blood parameters of the chronic periodontitis group were not available in the healthy state, and as a result, it becomes difficult for us to ascertain whether the changes in the blood parameters occurred due to the diseased condition or not. Recent systematic review and meta-analysis, Dongliu et al. In 2020 carried out a systematic review and meta-analysis to assess alterations of the level of hematological parameters and iron metabolism marker in patients with or without periodontitis. Generally, anemia of inflammation, that is a hallmark of chronic and persistent inflammatory diseases with prolonged immune activation, is characterized by insufficient production of the erythropoietin and decreased response of the erythroid progenitors. In addition, anemia of inflammation inhibits the release of iron from the body stores and alters the iron status after being stimulated by hepcidin. A number of diseases might ultimately lead to anemia of inflammation, including chronic kidney disease, chronic pulmonary disease, and congestive heart failure. By Weiss et al. In 2019, this systematic review and meta-analysis indicate that periodontitis decreases hemoglobin concentration and disturbs the balance of iron metabolism, which confirms strength of association between the periodontitis and developmental tendency of the anemia of inflammation, especially for the cases of severe periodontitis. Conclusion: thus, it is concluded that from the present study that unlike other chronic conditions, even anemia is known to affect periodontitis. Since in our study we did not intervene any of the periodontal conditions by way of treatment and measurements, later on it was not possible for us to comment whether anemia was a factor that caused periodontitis or it was a consequence. Thus, the authors conclude that there is a confirmed relationship between anemia of chronic disease and periodontitis. The low-grade inflammatory state in periodontitis patients is defined by marked leukocytes due to increase in number of neutrophils and lymphocytes. Thus, there is confirmed relationship between the anemia of chronic disease and periodontitis. Thank you.
Hello.
Good morning, sir.
Good morning. So, did you went for any of the treatment modalities with these patients?
Sir, due to COVID, we could not carry out, since the ultrasonic scaling was also not possible for us to carry out, we did not intervene any of the periodontal treatments. As a result, we had to only compare between the indices clinically and the hematological parameters. But we are going to continue this study post-COVID and complete it, sir.
So, how did you differentiate between, because you're not indulging into any of the clinical procedures?
So, based on the inflammation, we checked plaque indices, gingival indices, which helped us to know how much was the...
That may be because of the pre-existing periodontitis as well.
So we made sure that patients, it might be, sir, but then we could not help it out due to COVID, sir.
So what do you conclude?
So that anemia can result into periodontitis. Even if the patient is earlier not anemic, also a periodontally, also a chronic periodontitis patient can result into anemia. Both are interlinked diseases. So that is the reason we should, because they both are associated with the inflammatory cytokines. So that is the result also called as cytokine mediated anemia. And nowadays also called as anemia of inflammation. So as a result, so many parameters together are affected in periodontitis as well as in anemia, like total erythrocyte counts, leukocytosis, reactive thrombocytosis. All of these together make us to come to a conclusion that anemia can cause periodontitis if initially the patient is periodontally healthy. Also, a chronic periodontitis can result into anemia if not treated, if the patient has not undergone any periodontal surgical treatment, then he can later on result into anemic patient because of this cytokines and acute phase proteins all.
Can you justify it as a two-way interrelationship between these two?
Yes, sir, due to the inflammatory cytokines, the load of the inflammatory cytokines like interleukin 6, which is known to be associated with the hepcidin, that is a pro-hormone associated with production of production of hemoglobin, production of erythrocytes. So all of these make us to a conclusion that yes, it is a two-way relationship. Periodontitis can cause anemia and anemia can cause periodontitis.
Okay, fine. Okay, fine.
Okay, thank you, sir.
Hi everyone. Topic for my paper presentation is efficacy of different sterilization protocols and impact on osteogenic potential of autogenous tooth bone graft. These are my guide and co-guides. Bone graft materials have been successfully used in dental practice, and according to bone healing mechanism, it can be grouped into materials that induce osteogenesis, osteoinduction, and osteoconduction. And to provide a rationale, these materials must be at least osteoconductive. Bone graft currently used in dental practice can be divided into autograft, allograft, xenograft, and allograft. And among these, autogenous graft are most preferred as these contain vital bone cells. In 2008, it was first developed from the extracted tooth by Mehta Hall and used in dental clinics. In the past few years, due to increase in the incidence of communicable diseases, concerns have been raised about the safety of autogenous tooth bone graft. And to make an autogenous tooth bone graft a possible alternate for periodontal regeneration, we need to maintain quality standard and their unique bone genesis property. Various sterilization procedures used in dentistry include irradiation, autoclaving, heat treatment, etc. And although studies have been already conducted to rule out the best sterilization procedure, but very few studies evaluated the osteogenic potential of autogenous tooth bone graft after the completion of different sterilization procedure. As it is an important task, so in the present study, we aim to compare the efficacy of different sterilization protocols and their impact on the osteogenic potential of autogenous tooth bone graft. Primary objective is to evaluate the microbiologically the effectiveness of different sterilization protocol. And the secondary objective is to evaluate the osteogenic potential after completion of different sterilization protocols. And this is a comparative in vitro study with total sample size was 98. These are the inclusion and exclusion criteria of the studies. These are the study sample categorization, and each group and subgroup contain 10 sample and 28 samples are kept as a non-demineralized, which considered as a reference sample and were treated with the same sterilization protocols of the study. These are the sterilization protocols that was adopted in the study. And this is the workflow of the study that involved the grinding of the clean, dry extracted tooth. And after the collection of desired particles, the particles were demineralized or were divided into demineralized sample and non-demineralized sample. And after that, sterilization of each sample was done. And after the completion of each sample, evaluation of microbiological and biochemical parameters were done. For microbiological parameters, the samples was incubated at 37 degrees Celsius for 10 days, and at 3rd, 7th, and 10th day of incubation, direct inoculation was done to find out the presence of microflora, and also after checking the presence, the total colony forming units was counted at each interval. For biochemical parameter, the concentration of BMP2 in the samples was determined by ELISA kit, and it was used according to the manufacturer's instructions. This is the bar diagram which showing the presence of microflora in the demineralized normal cell line group as well as in the non-demineralized autoclave and non-demineralized normal cell line group. Then mixed ANOVA analysis performed to find out the significant difference between different days of incubation and immunized, and both are significant as p-value is less than 0.05. Then for pairwise comparison between different groups, two subsets are created. Subset one include all the groups and subgroups of the study except normal line, and the normal line is under the subset 2. And all the group and subgroups of subset was significantly different from normal saline group, as p-value for each subgroup and subgroup pairwise comparison was less than 0.05. Then post-hoc analysis was done for pairwise comparison on different days of incubation. It was shows that 10th-day incubation mean value was significantly different from third and second day of incubation, as p-value was less than 0.05. This is a line diagram showing a comparison of mean colony-forming units at different days of incubation. Then mixed analysis was again performed to find out a significant difference between the procedures for demineralized and non-demineralized sample, but it was observed that there was no significant difference. P-value was more than 0.05. This is a descriptive slide showing the BMP2 concentration, and it was observed that the subgroup A, that was chlorhexidine group, has maximum mean BMP2 concentration value. Then one-way ANOVA analysis was further performed to find out the significant difference between groups and subgroups, but this was non-significant as p-value was not less than 0.05. Then this is a descriptive slide showing BMP2 concentration in all the demineralized and non-demineralized groups and subgroups. And two-way ANOVA analysis was performed to find out the significant difference, as the value for the procedure less than 0.05, so it was showed that there was significant difference between BMP2 concentration between demineralized and non-demineralized samples. Part diagram showing the comparison of mean BMP2 presence in all groups and subgroups of demineralized and non-demineralized procedure. Then coming to the discussion, in brief, all groups and subgroups of sterilization protocol except normal saline demonstrate their efficacy in eliminating the microflora. Then gamma radiation has many benefits over other sterilization procedures. Mode of action include direct collisions of particles with nuclear protein, which is lethal to cells and bacteria. But previous studies concluded that gamma radiation is a viable option for sterilization for bone autograft, and the protocol for sterilization by autoclave was effective in the current investigation. However, previous studies reported 53.1% positive culture rate after sterilization with autoclave. So effectiveness of chlorhexidine solution can be attributed to its broad spectrum activity against oral pathogens. Povidone, iodine, and iodophore with the broad spectrum antibiotic property having a non-selective mode of action, and lactic acid is a safe bio-based biodegradable option for antimicrobial action. In the past, you should all use lactic acid clinically in the sterilization of autogenous tooth bone for alveolar ridge preservation procedure. Sodium hydroxide is a strong oxidization, but in a combination used with steam sterilization have a more dangerous effect on graft material. And after assessing the effectiveness of different sterilization protocol in terms of microbiological parameters, we looked at their efficacy in terms of BMP2 concentration, and the highest mean BMP2 concentration was 141.91 picogram per ml seen in auto TBC particles treated with 0.44% chlorhexidine. However, the BMP2 did not differ significantly in any group and subgroup sample of different sterilization protocol. Comparative analysis of demineralized and non-demineralized samples revealed that all sterilization protocol effective sterilize the graft irrespective of the status of demineralization except normal saline. However, in the context of mean BMP2, demineralization sample shows higher concentration as compared to non, and result was in accordance with the previous study, which stated that demineralization is believed to increase the release of growth factor from the tooth matrix by decreasing the mineral content. And the strength of our study is that it is evaluated simple just at chemical-based sterilization protocol with respect to standard sterilization protocol, that is gamma radiation and autoclave. These are the conclusions. Thank you.
Good evening. everybody.
Good morning,
Today I
sir.
would like to present a paper on evaluation of hematological parameters in healthy and in chronic periodontitis patients, a clinical and a hematological study.
Good morning, sir.
Good morning, Doctor. See, number one, when you are
Thank you, sir.
presenting a paper, you are giving a video presentation, your voice should be a little audible. I was not
Okay,
able
sir.
to hear most of your content. It was very slow as you also cross the time limits. So it has to be audible, otherwise judging becomes a little difficult. Right.
Okay, sir. Thank you, sir.
And second thing, so what according to you is the best material or the methods which have the ideal properties for the sterilization?
Sir, according to my study, the result was in favor of the chlorhexidine, that is 0.4% concentration used. In the parameter with respect to the microbiological, all the methods are effective. But in case if we measure the BMP2 concentration after sterilization method, then the chemical sterilization group had more BMP2 concentration as compared to gamma radiation and the autoclave groups.
See, when now
And
you are answering, your voice is audible. So I can
thank you,
judge
sir.
it now. But during the presentation, it was completely not audible.
Okay, sir.
Understood. Okay, fine. No more questions.
Thank you, sir.
Greetings to everyone present here. My paper topic of today is estimation of salivary tower protein on Alzheimer's patients with periodontitis. Periodontitis is a disruptive chronic inflammatory disease that causes destruction of the supportive structures of the teeth. It also serves as an entry portal for the bacterial endotoxins and the associated pro-inflammatory cytokines to enter the systemic circulation. It has been hypothesized that the periodontal pathogens may enter the brain via the peripheral nerve pathways. There is growing evidence of an association between periodontitis and neurodegenerative disorders such as Alzheimer's disease. The identification of oral treponema in the trigeminal ganglia supports the neural root. Lipopolysaccharides and the Phosphomonas gingivalis have been shown capable of crossing the blood-brain barrier in the AD brain samples. Tau proteins are proteins that stabilize the microtubules abundant in the neurons of the CNS. The tau proteins that have become defective and are no longer stabilizing the microtubules. Inflammatory cytokines produced by the periodontal tissues during the periodontitis can enter into the bloodstream and have been implicated both in periodontitis and in the neurological changes of AD. Periodontitis have been shown to be associated with Alzheimer's disease by the virtue of the keystone pathogen Phosphomonas gingivalis. The aim of the study was to estimate the levels of the salivary tau protein in a periodontitis patient with and without tauopathy to better understand the association between the clinical severity of periodontitis and the neurological disorders just in the Alzheimer's and the Parkinson's disease. The objectives were to evaluate the association of the periodontitis with cognitive impairment, to estimate the range of the salivary p-tau in healthy individuals, in patients with periodontitis, and in patients with Alzheimer's and Parkinson's disease, to assess the oral hygiene status in patients with degenerative disorders, especially in Alzheimer's and Parkinson's disease. Materials and method: about a total of 88 patients were selected for this cross-sectional study. They were segregated into three groups, such as the group A, B, and C. Group A were patients with neurodegeneration. Group B was age-matched periodontitis patients with without neurodegeneration. Group C is age-matched healthy controls. So inclusion criteria for group A is patients with neurodegenerative disorders and periodontitis, age above 60 years of age, patients having more than or equal to 20 permanent teeth, patients who did not undergo periodontal treatment for the past 6 months, patients who are not under any anti-inflammatory or the antibiotic therapy for the past 6 months. Group B is patient diagnosed with periodontitis, and the rest of the inclusion criteria from group A. Group C is patients who are systemically healthy without any relevant medical history, patients who did not undergo any periodontal treatment for the past 6 months, who are not under any anti-inflammatory or the antibiotic therapy for the past 6 months. Exclusion criteria for all the groups included the history of myxedema and or pernicious anemia, history of infectious diseases such as syphilis, history of tumors such as the frontal lobe meningiomas. Study protocol for group A, diagnosis of dementia was done, cognitive function assessment tests were done, and after giving an informed consent for patients in each group, clinical periodontal status is to be evaluated. Group B and group C, age-matched controls were selected with and without periodontitis. Diagnosis of periodontitis was done, medical history was elicited, and periodontal parameters such as the gingival inflammatory status, the pocket probing depth, and the mobility were done. Collection of saliva sample was done to assess the phosphorylated p-tau levels in the saliva of AD and BD. So clinical assessment, periodontal examination, examination of the examination of the gingiva was done, the periodontal screening was done, the mobility index was taken, and cognitive assessment, MOCA or MMSE was done. Salivary collection, 1 ml of whole unstimulated saliva was collected while the patients were sitting in this relaxing position by spitting into the uricol containers. Saliva samples were then transferred to the laboratory inside a chamber containing ice and were kept at a freezing temperature of -80°C until further analysis to be done. Laboratory analysis, salivary p-tau levels were assessed using enzyme-linked immunosorbent assay. Statistical analysis, salivary p-tau levels were assessed by Kruskal-Wallis test. The statistical analysis was done using SPSS software version 2.2. So these are the results. These are the bar charts showing the frequency distribution of the history of periodontitis and the stages of periodontitis. Statistical significance of the history of periodontitis and the stages of periodontitis showed that there was no significant difference between the protein content when compared to them. And the statistical significance of the grade of periodontitis showed that there was significant difference when compared to the protein content, whereas amnesia showed that there was no significant difference when compared to the protein content. Statistical significance of the tremor showed that there was significant difference when compared to the protein content. Apart from these, the statistical significance with other variables such as the age and PPD showed that there was no significant difference, whereas in bleeding on probing showed that there was significant difference, and quantification showed that there was no significant difference when compared to the protein content. Discussion, AD is characterized by neuronal loss and the presence of senile plaques which contain the A, beta and hypophosphorylated tau protein. An alteration in the ANS as seen in the AD can affect the salivary production and the composition. These intervals having the highest association with the severity of the periodontal disease, the lipopolysaccharide produced by this crosses the blood-brain barrier and it plays a role in the Alzheimer's disease. It is possible that long-term inflammatory burden can cause neuronal degeneration. Biomarkers such as the p-tau and the A-beta-42 can be obtained from the CSF only through invasive techniques. An inexpensive non-invasive technique which detects the biomarkers with sensitivity and reliability would be ideal. Evidence suggests that biomarkers such as lactoferrin, alpha-synuclein, and p-tau were expressed in the saliva. As a result, the saliva sample could be a valid alternative to CSF or blood. Inflammatory cytokines such as the IL-1, interleukin-6, and the TNF-alpha, as well as acute phase proteins, including the CRP, produced by the periodontal tissues during the periodontitis can enter into the bloodstream and have been implicated both in periodontitis as well as neurological changes of AD. From all of the above findings, the statistical significant association between the clinical parameters such as the PPD, the BOP, and the rate of progression of periodontitis and the salivary p-tau levels signify that active periodontal infection promotes increase in systemic inflammatory burden, ultimately causing an increase in the p-tau concentration. Conclusion, this study was aimed to explore the relationship between the periodontitis and tauopathy. The current study was done to estimate the salivary p-tau levels using the ELISA and to assess its correlation with the periodontal clinical parameters in patients with and without neurodegenerative disorders. Based on the clinical findings and the biochemical findings, it can be concluded that periodontitis is a possible risk factor for developing tauopathies like Alzheimer's disease or atypical Parkinson's disease. Thank you.
Morning, sir. Sir, I think you're on mute, sir.
Is it audible now?
Yes, sir.
Yes, sir.
I can hear
See,
you.
Dr. Sneha,
Yes, sir.
see, you have a certain protocols when you present a paper. Why you are so fast with you reading out your slides? You are just running and running with the slides. You cannot be very fast. There has to be some objective for the presentation. You just need to hear up what you are saying. It is not for only
Yes, sir.
and protocols.
I'm not
So
able to get
any treatments? What treatment
No, sir,
was given to the patients?
Sir, it was just to analyze if the periodontitis was also a risk factor for the patients with neurodegenerative diseases, sir. There wasn't exactly
That I understood. Any clinical treatment was given.
No, sir. Other than the normal phase 1 therapy, nothing else was given, sir.
Nothing has been done. So what did you concluded? Is it a potential risk factor?
Yes, based on the clinical findings as well as the biochemical findings, we found that periodontitis is a risk factor for neurodegenerative diseases, sir. Alzheimer's
So
as well as
till
Parkinson's.
how long did you went for a follow-up? Was there any follow-up with these studies?
No, sir, it was just a 6 months follow-up, sir. But
6 months
during
follow-up
COVID time, we couldn't follow up with exactly all the patients, sir.
so it was only based on your lab and statistics.
It was just a statistics, sir. We couldn't follow up with the patients because of the pandemic, sir.
Okay, fine. That's all.
Okay, thank you.
Topic for paper presentation is evaluation of maxillary anterior buccal bone dimensions and sagittal root positions using
Can you be a
CBCT
little loud?
observation study, which comes under basic research. Coming to the introduction, with the introduction of computed tomography for diagnosis in implant therapy, the three-dimensional visualization of the bone is now possible. Cone beam computed tomography has significantly widened the use of CT images in implant dentistry due to visualization, particularly in buccolingual direction, and reduced radiation doses, which previously was not possible with conventional radiographic techniques. CBCT provides a highly accurate method to evaluate the bone architecture. There is lack of data in the Indian population regarding maxillary and mandibular anterior bone morphology and tooth positions for the placement of immediate implants. So this study provides the information a clinician requires in placing implants in the correct angulation and maintaining the adequate peri-implant bone for long-term success. This virtual implant position can be replicated in the form of static and dynamic guides for the implant placement. Thus, the current study targets to evaluate the dimensions of maxillary and mandibular buccal bone dimension and respective anterior sagittal root position, and thereby placing virtual implant to calculate the perforations occurring as a result of above parameter study in the CBCT images. Aim of this study is to determine the maxillary buccal bone concavity angle, tooth ridge angulation, and dimensions of facial alveolar bone in respective of anterior root position in the cone beam computed tomography images. Objectives are to evaluate the dimensions of facial alveolar bone of the anterior teeth in maxillary arch, to find the prevalence of different SRP in maxillary arch, to evaluate the tooth ridge angulation of maxillary anterior teeth with respect to alveolar bone, to determine the concavity angle of maxillary anterior teeth, to find out the correlation between sagittal root position and buccal bone dimensions, sagittal root position and tooth ridge angulation. Material and method study design. This study is the CBCT based retrospective observational study. Sample size, total sample size of 140 based on the power analysis were evaluated for this study. Sample selection: patients who visited the Department of Odontology were selected for the study since 2012 till June 2018. Inclusion criteria were images showing permanent central incisor, lateral incisor canine, which were fully erupted. Exclusion criteria were orthognathic surgically treated cases, grafted alveolar ridge in the region of interest, patients with supernumerary or infected teeth in the region of interest, history of periodontal disease or traumatic injury at the region of interest, presence of artifacts or faulty CBCT images, presence of pathological lesions or evidence of root resorption in region of interest. Results from the scans of 1,680 teeth available for the study, 1,330 teeth were qualified for further analysis. There were 81 males in the age range of 19 to 84 years and 57 females in the age range of 21 to 24 years. Total number of maxillary central incisors were 218. maxillary lateral incisors were 213 and the maxillary canine were 216. Average buccal bone dimensions were assessed. Horizontal buccal bone thickness, which was measured at the 3 points, showed increase in the width as one approached from coronal to the apical direction for the maxillary anterior teeth. Vertical buccal bone dimensions, as denoted by a distance between cemento-enamel junction and alveolar bone crest, increased progressively from anterior to posterior in maxillary arch. There was no statistically significant difference seen in the buccal bone measurements between the right and left side of the maxillary arch. Sagittal root position was calculated. The class 1 was most prevalent, followed by class 4 and the class 2, and least prevalent was class 3. In class 1 SRP, for maxillary arch, the canine teeth were most common compared with the central and lateral incisor. SRP did not show statistically significant difference between right and left side in the maxillary arch. Tooth-ridge angulation was calculated for all the teeth for maxillary teeth. The comparison between right and left teeth showed no statistical significant difference. Uh, Maxillary concavity angle was measured for maxillary teeth. The comparison between right and left side showed no statistical significant difference. Maxillary concavity angle was similar in incisors and canines. MCA was highest for right canine, followed by left canine and incisors, and least for the right incisors. Uh, in the table, the buccal bone dimensions, the horizontal measurements, the buccal thickness of buccal bone dimensions was increased from the coronal to the apical direction. The comparison of buccal bone dimensions, tooth-ridge angulation, and maxillary concavity angle of the right and left side of the maxillary arch. In the buccal bone dimensions, the there is the statistically significant difference seen in the horizontal bone thickness, and there was no statistic significant difference in the vertical bone thickness. In the tooth-ridge angulation, there was no statistic significant difference were seen, and in the maxillary concavity angle, also not statistical significant difference seen. In the tooth-ridge angulation, in our study showing the angulation becomes more negative, that is more palatal inclination as one proceeded posteriorly. In maxillary concavity angle, our study showed a higher compared to the other studies. In sagittal root position, the canine showed the common class 1 SRP than the central and lateral incisor. Coming to the discussion, the preservation of buccal bone dimensions is critical when planning the immediate implant placement in the anterior teeth, as reduced bone thickness leads to bone resorption, leading to bony dehiscence and soft tissue recession. Hence, the average buccal bone dimension in the present maxillary anterior region of the jaw was first parameter assessed in this study. Uh, Study done by Roman Funtis in the 2015 reported that the 10% of sites showed an ideal conditions of thickness more than 2 millimeter buccal bone wall, with exception of central incisor region wherein 14.4% cases had thickness of greater than 2 millimeter. Previous study have considered the average buccal bone thickness in the anterior teeth. In our study, the dimensions of buccal bone were measured at the 3 level, coronal, medial, and apical 3rd level. Then the SRP was measured according to the classification given by Khan in 2011. They classified relationship of
So you could not finish within the limitation of your time. What was your conclusion?
My conclusion is that the results
Be a little louder. Be a little louder.
My conclusion is that results of this study ensure the tools for the to help the future implant placement with after virtual implant placement, and also to prevent the implant failures or the perforations during surgery.
So we all know that CT is the best mode of radiographic to analyze the images. So if there is any absence of CT, can this be substituted by any other modalities or any other radiographic methods? If for any reason, if CT is not being done, so any other radiographic methods to assess the bone quality in the anterior region?
OPG.
OPG, is that suffice? Any other thing you know, especially in terms of placing an implant in the anterior region? Have you not heard of RVGs?
Yes, RVG.
Have you heard of RVGs?
Yes.
So RVGs can be also help as a potential tool.
Yes, it can. Yes.
Pre and during and even the post-implant implant evaluation.
Yes, sir.
Okay, fine. Okay.
Good morning. Topic for paper presentation is evaluation of pre-operative anxiety and post-operative quality of life in patients with ultrasonic scaling, a cross-sectional study. Introduction. Dental pain and anxiety are important barriers that prevent patients from seeking oral health-related quality of life. Despite improvement in preventive dentistry and advances in treatment techniques, dental anxiety shows a stable trend over the years. Controlling the levels of fear and anxiety has been a great challenge for the dentist and other dental care professionals. It is also seen that it impacts the daily life and quality of dental procedure. A practitioner must assess levels of patient's anxiety in order to provide quality treatment. The effectiveness of periodontal therapy was established by many longitudinal studies assessing the effect of anxiety on patients' pain during and after surgery. Aim of the study was to evaluate pre-operative anxiety and post-operative quality of life in patients with ultrasonic scaling. Objectives of the study was to evaluate levels of anxiety prior to ultrasonic scaling procedure and to assess the post-operative quality of life after ultrasonic scaling and to find whether there was association between anxiety, gender, socioeconomic status, occupation, income, and well-being. Coming to materials and methods, a cross-sectional survey was conducted among the outpatients of Department of Periodontology, Narayana Dental College and Hospital, Nellore. Sample size of 100 were considered and an informed consent was given to the patients of both genders, of all race, socioeconomic status were included. Self-administered closed-ended questionnaire was given at baseline before their scheduled treatment, which included modified dental anxiety scale. After procedure, sensitivity and pain was evaluated using visual analog scale. A follow-up survey was done after 15 days from baseline to assess post-operative quality of life, which includes clinical evaluation and oral function evaluation. Inclusion and exclusion criteria. Inclusion criteria includes patients of age 18 to 65 years, systemically healthy patients, and patients with gingivitis and periodontitis. Exclusion criteria excluded pregnant and lactating women and patients who provided no consent form and were non-cooperative were excluded. Coming to the results, Figure 1 illustrates demographic distribution. A total of 100 participants were selected, among them 55 were females and 45 were males. Table 1 illustrates socio-economic data and results of modified dental anxiety scale. Total number of patients who were anxious were 88 and total number of patients who were not anxious were 12. There was statistically significant association between levels of anxiety and age, education, and income, whereas there was insignificant association between levels of anxiety, gender, and occupation. Figure 2 illustrates discomfort felt during scaling. 55 participants noticed bleeding during scaling and 45 participants noticed no discomfort during scaling. Discomfort due to water spray was observed by 75 participants and discomfort due to water spray was not present among 28 participants. Figure 3 illustrates mean values of pain and sensitivity among males and females. Mean values of pain and sensitivity were higher in females when compared to males. Figure 4 illustrates post-operative quality of life among study participants, and this assessment includes clinical evaluation. All the participants felt that their teeth were cleaned, and spacing between the teeth were observed among 11 participants, and absence of spacing was observed by 89 participants. Decrease in bleeding were observed among 94 participants, and decrease in malodor were observed by 91 participants. Figure 5 illustrates post-operative quality of life among study participants. Assessment also includes oral function evaluation, which was done 15 days from baseline, and it includes 4 parameters such as chewing, speaking, sleeping, and walking. All the 4 parameters have improved scores. Coming to the discussion, dental anxiety is a fear or response due to some real facts or by the lack of dental health education, which in turn might end with poor patient compliance and attitudes. In current study, the results suggest that there is statistically significant association of anxiety with the age, level of education, and monthly income, and had insignificant association with gender, socioeconomic status, and occupation. The study conducted by the Filippo et al. Also concluded that dental anxiety can occur irrespective of gender, and there is insignificant association between anxiety and gender. In her study, it is also seen that younger patients between 18 to 26 showed greater anxiety among all age groups, which supports the findings of Hilton J. et al. The assessment of clinical and oral function evaluation provided the participants with the possibility to report the positive effects of oral health and not only the absence of problems. Improved oral health preceded in increased confidence and comfort, specifically when compared to a previous status of periodontal disease. Conclusion. In conclusion, the level of anxiety is low among the outpatients of Department of Periodontology, and the participants had improved post-operative quality of life. Adequate awareness of dental procedures and dental health promotion through social media, print media, and oral health related campaigns may reduce the anxiety and improve oral health related quality of life. Limitations of the study were small sample size, and outpatients of Department of Periodontology were only included, and patients who were cooperative were only included. Thank you.
What were the measures taken to reduce the anxiety pre-treatment scaling?
So actually, we have not taken the measures, sir. Just taken the anxiety scores, modified dental anxiety scores.
Be a little louder, doctor. Be a little louder.
Yes, sir. We have just taken modified dental anxiety scores, sir. We have not taken the measures to reduce. I have just seen preoperative anxieties.
And what about post-treatment?
Yes, post-treatment, like after scaling, just we have taken based on questionnaire, post-operative quality of life was assessed.
Your voice is not very clear. It's breaking. Please be a little clear.
Yes, sir. Yes, are you clear, sir? Is it clear, sir, now?
Yeah.
Yes, sir. Yes, sir. We have gone through a questionnaire, sir, closed a questionnaire where we have taken post-operative quality of life, sir.
Okay. So how do you differentiate between the socioeconomic status, income, and gender, post-operative, post-scaling rather? Hello?
Hello?
Yeah, is it audible to you?
it's audible, sir.
Yeah. So how do you assess to reduce the post-treatment anxiety in terms of the classification of socio-economical status, gender, income?
Yes, so by creating an awareness and motivation, we can demonstrate like a burden of periodontal disease on well-being of population can be reduced by advocating the resources and to improve the access to oral health and services, like more of motivation and awareness and patient experience, patient-related outcome has been received, so that they are satisfied with the treatment which have been done and had improved quality of life after scaling. So with this, we can give awareness and reduce anxiety. And those patients were anxious, had good post-operative quality of life.
Okay, fine. Done.
Thank you.
Greetings to all. My paper is on antibiotic resistance and its associated plasmids of the oral microbiome in periodontitis. Coming to the introduction, periodontitis is characterized by microbially associated host-mediated inflammation that results in the loss of periodontal attachment. This microbial etiology of the periodontal disease provides the rationale for the use of antibiotics on periodontal therapy. Though the adjunctive use of local and systemic antibiotics is considered to be effective in periodontal management, inappropriate antibiotic use is a contributing factor to the development of the antibiotic resistance, which is a major concern of developing countries today. Antibiotic resistance can result due to the use of antibiotics with no clinical indication, use of broad-spectrum antibiotics when not indicated, and inappropriate choice of empiric antibiotics and inappropriate drug use, route and drug regimen. The widespread use of antibiotics for prophylaxis and the treatment of periodontitis has led to the emergence of the antibiotic resistance. The bacterial plasmids serve as scaffolds on which are assembled arrays of antibiotic-resistant genes by transposition and site-specific recombination mechanisms. In terms of antibiotic resistance, plasmids play a central role as vehicles for resistant gene capture and their subsequent dissemination. Plasmid curing is the elimination of a plasmid from a cell culture by treatment with certain compounds at a concentration insufficient to inhibit the chromosomal replication but sufficient to inhibit the plasmid replication. Coming to the aim, to identify the antibiotic resistance of the oral microbiome and its associated plasmids and to correlate any association of the resistant organisms with the clinical severity of periodontitis. Objectives: to isolate and identify the periodontal pathogens from saliva and subgental plaque of periodontitis patients using 16S rRNA gene. To investigate the antimicrobial susceptibility profile in bacteria isolated from periodontitis. To isolate the plasmids from the periodontal pathogens. To evaluate the plasmid profile and identify the resistant genes in plasmid. To evaluate the current curing status of the plasmids in periodontal pathogens. Materials and methods. 40 patients were selected from the Department of Periodontics and Oral Implantology, Sri Balaji Dental College and Hospital, Palikarnai, Chennai. The inclusion criteria. It includes the people who have generalized periodontitis, aged between 30 to 60 years, with more than 20 scorable permanent teeth. The exclusion criteria includes pregnant and lactating mothers, any antibiotic or steroid therapy for the past 6 weeks, and the periodontal treatment for the past 6 months. Study protocol. Medical history and informed consent were obtained. Clinical periodontal status such as the probing pocket depth and the clinical attachment level were evaluated. And the clinical parameters such as the oral hygiene index, mobility, clinical enlargement, gingival recession and furcation were assessed. Subgental plaque and unstimulated saliva were collected from the patients and stored at -20°C until analysis is done. Laboratory analysis is done. The statistical analysis was done by students' t-test and the chi-square test using the SPSS software version 20. Coming to the laboratory analysis, it started with the preparation of the herbal extract, that is Anacyclus pyrethrum. The identification of the microorganisms in saliva and subgental plaque was done. The molecular identification done by genomic DNA isolation, identification and separation of DNA in 1% agarose gel, amplification of 16S rDNA gene, and the antimicrobial susceptibility test done by Baer and Kirby method. And the transformation assay is done to ensure the susceptibility of the bacteria. The plasmid isolation done by manual and the kit methods, and the curing is done with the 4 materials such as the acridine orange, promethazine, and elevated temperature, and the herbal extract, that is the Anacyclus pyrethrum. Coming to the results. This is the distribution of periodontitis among the patients who are taken as subjects and the staging and the grading of these patients. Comparison of staging across the patients across the different organisms. As you can see, there is a marked significance of Neisseria perflora in block and Streptococcus species in block when compared among the staging, and comparison of grading across the patients across the different organisms. As you can see, there is a significance in Neisseria perflora in block when compared with the grading. These are the organisms which are isolated, which includes the four organisms, namely the Klebsiella pneumoniae, Neisseria perflora, Ralstonia picketi, and the Streptococcus species. This is the resistant percentage for these four organisms among the antibiotics which are commonly used in periodontics, such as amoxicillin, ampicillin, clindamycin, metronidazole, tetracycline, and the herbal extract. This is the minimum inhibitory concentration of these organisms against these antibiotics. The plastic curing of Klebsiella pneumoniae, it actually states that acridine orange is the most effective curing agent against Klebsiella pneumoniae, and the plasmid curing of Streptococcus species implies that Anacyclus pyrethrum is the most efficient curing agent for these species. And the plasmid curing of Ralstonia picketi states that promethazine is the most efficient curing agent for Ralstonia picketi. Coming to the discussion. Neisseria perflora, Klebsiella pneumoniae, Ralstonia picketi, and Streptococcus species were isolated from both saliva and subgingival blood. No significance was observed between age, gender, probing pocket depth, and the presence of organism. More than 41% of Klebsiella pneumoniae isolates was found to have more resistance to ampicillin, whereas only about 21% have resistance to metronidazole. The Neisseria perflora showed more than 78% of resistance to tetracycline, and the Ralstonia picketi have 73% to clindamycin. And Streptococcus species does not exhibit any resistance to clindamycin, and the elevated temperature being the most least efficient curing agent, and Anacyclus pyrethrum has a greater curing efficiency against all the three organisms. Coming to the conclusion, Neisseria perflora, Klebsiella pneumoniae, Ralstonia picketi, and Streptococcus species were isolated from both saliva and subgingival blood. They are associated with the antibiotic resistance exhibited to the antibiotics commonly used in periodontal practice. As plasmids play a key role in the spread of antimicrobial resistance, plasmid curing seems to be a promising mechanism to prevent antimicrobial resistance. Anacyclus pyrethrum was the most efficient curing agent, and elevated temperature was found to be the least effective. Though plasmid curing seems as a promising mechanism to prevent antimicrobial resistance, there is lack of in vivo studies on curing mechanisms of various agents, and hence many studies in future are needed to prove the efficiency of the plasmid curing in order to prevent the antibiotic resistance. Thank you. Good morning, sir.
Hello.
Good morning, sir.
Good morning. So, what do you feel? That all antibiotics should be given as a prophylaxis?
Sir, it can be given, sir, but since we made a big...
Be a little louder. Dr. Angela, be a little louder.
Sir, since we made a greatest mistake of providing a broad spectrum antibiotics in the past, it has been a problem worldwide, sir. So, in order to solve that, we have to give antibiotics for the treatment, sir, because it is useful as an adjunctive for periodontal treatment, sir. But the thing is, we have to solve the problem by how to solve this resistant things, and also, so we can try this curing process, sir.
What is the basic rationale for prescribing an antibiotics?
Sir, actually, the mechanical debridement is quite effective for the elimination of bacterium which are virulent for us, sir. But when we use antibiotics along with them for as an adjunct, it is the most effective than using the mechanical debridement process alone, sir.
So how it goes in the cases of a local drug delivery?
It is actually quite effective, sir. It has been found that the 20 milligram of doxycycline, when used as an adjunct, is quite effective when in comparison of giving with the broad spectrum antibiotics. And it has been proved that many antibiotics such as tetracyclines can also be used as an adjunct, and it is effective along with root planing, sir.
Okay, fine, done.
Thank you, sir.
Good morning to all. My paper is on correlation of periodontal inflammatory burden index and serum TNF alpha and interleukin 6 levels in acute coronary syndrome to severity of periodontal diseases. Introduction. Periodontitis is a chronic inflammatory disease with primary bacterial etiology resulting in inflammatory process that led to the destruction of supporting structures of the teeth. The degree of chronic periodontal destruction is determined by individual inflammatory response of the patient. Periodontal bacteria may stimulate chronic inflammatory cells of the gingiva and fibroblast to produce cytokine, including interleukins and TNF alpha, to which stimulate osteoclastic bone resorption. There is an increasing evidence that periodontal disease is associated with increased risk of cardiovascular disease with many potential pathogenic mechanisms in common. The destabilization of pre-existing atherosclerotic plaque leads to formation of clot, which leads to acute coronary syndrome. The dental plaque may also play a role in destabilization of the atherosclerotic plaque. Thus, the classic coronary risk factors may interact with the systemic and periodontal infection to increase the risk of acute coronary syndrome. Coming to aim and objective of this paper is to assess the serum level of interleukin 6 TNF alpha in patients with acute coronary syndrome with mild, moderate, and severe periodontitis to explore if the severity of periodontitis could be a risk indicator for developing ACS and to assess any correlation with PIBI. Coming to materials and method, 120 individuals are selected for the study, in which 71 individuals with ACS and no periodontitis and ACS with periodontitis and in 49 individuals are control group, they were periodontitis without acute coronary syndrome. In coming to inclusion and exclusion criteria, the test group include age of 30 to 70 years of patient, and both male and females were included, and patients with the method generalized periodontitis and smoker and systemic disease like diabetes were included in the study. Methodology. The initial diagnosis of ACS is confirmed with electrocardiogram, ST elevated myocardial infection, and now ST elevated myocardial infection, and with a little level of specific cardiac markers such as troponin and maximally marked creatine kinase and maximally marked creatine kinase NB function. Coming to periodontal examination, clinical periodontal status were recorded using probing pocket depth, clinical attachment level, tooth humidity, and level of occasion. Each patient are categorized as a mild, moderate, and severe based on CDC AAP case definition for population-based surveillance of periodontitis. Periodontal inflammatory burden index was derived from PD values to find the correlation between the periodontal and inflammatory burden index. Periodontal inflammatory burden index was calculated by adding number of periodontal sites with moderate periodontitis to the weighted level of periodontal sites with advanced periodontitis. Into collection of serum, 5 ml of venous blood was withdrawn into a sterile wet container. The collected blood is then centrifuged at a speed of 3000 rpm for 20 minutes to obtain the serum. It was then stored at -80 degrees Celsius until further analysis of interleukin 6 and TNF alpha. The analysis of serum cytokine levels were determined using the sandwich kit of ELISA. Interleukin 6 and TNF alpha were measured using human ultrasensitive cytokine antibody indicator. Coming to a result, the interleukin 6 and TNF alpha was biochemically evaluated, and they show a higher level of significance in the result of interleukin 6 shows statistically significant in patients with ACS and mild periodontitis and severe periodontitis, and the result of TNF alpha shows statistically significant in patients with ACS, mild and severe periodontitis, and non-ACS patient with a moderate periodontitis. Periodontal inflammatory bleeding index were used to study the severity of periodontitis. They show statistically significant in different groups and within groups. The other systemic status such as HbA1c, BMI, and smoking status were also measured. They did not show any statistical significance in this study. The most of the ACS patient had a history of smoking, which may lead to progression of the coronary diseases. Coming to discussion, cardiovascular disease ranked among leading cause of death, and it has both clinical and epidemiological importance. Inflammation plays an important role in atheroma formation to plaque rupture as in ACS, and there is increase in level of pro-inflammatory cytokine similar to the periodontal disease. Periodontal disease may induce the systemic inflammatory response, resulting in elevated serum levels of inflammatory markers such as interleukins and TNF alpha and C-reactive protein that contribute the plaque instability and atherosclerotic events. Interleukin 6 is evaluated in the study. Our study shows higher level of non-ACS periodontitis patient, higher level of interleukin 6 in non-ACS periodontitis patient, and than the patients with the ACS periodontitis patient. Patient with ACS has a higher level of cholesterol and were under statin drug, which could have brought about the differences in interleukin 6 levels. TNF alpha was another cytokine that we investigated in the study. TNF alpha is increased in ACS patient with periodontitis and compared to the patient without periodontitis. Both the test group exhibited higher level of TNF alpha with moderate form of periodontitis. In our study, periodontal inflammatory burden index were used to find the severity of periodontitis. It was found to be highly significant in different groups and also different groups. The severity of periodontitis increases, the periodontal inflammatory burden index value also increased with the highest value in the severe form. WBC shows statistically significance between two groups, but did not show any significance in patients with ACS and periodontitis within the groups of severity. Various other confounders like diabetes, smoking status, hemoglobin levels were also take account in the study. It has shown to be factors for disease progression in both acute coronary syndrome and periodontitis. Coming to conclusion, this reveals that the chronic periodontitis, even in the absence of coronary disease, can be the risk factor for future morbid events of atherosclerosis like ACS. Added to this, the older group above 55 years have with the increase in WBC count and PIBA were found to be hindered, and at a moderate group of chronic periodontitis had a higher risk of developing acute coronary syndrome as measured by increased level of cytokines.
Hello.
Good morning, sir.
Good morning. So, how is periodontitis prevalently a risk factor for ACS?
Sir, in periodontitis patient, it may lead to bacteria which cause increased inflammatory mediators like interleukin 6 and TNF alpha, which may cause platelet aggregation. And the platelet aggregates recreate leukocytes and bind them to form mast cells, which may cause thrombosis and the vulnerable plaque formation. Which cause atherosclerosis
continue.
Which cause atherosclerosis and forms acute coronary syndrome. Maybe a risk factor.
So, any treatment was given to all these patients in the department?
No, sir, we didn't provide any treatment.
Not even the SRPs?
No, sir, we treated the patient further, sir, but not included in the study series.
So, what is the prevention for this?
Sir, we do generalized debridement. For the patient who needs surgery, we do surgeries, and for mild patients, we do only debridement.
Any preventive measures to be taken so that it could not develop to a severe form of ACS?
No, sir, we just do the periodontal treatment.
So, how does it improve the overall health status? Does the periodontal treatment given overall improve the health status of ACS patients?
Sir, it should improve, sir. Further, we refer to the physician for the further management.
Okay, fine. Okay.
Good morning, everyone. Myself, Dr. Anushree Gupta, going to present my topic titled Perception Regarding Gummy Smell and its Correction by Lip Repositioning Technique among Dental Professionals.
To begin with, what is a gummy smile? A gummy smile is what happens when a person smiles and his upper muscles act too much and pulls the upper lip too much. So along with the teeth, you see gums as well on the top of the teeth. This is known as gummy smile, and this can be a great source of embarrassment. Aesthetically pleasing smile is influenced by three factors, that is arrangement and proportion of lips, teeth, and gums. Excessive gingival display or gummy smile has been described as visibility of excessive amount of gingiva during smiling. The ideal gingival display ranges between 0 to 3 mm, while it is obvious that an abundance of 3 mm or above of the gingival showcase on smiling is considered as unaesthetic. There is a correlation between gender and the type of smile, with predominance of gummy smiles in females, that is 2:1, and low lip lines in males, that is 2.5:1. The major etiological factors for gummy smile includes short upper lip, hyperactive upper lip, altered passive eruption, where the excessive gingiva covers the teeth, or skeletal conditions such as vertical maxillary excess. Many techniques have been used for the management of gummy smile, such as crown lengthening procedures, maxillary teeth intrusion, lip repositioning, orthognathic surgery, and non-surgical procedures like the use of botulinum toxin. Lip repositioning procedure was first described in 1973 by Rubinstein and Kosciuszko-Wasky as a part of medical plastic surgery, which was introduced in dentistry after being modified in 2006 by Rosenberg and Salmon. The surgery aims to limit the smile muscle pull, that is zygomaticus minor, levator anguli oris, orbicularis oris, and levator labiae superioris by reducing the depth of the upper vestibule. This study is first of its kind, conducted among young dental professionals to determine the need for a better treatment protocol for the improvement of aesthetic smile in the near future. The various aims and objectives behind this survey is to assess the perception of dental interns and postgraduates about gummy smile, knowledge about its association and etiology, concepts about its treatment, awareness about its various treatment modalities, especially in contrast to lip repositioning technique. The type of study is questionnaire study, and the source of my data are dental interns and postgraduate students from the two dental colleges of People's University, that is People's College of Dental Science and People's Dental Academy. A total number of 200 subjects were recruited, out of which 100 were dental interns and 100 were dental postgraduate students. The questionnaire form used consists of 10 questions, which were divided under headings such as knowledge about gummy smile, knowledge about its association and etiology, concepts about its treatment, awareness about its various treatment available, especially in contrast to lip repositioning technique. Statistical analysis data were described using frequency counts and percentage, and comparisons were made using the chi-square analysis for different independent samples. There was a positive outlook about gummy smiles and their correlation using lip repositioning technique. Out of 10 questions, for most of the questions, responses were statistically insignificant, except for question number 4, 9, and 10. For question number 4, when asked whether short and hyperactive lip was considered as an etiology for gummy smile, 83% of postgraduates considered it as a cause, whereas only 69% interns considered it as a cause for gummy smile. This data was statistically significant, shown in the table. When asked about possible etiology to go for lip repositioning surgery in question number 9, 84% of interns opted vertical maxillary excess, whereas 63% postgraduates opted this as a reason. Similarly, delayed or passive eruption was also considered by 65% of interns and 83% of postgraduates as an etiology. Anterior dentoalveolar extrusion was significantly higher considered cause by postgraduates, that is 70%, as compared to interns, that is 55%. About question number 10, lip repositioning was considered as more preferred technique for gummy smile technique treatment by postgraduates, that is 71%, as compared to interns, that is 53%. But almost twice the number of interns, that is 47%, preferred orthognathic surgery in comparison to postgraduates, that is 29%. This difference was again statistically significant. Response to basic concepts about aesthetic and gummy smile had no significant difference among interns and postgraduates, showing no matter what should be the experience or knowledge, concern for an alluring smile is same for everyone. There is slightly higher awareness among postgraduates about various etiological factors responsible for gummy smile, with a significant difference regarding short and hyperactive lip. As the underlying cause for gummy smile can be many at the time, one can go for multiple treatment protocols for its resolution. If the reason behind gummy smile is due to vertical maxillary excess, it can be treated by orthognathic surgery to minimize gingival display and to restore normal interjaw relationship. The most popular and well-documented procedure is the crown lengthening procedure in which gingival margins are shifted apically through soft and possibly hard tissue dissection. 81% of interns and 88% of postgraduates are well aware of this dental procedure. A newer emerging technique which is gaining popularity in this field is the lip repositioning technique. If the short and hyperactive maxillary lip is the cause for excessive gingival display, this surgery followed by orthodontic treatment can be a good alternative to orthognathic surgery. By lip repositioning technique, one can achieve reduction up to 3.4 mm, ranging between 3 to 8 mm. In the surgical procedure, the area to be operated is demarcated with the help of an indelible pencil. Incision is made and both superior and the inferior partial thickness flap is raised from maxillary right first molar to maxillary left first molar. Epithelium is then removed, exposing the underlying connective tissue. The parallel incision lines are approximated with the help of interrupted stabilization sutures at the midline. Then a continuous interlocking suture is used to approximate both the flaps. Patient is recalled after 1 week for the follow-up. 74% of postgraduates are familiar with this surgical procedure. As far as awareness of the interns are concerned, they are less familiar with this technique, and their knowledge about the etiological factors treated by lip repositioning techniques is statistically significant. Normally, when a patient walks into the dental clinic with the desire of getting a perfect smile, he or she thinks of less invasive procedure with quick and good results. Once the clinician explains the procedure of orthognathic surgery, they usually hesitate to go for such aggressive procedure. So when the gingival display is mild to moderate with not of much skeletal deformity, one can manage the issue by performing lip repositioning surgery with good knowledge and expert skill. 71% of postgraduates opted lip repositioning over orthognathic surgery as correction for the gummy smile. Nowadays, people are becoming more and more aware of dental treatment procedures. Being dental professionals, it is our duty to provide our patient their lost confidence and satisfaction by performing our job in the best way possible. Through this survey, we came to conclusion that the awareness about the diagnosis and the underlying etiology for gummy smile are managed by lip repositioning surgery is slightly higher among postgraduates, but the dental interns are also not completely unaware of the drawbacks of the gummy smile and its resolution by varying methods available. With the further more learning, understanding, and experience, one can be able to provide major contribution to the cosmetic dentistry in the near future. These are my references.
Good morning, sir.
Good morning. So did you provide any treatment for this gummy smile?
No, sir, it is a questionnaire study. So I have just gone through, explored
what did you achieve?
Sir, the result was that both the postgraduate students and the interns were knowing about the gummy smile, but the awareness was slightly higher among the postgraduate students about the etiological factors which are responsible for gummy smile, that is short and hyperactive, and interns were slightly.
Just a minute. So why do you think that the awareness is a little higher with the postgraduate students as compared to the interns?
Sir, because there was a question in the questionnaire about the etiological factors. What are the etiological factors responsible for gummy smile? So they have opted those answers more. Postgraduates, at interns were less.
So apart from the aesthetic concern, is there any related to the pathological reasons for that?
Pathological. So some of the syndromes are there which are responsible for excessive gingival display. For where the maxillary bone, there is vertical maxillary excess in some of the cases.
So the patient will only go for the aesthetic reasons for the treatment of gummy smile.
Yes, sir. For most of the cases. So for most of the cases.
You don't think any pathological concerns are needed?
So sometimes there is open mouth breathing due to incompetent lip where gingiva is displayed more. For in that case also.
So what, according to you, the best treatment modality or in options?
So for the correction of gummy smile, it mainly depends upon the etiological causes. If the cause, causes.
Okay, fine. Hello. Huh? Okay.
Greetings to all. My paper presentation is on evaluation of salivary proteomics and saliva-based proteins in detection of autism spectrum disorder, a systematic review. The authors are Anchal Uri, Dr. Nandini Bhaskar, Dr. Rose Kavaljeet Kaur, Dr. Ashish Jain. Introduction. Autistic spectrum disorders are characterized by neurodevelopmental impairment resulting in altered social, emotional, and communicative skills along with stereotyped motor and mental health. The onset is typically between 3 years from birth. Autism affects nearly 0.6% of the population. Recent times observed a surge in the cases of autism spectrum disorders, but due to complications in understanding its etiology and involvement of multiple factors, still appropriate methods to study its biological causes remain understudied. Even diagnosis of autism spectrum disorder is mainly by clinical symptoms, as vast genetic polymorphisms in autism spectrum disorders make it impractical to perform genetic testing. As early detection of autism spectrum disorders is important, the research in arena of easily accessible biomarkers is of prime concern that could help in monitoring the disorder. In recent years, cataloging of salivary proteins and protein profiles have been made possible by salivary proteomic techniques along with bioinformatics analysis. Different proteomic strategies such as mass spectrometry tools and biochemical analysis are being probed these days for identifying biomarkers. Aims and objectives. The aim of the systematic review was to determine role of salivary proteomics and salivary proteins in detection of autism spectrum disorder. Participants were human subjects with autism spectrum disorder. Intervention was for salivary proteins. Subjects without autism spectrum disorders were compared to typically developing. Evaluation of salivary proteomics and salivary proteins as diagnostic parameter in autism spectrum disorder through deviation in proteome or protein levels of individuals in autism spectrum disorder as compared to healthy individuals were studied. Search strategy. The preferred reporting atom for systemical reviews and meta-analysis guidelines has been applied in this review. 3 databases, that is PubMed, Embase, and Scopus, were used for searching full-text manuscripts. The terms proteome, proteomics, protein, peptidome, saliva, salivary, oral fluid, autism spectrum disorder, along with Boolean operators were used for the search. This was the PRISMA flowchart. In the end, 9 records were included. This table shows the characteristics of the studies included. Results. We identified a total of 954 records with the search strategy, and by following the flow of PRISMA flowchart as shown, and ultimately 9 studies were included. Of the 9 observational studies selected on the basis of criteria, complete protein expression profiling was done in 3 studies, whereas in others, targeted protein quantitation was done. In all the studies, autistic individuals were compared to typically developing or healthy individuals, except for one in which comparison was done to values in literature. Out of 9 studies, 5 were carried out in USA, 2 in India, and 1 in Italy and Greece each. Most studies had a small sample size, and there is quite variation in the age of subjects among studies. For enrollment of autistic individuals, DSM-4 CR criteria was used in most of the studies, while in one study, autism diagnostic observation schedule Hendrick was used, and in another, checklist of autism in toddlers were used. In all the selected studies, saliva have been used to study the proteins in autistic individuals. Saliva collection, being non-invasive, can prove to be important and less aversive diagnostic tool, specifically in case of autism spectrum disorder. Proteomic analysis. In all these studies, different techniques for proteomic analysis or measurement of levels of proteins were used. In most of the studies, mass spectrometry-based techniques were used. In one study, ELISA was used to measure levels of protein biomarkers, and in another, Liquipeth alpha amylase kit with UV spectrophotometer was used, while other studies used reaction assays to observe the variability in levels of salivary alpha amylase between autistic individuals and control group. Software such as String, Panther, David were used in a study for further bioinformatic analysis. Deviation in proteome and protein levels. One study observed hypophosphorylation of salivary peptides in 66% of the autistic subjects enrolled in the study, which hints towards possible role of proteins in pathogenesis of the disorder. In two studies, down-regulation and up-regulation of salivary proteins in autistic individuals came into light. They observed nearly 889 spots for fold change in autistic individuals, and the results were statistically significant. This is the schematic representation of salivary proteomics. First, saliva is selected and protein is extracted from saliva. Then trypsin digests the proteins and converted into peptides. Mass spectrometry analysis is performed, which identify and quantify the protein, and they are studied with the help of bioinformatic analysis. This table summarizes the most commonly examined upregulated and downregulated proteins in autism spectrum disorder. Discussion. Main domains of proteomics are protein expression, protein profiling, targeted protein quantitation, and analysis of protein-protein interactions. These several methodologies could be used to study upregulation or downregulation of proteins and quantitation of selected protein to find its role in detection of autism spectrum disorder. With so many ongoing advancements, still there is lack of characterized salivary proteome, and many disorders such as autism spectrum disorder has not been studied much for any relationship between salivary proteins and pathophysiology and biochemical processes of the condition. Salivary proteome could be examined by different approaches such as short-run proteomics and targeted proteomics. These advancing techniques, along with experimental models, statistical methods, and bioinformatic analysis, can give great insight into pathophysiology of autism spectrum disorder. Limitations. One major limitation of these studies is missing specificity and sensitivity information of salivary proteins, as without which their strength as salivary biomarkers could not be established. There is also dire need to increase the sample size to increase significance and decrease effects of inter-individual variability. Another major limit is that all the data from the vast proteomics has not been utilized, and also limited biomarkers have been studied. Future considerations and conclusions. By studying the changes in protein profiles and their role in biochemical processes, a novel treatment protocol could be developed to treat autism spectrum disorder. Further stratification of disease phenotypes and early interventions could be achieved by studying the protein biomarkers. Integrated multi-omics approaches along with proteomics may also yield promising information. Due to lack of much research, translational proteomics approach, that is studying complex workflows with metabolomics, has not been applied to this subject. There is also dire need for computational models to incorporate proteomics fused data with multi-omics for predicting pathways. Further, chemometric models could be used for better statistical results in metaproteomics. Thus, more research into this subject is required, as proteomics offer the best possibility of examining functional pathways in autistic individuals to help in diagnosis, personalized treatments, and subgroup stratification. These are the references. Thank you.
Hello.
Good morning, sir.
Good morning. What were your observations?
Here in this study, we observed that so many proteins are getting upregulated and downregulated with the that we could study with the salivary proteomics. But this topic is so much untouched when we at the salivary point of view, because so many studies are already existing with blood proteomics. But in saliva, as compared to blood, we have more number of proteins, and now even salivary stratification was done in 2009, and we nearly 3,000 proteins in saliva already have been stratified. So this for diagnostic purposes, there is lot more in saliva.
So what do you think? Does it will be helpful in establishing a link between the autism and by the way of salivary proteins?
Yes, sir, it could help. We tried consulting a statistician also for developing an odds ratio, but these studies are at very much preliminary stages, and in most of the studies, the participants are very less, nearly 6 to 7 in each study. But surely a link could be developed, because there are nearly 889 spots that are showing upregulation and downregulation in proteins.
So why did you choose this topic?
Sir, actually, I have come across two autistic kids, and one is in India and one is settled out of India. The one who is in India is having some issues in the living, but the one outside India, because he was diagnosed earlier, uh, mm, uh, we could modify their ways, because these kids could not easily learn things, but they can have a normal living if they are taught proper habits, and their life could be better if at early stage they are sent to there are even autistic schools are different in foreign countries, but in India there is not much more understanding about the disease.
Okay, done.
Good morning, everyone. Today I'm going to present interleukin 17, a possible salivary biomarker for preterm birth in female with periodontitis. Now coming to introduction, periodontal disease is a chronic inflammatory disease. In this chronic inflammation, pro-inflammatory cytokine like interleukin-1, interleukin-6, tumor necrotizing factor gamma play a significant role in resorption by activating osteoclasts. Interleukin 17 acts on many different cell types, causing them to secrete cytokines such as granulocyte or macrophage, colony stimulating factor, and interleukin 6. Preterm low birth weight is major predictor of perinatal mortality and morbidity. In India, the prevalence of low birth weight has significantly declined from 20.4% to 16.4% in last decade. The prevalence of low birth weight remained high in girl children. Many studies have explored the role of periodontal status in preterm low birth weight on the basis of the data collected retrospectively, while the number of prospective study at present is very few. So, the aim of this study is to assess the relation between the periodontal health status and preterm low birth weight of the newborn on the basis of salivary interleukin 17 level. The objective of this study was to find the association between periodontitis and preterm low birth weight cases, and to assess and compare the salivary interleukin 17 level in pregnant female with periodontitis and without periodontitis. So, the material and method is, this is a prospective observational study conducted in Durg District Hospital, Chhattisgarh, between the periods of November 2019 to May 2020. 40 pregnant females between the age group of 18 to 35 years included in this study, and they are divided into two groups. In group 1, systematically healthy pregnant females were included, and in group 2, pregnant female with periodontitis is included. The primary data collected using questionnaire to assess educational level, socioeconomic status. So, the inclusion criteria of this study is pregnant female in their 24 to 34 weeks of gestation period, and age of 18 to 35 year, diagnosed with periodontal disease, patient who are willing to get enrolled in the procedure with consent. Now, exclusion criteria of the study is systemic condition affecting pregnancy outcome, patient with infectious disease, HIV, bacterial vaginosis, use of tobacco in any form, alcoholism, drug abuse, patient in hormone replacement therapy, patient undergone in vitro fertilization. Armamentarium used in this study were diagnostic mouth mirror, CPI-TN Pro, Falcon tubes, ice pick, centrifuge machine, cryofreezer, human interleukin 17, ELISA kit, micropipettes, and disposable tip incubator, 450 nanometer ELISA plate reader, CPI. Now, CPI index was used to evaluate the periodontal status. Here, 2 ml of unstimulated whole saliva was collected by drooling into a chilled centrifuge tube for 5 to 10 minutes at second trimester and postpartum. The tubes were coded and transferred on ice to the laboratory for processing. Saliva sample processing. All samples were centrifuged at 2500 resolution per minute for 10 minutes at 4 degrees centigrade. The supernatant constituting clarified saliva was separated and stored at minus 80 degrees centigrade until further analysis. Sample analysis was done using BioLegend. Statistical method was done using SPSS version 16.0 software. Independent t-test was applied to test two means of independent groups, and chi-square test was used to compare the categorical variables. Now coming to results, the first picture showed the age distribution of the participant. The difference between the group was not statistically significant because the p-value is equal to 0.70. The second picture shows the intergroup comparison of body mass index between two groups, and the difference in body mass index of participants of both groups was statistically not significant because the p-value is 0.66. In the third figure, show the term and preterm birth in study group. In group 2, there were a greater number of participants had preterm delivery, but the difference between both groups was statistically not significant, and the p-value is 0.058. In fourth figure, which is show the percentage of weight of infant at the time of birth, and it also saw no statistically significant difference between two groups where p-value is 0.14. The figure fifth shows salivary interleukin 17 level in second trimester and postpartum between both groups, and the interleukin 17 level in group 2 was increased in saliva compared to group 1. Now coming to discussion, Declin et al. And Bernal et al. Reported elevated interleukin 17 level in individual with periodontitis. The result of my study is in accordance to the study done by Ejuda et al. In 2008 and Mori et al. In 2004, where they did not find any association between periodontitis and preterm cases. The present study found in the group 1, the level of interleukin 17 was significantly increased from second trimester to postpartum. This result is consistent with the study done by Jarshia et al. In 2010, where they found increase in the serum concentration of interleukin 17 from second trimester to third trimester in healthy pregnant female. Kamal et al. In 2017 did not find any association between periodontitis and preterm low birth weight based on the interleukin 17 level in GCF and placental tissue samples. Now, conclusion of my study is it can be concluded that there is increase in interleukin 17 level in saliva of patient with periodontal condition. There was no association found between the periodontitis and postpartum low birth weight based on estimation of the level of interleukin 17 in saliva of the participants. These are my references. Thank you.
Hello.
Yes, sir. Good morning, sir.
Good morning. So, what did you observe with your study?
So here we go for to assess relation between periodontal health status and preterm low birth weight in terms of interleukin 17 on the basis of saliva, but we failed to establish any association between periodontitis and preterm low birth weight based on the measurement of interleukin 17 level in saliva. And a previous study done by 2017 by Gammal et al. But they measure interleukin 17 in GCF and placental tissue, but they also did not find any association.
So, do you think that periodontal medicine would play a crucial role in assessing the preterm low birth weights?
Yes, sir.
Do you think that periodontal medicine would play a crucial role in assessing the preterm low birth weight babies and developing, especially in a female girl child?
No, sir.
Did you get my question?
I can't hear you properly, sir. Sorry. Hello?
Do you find that periodontal medicine would play a crucial role in assessing the preterm low birth weight babies?
Not properly, sir. I don't know, sir.
Okay, fine.
Percent of dental and 31.3% of medical students. Good morning, this is Vagishri Mukuna. My topic for the paper presentation is familiarity and specialty of periodontics among preclinical medical and dental students, a pilot study. Introduction. Oral diseases are multifactorial caused by interactions between bacterial infections and host response. Medical and dental students should have awareness about various specialties in dentistry as they are forthcoming health professions to encounter the oral problems in patients as there is an established link between the medical and dental students. Aim. The present pilot study was conducted to assess the familiarity of periodontics among preclinical dental and medical students. Objective. To assess the familiarity of specialty of periodontics in preclinical medical and dental students. And also to compare the familiarity of specialty of periodontics among preclinical medical and dental students. Methodology. This is a cross-sectional study was conducted using a self-structured closed-end questionnaire consists of 18 questions in the specialty of periodontics. A sample of 300 clinical, medical and dental students, 150 each of Narayana Medical Institutions were included in the study. The results were established based on the statistical analysis. Study criteria. All the non-clinical students of both medical and dental professions were included in the study. Clinical students were excluded from the study of both dental and the medical profession. This table represents the questions based on the idiopathogenesis and the positive attitude of both dental and medical students. 58% of dental and 59.3% of medical students are well aware of the periodontal diseases. 36% of dental and 31.3% of medical students are well aware of gingival enlargements in the etiology. And as low as 24.6% of dental students and 16.6% of the medical students are aware of gene playing a role in the periodontal diseases. 52% of dental and 31.3% of medical students says that diabetes is a risk factor of the periodontal disease, and this data is statistically significant. As low as 10% in dental and 14.6% of medical students are aware of that periodontal diseases would lead to the preterm low birth in the weight deliveries. 57.3% of dental and 46.6% of medical students are aware that the smoking affects the healing of the periodontal disease. And 23.3% of dental and 17.3% of medical students are aware of the gingival swellings which sometimes occurs during the pregnancy. 59.3% of dental students and 74% of medical students are aware that the dental pain would refer to ears, and this data has a statistical significant values. 49.3% of both dental and medical students are aware that the oral manifestations in the patients with the other systemic diseases. From this table, we get to know that the dental students have a better knowledge in the idiopathogenesis in regards with the compared to the medical students. This table represents the question based on the concept about the treatment and the positive attitude of among dental and the medical students. 86% of dental and 84.6% of medical students are aware that the dental hypersensitivity would constitute the cold, heat and sweet. 86% of dental students and 84% of the medical students are aware when the bleeding from gums occurs, we need to visit the dentist. 64.6% of dental and 45.3% of the medical students are aware when the aesthetic procedures like gummy smiles. And this data has a statistical significant values. And the lasers used in the treatment of periodontal diseases have a statistical values with 57.3% of dental students and 28% of medical students. 13.3% of dental students and 14% of medical students have a knowledge about the allergens in dentistry, which shows a poor knowledge. 18% of dental and 16.2% of medical students are aware of the treatment of gingival overgrowth during pregnancy. 32.6% of dental and 33.3% of the medical students are aware of the oral prophylaxis as it affects the patients with effective endocarditis. 80.6% of dental and 78.6% of medical students are well aware of dental implants. Overall, to assess the concepts of the treatment, dental students and medical students share similar knowledge regarding the treatment procedures. Whereas implants are well known in both the groups, and leastly known are the allergens and the treatment procedures of the gingival overgrowth. This table represents the awareness of frequency of dental visits in an year. Both the dental and the medical students shares a similar knowledge of visiting a dental for every 6 months. This graph represents the awareness of diabetes, dental pain, and awareness of gummy smile treatment and lasers in dentistry in both the dental and the medical groups. This data shows a statistical significant values in both the groups, and the familiarity that diabetes is the predisposing factor for periodontal disease, and the dental origin pain would refer to here, and aesthetic procedures like gummy smile can be treated and lasers in dentistry. Discussion. Periodontal diseases is a bidirectional phenomena, interactions between the bacterial infections and the host response. As we know, oral cavity in our oral diseases are the first person to diagnose. Considering the aforementioned relation between the oral health and systemic conditions, it is determined that all the dental and the medical students, irrespective of the clinical exposure, should have a knowledge regarding the periodontal disease. In the present study, awareness of the periodontal disease etiology and the treatment concepts were evaluated among preclinical dental and the medical students. Under the category of etiology of periodontal disease, as we assessed that the dental students are well aware that the diabetes is the predisposing factor of periodontal disease. Regarding the referred pain of the oral origin, it is assessed that 75% of the medical students are well aware than the dental students. 49.3% of dental and the medical professions are well aware that the bidirectional relationship between the systemic and the periodontal disease. These results are similar with the study conducted by Ravindra Dupala and Yamuna Amarella. When both the professions are compared regarding the etiology of the disease origin, all the participants showed a similar knowledge. While assessing the treatment concepts among the preclinical dental and the medical students in regards with the frequency of dental visits in a year, all the participants showed a close results, which is represented in the figure 1. From the data, we determined that the dental professions are well aware on various treatment modalities in compared to the medical professions. These results are similar to the study conducted by Veena K and Shifali Jain. Conclusion: preclinical dental students showed a better familiarity with the specialty of periodontics compared to the preclinical medical students. Incorporation of oral health awareness during the primary educations will be beneficial in the upliftment of a specialty. And these are my references. Thank you.
Hello.
Good morning, sir.
Good morning. So it is quite understood that the preclinical dental students will be much more familiar with the periodontics as compared to the preclinical medical students.
Okay,
So,
sir. Yeah.
what did you observe with this study?
So I observed that the dental students are well aware regarding the etiology also, sir. They have a much more grip.
Little louder.
So, sorry, sir.
A little louder.
So from the study, we came to know that the dental students and the medical students share the similar knowledge in the treatment procedures. But then regarding the etiology, dental students are much familiar. Maybe due to the profession or the stream, dental students have a much higher knowledge. Hello.
Hello.
Yes, sir. Am I audible?
Yeah, you're audible.
May I repeat, sir?
So it was only based on the questionnaire form, right?
Yes, sir. It is a questionnaire study.
So did the medical specialty were aware of the periodontal aspects, periodontal diseases aspects?
Certainly, sir, but they are not such as like diabetes would be a risk. They are well aware that the diabetes is a risk factor for the periodontal diseases, sir. And also, they are regarding the referred pain, there is a statistical significant values were given in the both the dental and the medical students, sir.
Not about the diabetes, about the periodontal diseases I'm asking.
Actually, we didn't particularly we didn't include in the study regarding the periodontal diseases, sir. In a general aspects,
You should have included the periodontal disease because diabetes is much more known to the medical specialty as well as to the dental fraternity also.
That's what, sir. On a general basis, we may patterned our questions and reference to a previous study conducted by Ravindranath Dupala, sir. So in those reference only, they conducted in the interns and postgraduates, sir. But then we want to know how familiar in the preclinical students. So we conducted the same similar questionnaire with the preclinical students. Sir.
Any limitations you got in your study?
Limitations like all the students have like preclinical students. I would think they have a similar knowledge because they don't have any clinical like as they don't have any clinical knowledge. Both the dental and the medical have a equal knowledge. So that would be a drawback, sir. Like if I also have done in clinical students, that would be a more commanding, sir.
Okay, done.
Thank you, sir.
Thank you so much, Abhishek, sir. I extend my sincere thanks to you on behalf of 19th ISP PG Convention, and special thanks from Dr. Abhay Kolte, sir, for sharing his responsibility so nicely.
It's always been a pleasure to share this as responsibilities. We are so respectful to this Abhay, sir.
Thank you, sir. Thank you so much, sir. So here we come to the end of session.
Hello.
Yes, sir. Yes, sir.
Can you do me one favor?
Yes, sir.
Yeah, can you please mail me once again the evaluation sheets?
Definitely, sir. Definitely, sir.
Please do mail me. Okay.
Yes, sir. Yes, sir. Thank you.
Thank you so much.
Yeah. Yes, sir.
So we are done with this session.
Yes, sir. We are done with this session. We are starting with the next session.
Okay, fine. Thank you.
So for the session 3 and session 4, we have Dr. Dhaval sir and Dr. Kamal Kishore sir as our chairperson. Dr. Dhaval Modi sir has completed his BDS from SPDC Savangi Mege, Varda in 2008 and passed his MDS from GDC Ahmedabad in 2012. He is currently working as a reader in the Department of Periodontics and Implantology, VSPM Dental College and Research Center, Nagpur. Sir has an experience of around 9 years in academics and also owns a private practice in Nagpur. He is currently an EC member of the Indian Society of Periodontology. He has numerous national and international publications to his credit. Our next chairperson for the session is Dr. Kamal Kishore Mankar sir. He has completed his BDS from SPDC Savangi Mege, Varda and passed his MDS from GDC Nagpur. He is currently working as a reader in the Department of Periodontics and Implantology, VSPM Dental College and Research Center, Nagpur. Sir has experience of 8 years in academics with several publications to his credit. I welcome you, Dr. Abhay, Dr. Kamal sir and Dr. Dhaval sir. I hand over the proceedings to both of you.
Thank you, Dr. Girish. Yeah, we can start with the next presentation.
Yes.
So can I start the presentation, sir?
Yes, you can start.
Good morning, everyone. Myself, Dr. Ashwini. I'm here to present my seminar, my study on topic evaluation of antibacterial substantivity of Nigella sativa mouthwash. Good morning, everyone. Myself, Dr. Ashwini, first year postgraduate from Dayanand Sagar Dental College and Hospital, Bangalore. I'm here to present my study on topic evaluation of antibacterial substantivity of Nigella sativa, that is 0.1% mouthwash. I'll be talking under these contents. Coming to the introduction, gingivitis and periodontitis are highly prevalent diseases of the oral cavity. As we know, gingivitis is the initial stage of the periodontal diseases. If it is not treated at the earlier stage, it will progress to the periodontitis and eventually leads to the tooth loss. The etiology of the periodontal diseases are the host, environmental factors, and the microorganisms, where the microorganisms play a major role. So, frequent and precise removal of the microbial plaque is important for the prevention and the treatment of the periodontal diseases. Toothbrushing and interdental aids, they are most self-performed oral hygiene method on routine basis. However, this mechanical plaque control is not sufficiently effective because of the time consumption, dexterity required, and injury to the soft tissues. Therefore, the use of the effective and safe adjuncts along with this mechanical plaque control is important for maintaining a good oral hygiene. Mouthwashes are one among the most effective antimicrobial agents for chemical plaque control. Among the various available chemical plaque control agents, chlorhexidine is considered as a gold standard mouthwash because of its substantivity property. But its long-term usage will lead to the staining of the teeth, tongue, taste alteration, and the increased calculus formation. Hence, there is a need for the naturally occurring indigenous and cost-effective oral hygiene aid with similar positive effects and decreased adverse effects. Medicinal plants have evolved as an emerging substances worldwide for the treatment of the wide array of inflammatory conditions. Nigella sativa is one such herbal product which has a rich historical and religious background. It is also known as black seed and the colonji. It belongs to the family Ranunculosea, and the major constituents are the thymoquinone, dithymoquinone, thymol, and thymohydroquinone. Where the thymoquinone is known for its anti-inflammatory and antioxidative properties, and it has also been reported to have an important role in the prevention of the periodontal diseases. Coming to the objective of the study, it is mainly to assess and to compare the antibacterial substantivity of Nigella sativa mouthwash 0.1% with chlorhexidine gluconate 0.2% mouthwash. The armamentarium required for the study are the human teeth, glass tubes, diamond disc bow, spectrophotometer, distilled water forensic, and formalin. Agents required are the artificial saliva, Nigella sativa, chlorhexidine gluconate mouthwash. Coming to the methods, 20 human extracted teeth were sectioned with a waterproof diamond disc burr to obtain only the crowns. Then these crowns were grouped into Nigella sativa mouthwash, which is group 1, and group 2 is the chlorhexidine gluconate mouthwash. And these crowns were immersed in their respective mouthwashes for 1 minute. Then the samples were immersed in 10 ml of the artificial saliva and kept in a glass tubes. After a time interval of 8 and 12 hours, an aliquot of artificial saliva was taken from the glass tubes, and the same volume was immediately replaced and analyzed using ultraviolet spectrophotometer at 260 nanometer. Coming to the statistical analysis, the comparison of the mean substantivity between the two groups at 8 hours and 12 hours time interval was done using Mann-Whitney test, and comparison of the mean substantivity value within the group at the 8 and 12 hours time interval was done using Wilcoxon sign rank test. These are the results obtained at 8 hours and 12 hours time interval using the spectrophotometer. Coming to the interpretation, the intergroup comparison at 8 hours of time interval was the mean substantivity value of the black seed was relatively higher as compared to chlorhexidine gluconate group at a time interval of 8 hours with a mean score of 0.80 plus or minus 0.13. However, this mean difference in the substantivity value was not statistically significant. The intergroup comparison at 12 hours of time interval was the mean substantivity value of Nigella sativa was relatively higher as compared to chlorhexidine gluconate group at a time interval of 12 hours with a mean score of 0.79 plus or minus 0.14. However, this difference was not statistically significant. Next is the intragroup comparison, that is within the Nigella sativa group. The mean substantivity value at 8 hours of time interval was relatively higher as compared to 12 hours of time interval with a mean score of 0.88 plus or minus 0.09. However, this difference in the substantivity value was not statistically significant. Next is within the chlorhexidine gluconate group, where the chlorhexidine gluconate at 8 hours of time interval was relatively higher, shows relatively higher substantivity value as compared to 12 hours of time interval with a mean score of 0.79 plus or minus 0.14. However, this difference was not statistically significant. Coming to the discussion, periodontitis is a multifactorial disease in which microorganisms play a vital role. Although various chemical plaque control agents are used daily, due to their limitations, herbal products have emerged as a good alternative to overcome these side effects. Nigella sativa is found to possess antibacterial activity against the gram-positive and gram-negative organisms, which was stated by the Kapil H. et al. In 2018. The substantivity of the mouthwash, it refers to the ability of the mouthwash to maintain its antibacterial properties in the oral environment. Therefore, determination of the substantivity of the mouthwash is an important parameter for prevention of the microbial plaque growth. The substantivity of the Nigella sativa mouthwash has not been available in the published literature. Hence, this study was done to evaluate the substantivity of the Nigella sativa and to compare it with the gold standard mouthwash, that is chlorhexidine gluconate 0.2%. And the results were, the result shows the higher substantivity value at the 8 hours time interval when compared to chlorhexidine gluconate group. In vitro studies done by the Senthil Nathan K. et al., Mohammad N.A., Tada A. et al., and they have identified that Nigella sativa possesses the antibacterial activity against the periodontal pathogens. Limitations of the study are as it is a pilot study, the sample size is less, and there are no much studies to compare the substantivity of the Nigella sativa. Coming to the conclusion, unlike the chlorhexidine, antibacterial substantivity of the Nigella sativa was not evaluated so far. Hence, the present study was done to determine its substantivity, thereby promoting its frequency of usage for a maximum efficiency. The Nigella sativa is found to have a greater substantivity up to 8 hours of time interval, and it can be used twice daily for its maximum antibacterial effect. These are my references. Thank you. Sir, I'm not able to hear you.
Dr. Ashwini,
Yes, sir.
can you hear me?
Yes, sir, I can hear you, sir.
Okay, so can you tell the factors which affect the substantivity of the mouthwash?
So it mainly concentration, pH, and the duration of the mouthwash, and what ingredients of the mouthwash, sir.
Okay.
And at what time the mouthwash is given, sir.
So based on the results of your study, will you prescribe this mouthwash to your patients?
Yes, sir, I will prescribe, sir.
Or do we need more studies?
So we need more studies, and sample size should be higher, sir, in order to get a proper result, sir.
Yeah, so before going for prescription of this mouthwash, we should have sufficient studies.
Yes, sir.
Evidences.
Okay. Yeah. Yeah, I am done.
Any effect of this black seed on oral microbial flora?
Yes, sir. They have done many in vitro studies to determine the antibacterial activity against many periodontal pathogens like P. gingivalis, P. intermedia, sir. And they have found a good result, sir.
Okay, only in vitro studies, no in vivo.
So in vivo studies I have also done, sir, but it's on oil-based or solution-based, not on the mouthwash, sir.
Okay, thank you.
Thank you, sir.
Good morning to everyone. My topic is to evaluate clinically and radiographically the bone fill and interbony defects using demineralized freeze-dried bone allograph DFDBA with and without platelet-rich fibrin. Now, periodontal surgical procedures have always focused on elimination of hard and soft tissue defects, that is, probing depth and osseous defects by regenerating new attachment. To achieve this goals, a variety of materials and regenerative procedures such as bone graft, bone replacement materials, and growth factors are being used. Regenerative potential have been demonstrated by various graft materials such as DFDBA, xenograft, autogenous graft, etc. But the most extensively evaluated graft material for the treatment of intrabony defect is DFDBA. DFDBA procedures have shown more bone fill and reduction of pocket probing depth in comparison to open flap debridement, which proves its superiority over open flap debridement alone. Now, several studies have shown that DFDBA leads to bone regeneration in intrabony defects. Numelhart J. et al. Conducted a study where they used DFDBA for the treatment of intrabony defects. Some of the similar studies were also done by Reynolds, Emmy, and Melonic J.T. et al. Now, clinical trials suggest that the combination of bone graft and growth factors contained in PRP and PRF may be suitable to enhance the bone density. Now, what are the aims and objectives of the study? The aim of the study was to investigate clinically and radiographically the bone fill in intrabony defects using demineralized freeze-dried bone allograft with and without platelet-rich fibrin. Now, the objectives of the study includes to evaluate the effectiveness of flap surgery with DFDBA in periodontal intrabony defects as evaluated by relative attachment level, percentage of bone fill, and gingival marginal level, to evaluate the effectiveness of flap surgery with PRF in periodontal intrabony defects, and to compare the efficacy of the combination of DFDBA and PRF and compared to DFDBA alone in the treatment of periodontal intrabony defects. Now, what are the inclusion criteria? Patients were selected between the age of 18 to 65 years having bilaterally similar type of defect, patient at good physical health, and patient maintaining good oral hygiene after completion of scaling and root planing was selected. Exclusion criteria includes pregnant female and patients having allergy to local anesthesia and chlorhexidine, antibiotic, and analgesic drugs. Patients having a habit of smoking and tobacco chewing are excluded, as well as patients not willing for participation in the study and further follow-up. Patients who have systemic conditions such as diabetes and hypertension were also excluded from the study. Now, the methodology. What is the criteria for selecting a periodontal defects? Patient with attachment loss of more than equal to 6 mm at 2 or more sites were selected, and 2 or 3 wall intrabony defects were selected. Randomization was done using the flip coin method just prior to the surgical procedure, and each patient who were eligible received the initial periodontal therapy, that is scaling and root planing with oral hygiene instruction. Now, the surgical protocol includes reflection of all the sites via full thickness microperiosteal flap, attempting to retain all the soft tissues. After that, the exposed roots and osseous defects were debrided with all hand and ultrasonic instruments. In the control site, DFDBA was placed following debridement, and after that, flap repositioning and suturing using seal sutures was done. And in test sites, a combination of DFDBA and PRF was placed, followed by suturing. These are the bone graft materials that was used in the study. At first, incision was given, and after flap reflection, debridement of the defect was done. After that, in the test group, placement of the PRF plugs and DFDBA was done, and the defect was sutured. Now, probing was measured at baseline and 6 months after surgery. Now, what was the recall protocol? Patients were recalled after 7 days post-surgery for suture removal. Patients were recalled every month for 6 months, and at each visit, oral hygiene was reinforced and full mouth supragingival scaling was done. The clinical parameters that were measured includes probing depth, relative attachment level, and gingival marginal level. Now, coming to the results, as we can see in the table, these are the clinical parameters at baseline and 6 months in the control group. We can see statistically significant difference was seen in case of plaque index, pocket probing depth, and relative attachment level, and there was no statistically significant difference in relation to gingival marginal level as compared to baseline and 6 months after surgery. Now, in case of the test group, compared to baseline, there was statistically significant difference in pocket probing depth, gingival marginal level, and relative attachment level. And there was no statistically significant difference in relation to plaque index from baseline and after 6 months after surgery. Now, in intergroup analysis, after 6 months after surgery, we can see there's no statistically significant difference between the control and test group regarding all the parameters, that is the plaque index, probing depth, gingival marginal level, and relative attachment level. The results of the radiographic parameter, that is a bone fill, we can see there was no statistically significant difference between the test and control group 6 months after surgery. Now, bone graft materials are needed in periodontal regeneration that are osteoinductive, have good handling characteristics, and have physical properties. DFDVA is the material of choice for surgical procedures because of this osteoinductive properties. The demineralization process of DFDVA exposes its BMP, that is a bone morphogenic protein that makes it osteoinductive in nature. The PRF induces a significant and continuous stimulation, proliferation of all different types of cell types, as well as release of growth factors, which helps in this mineralization process. Guti et al. In the year 2020 conducted a study where the extended use of PRF to DFDVA helps in improving the clinical and radiographic parameters. PRF was combined with DFDVA to produce a synergistic effect for treating interbone defects in chronic periodontitis patients. Hence, I want to conclude that the use of DFDV alone and in combination with PRF help in improving the clinical parameters, but there was no significant difference between the two, and as such, they didn't provide any additional benefits for the treatment of interbony defects. Now, these are my references. Thank you all.
Morning, sir. Sir, you're not audible, sir.
Yeah, good morning, Nishant.
Good morning, sir. Good morning, sir.
What type of intrabony defects were them?
Sir, two or three interbony defects were evaluated in this study because they provide a better prognosis, and it was easy to fill the bone graft and the PRF plug in that defect.
Okay. Have you heard the term transgingival probing?
Yes,
what
sir.
Is it basically?
So after giving local anesthesia, UNC 15 probe is used and inserted into the periodontal pocket till it touches the alveolar crest, and based on that measurement is taken. So for radiographic fill, distance from the CJ to the alveolar crest is measured, and then distance from the CJ to the depth of the pocket is measured, and again it is divided from the distance to the apex of the teeth, and then according to that the percentage of bone fill is calculated.
Okay. Thank you. Dr. Kamal.
Nishant?
Yes, sir.
What is the best way to evaluate bone regeneration?
Sir, post 6 to 9 months after post surgery, radiographical evaluation can be done.
Is it the best way to evaluate bone regeneration?
So along with that, clinically pocket probing can be.
Okay. So what is the role of PRF in bone regeneration?
Sir,
Can you throw some light on that?
So yeah, it helps to provide growth factors, mostly transforming growth factor, vascular endothelial growth factors, then various leukocyte cytokines, which helps in promoting bone regeneration along with the healing properties of graft materials. So it helps in providing a synergistic effect.
Okay. Thank you.
Thank you, sir.
Good morning, one and all. I'm going to present a topic on evaluation of accuracy and reproducibility of the probing depth measurement of two manual probes and a pressure-sensitive probe. So, periodontium is an attachment apparatus involving a tissue that supports and invests the teeth. It consists of the bone, periodontal ligament, and cementum and gingiva. According to 2017 World Workshop on the Classification of Periodontal and Periimplantal Diseases and Conditions, the severity of the periodontal damage can be assessed by clinical attachment loss, radiographic bone loss, presence of periodontal pocket, and gingival bleeding. There was a study done by Nazir Ami in 2017 who stated that the essential part of the periodontal examination is the measurement of the loss of periodontal ligament attachment, and it is considered as a gold standard in reporting the prevalence of the periodontal disease. So for the assessment of the periodontal disease, periodontal probes plays very important role as they are convenient and easier to use. Periodontal probes are highly specific and highly sensitive diagnostic tools that are used to measure the periodontal diseases. There are total 5 generations of periodontal probes. First generation is a conventional probe, which are also called as manual probe. Second generation is a constant force or pressure sensitive probes. Third generation are Florida probe, Foster probes. These probes are attached to the computer, so data can be saved. And fourth generation probes are 3-dimensional probe in which the 3D measurement of the pocket can be done, and fifth generation probes are non-invasive 3-dimensional probes. There are certain factors which can hamper the probing measurement. It includes probe-related factor, environmental factors, and examiner-related factors. So, probe-related factors include accuracy of the marking intervals. Environmental-related factors are subgingival obstruction, root anatomy, and the condition of the tissue of the pocket. And examiner-related factors include angulation of the probe, probing force, and the pattern of probing force. So null hypothesis for the study is that there is no difference in the accuracy and the reproducibility of probing depth measurement between all 3 periodontal probes. Aim of the study was to evaluate the accuracy and the reproducibility of the probing depth measured by 2 manual probes and a pressure sensitive probe. Objective for the study was to determine the accuracy and reproducibility of 2 manual probes, that is UNC 15 and CPIDN probe, to determine the accuracy and reproducibility with a pressure sensitive probe, and a comparison of accuracy and reproducibility of all the 3 probes. So material included in the study was UNC 15 probe, CPITN probe, these 2 are manual probes, and pressure sensitive probe, and aluminum box was used with 16 specifically engineered holes of different diameter and different depth. For the study, which was an in vitro study, it was carried out in the Department of the Periodontology, KM Shah Dental College and Hospital, Sumandeep Vidyapit in Vadodara. There was we have taken ethical committee approval, and then study was started with 90 subjects who were undergraduate and postgraduate student. The power of the study was calculated at 80%, and 5% of risk. And recruitment of the participants was done, and sites as per the inclusion and the exclusion criteria. So we have included undergraduate and postgraduate students who were willing to take participation in the study, and subjects who were not willing and who were unaware of use of probe and who were not familiarized with the probes were excluded. So aluminum box with 16 precision holes. Each hole was separated with the 10 mm interval, and diameter of each hole was 1.1 mm, and depth was varying at 2.5 to 10 mm, and the floor of each hole was flat. All participants were trained for using of probe prior to the study, and probes used in the study were UCN, UNC 15 probe, CPITN probe, and periodontic pressure sensitive probe. The first one is a UNC 15 probe with 0 to 15 marking, and the second diagram showing a CPITN probe with a ball of 0.5 mm at the tip, and third is a periodontic pressure sensitive probe with a marking from 1 to 10 mm. Participants were not aware of a depth of hole before the start of the study. All participants were asked to measure all 16 holes with all the 3 probes at baseline and at the interval of 7 to 10 days. The rationale for this analysis was based on the assumption that there was an agreement with an exact probing depth values. This indicated the accuracy of the measurement, and repeated values were compared to check reproducibility of the probes. Results of the study were calculated. A total of 90 undergraduate and postgraduate students included in the study, and all participants were asked to take a measurement at baseline to 7 to 10 days of interval, and statistical analysis of the measurements was done. So UNC 15 probe showed p-value is equals to 0.083. CPITN probe showed p-value 0.0417, and pressure sensitive probe showed p-value 0.45. All the values were insignificant, and thus showed good reproducibility, and the intergroup comparison of
mean depth of holes was P is equals to 0.00, that is which was highly significant, with a pressure sensitive probe showing most accuracy out of all three probes, followed by UNC 15 probe and CPITN probe. So the similar study was et al. In 2014, in which he concluded that operators using Vivacare probe whether neither accurate or not reproducible. Williams probe was reproducible when measured the probing depth in the aluminum blocks, and it was not accurate when compared to the standard measurement reference. But Chappell's probe was reproducible as well as accurate. A study done by Setna DT in 2016, there was no great variability in probing depth and cal between the conventional UNC 15 and PDT pressure probe. There was one more study was done by Renatas et al. In 2016, in which pressure calibrated method which stated that pressure calibrated method delivers reproducible results even with different uses, and there was no significant difference between the measurement of the values recorded by measurement method, that is electronic and manual, in respect to the total time. So I would like to conclude the present study that pressure sensitive probe showed maximum accuracy in measurement of probing depth, and an in vitro in vivo study comparing probing depth measurement between trained and untrained examiner with appropriate sample size and exact time frame needs to be planned for proving the accuracy and reproducibility of the manual as well as pressure sensitive probe. These are the references. Thank you so much. Good morning, sir.
Good morning. I think the sample size should be more. If you are comparing the reproducibility, your sample size was 90
90,
students,
sir.
right?
Yes, sir.
Yes. So when you are comparing the reproducibility with the conventional and pressure sensitive probe, I think in such studies, the sample size should be more. Like
Yes, sir.
this is very less sample size for comparing.
Yes, sir.
Okay.
Dr. Priyanka,
Good morning, sir. Yes, sir.
other than the sample size, what are other limitations of your studies?
So as this is the in vitro study, so the results cannot be applied for the clinical scenario. And in vivo study should be carried out to apply for the applicability of the results in clinical scenario.
Okay. And what was your research question?
So research question was whether the reproducibility and accuracy of manual probe is similar to pressure sensitive probe or not.
Okay. Thank you.
Thank you.
Thank you, sir.
Dr. Dheeraj Sharma, a passionate periodontist like all of us. But at the age of 41, he was forced to bid farewell to his profession, which he was most passionate about. Meet Dr. Subramanian. His age is 66. He is a general dentist practitioner. He is still practicing enthusiastically. The reason behind the stopping of practice of a young dentist and the practice of a senior dentist is a simple science which we quite often neglect to do, ergonomics. Good morning. I'll be presenting the evaluation of knowledge and level of information about equipment ergonomics in interns and postgraduate students of KM Shah Dental College. Dentists are more prone to work-associated injuries and illness, which reduce work proficiency, risk of long-term disabilities, mental stress, and psychological problems. Most prevalent among these is musculoskeletal injuries. Dental practice may result in muscular imbalance, neuromuscular inhibition, pain, and dysfunction, mainly due to cumulative microtrauma and repetitive use of awkward positions. Dentistry is a visually dependent occupation where the visual demands may require adoption of fixed postures for extended periods of time. Unlike practitioners, students usually perform dental procedures without an assistant with their limited coping skills and psychological stress in the dental school environment. Introduction of ergonomically designed chairs early in the training before development of wrong postures is mandatory. Taking frequent and brief rest periods in between the working hours to reduce MSI is known as micro breaks. Comprehensive understand and practice of EE decisive of interception of the dentistry related health concerns. The aim of the study was to assess awareness regarding equipment ergonomics, exercise, and micro breaks among interns and PG students of KM Shah Dental College and Hospital. This study design was a questionnaire institutional study with close-ended questionnaire survey amongst interns and PGs at KM Shah Dental College and Hospital. This was the 21 questions which we raised to the study population, in which 7 significant questions we'll be discussing in the presentation. 180 participants were participated in this survey. Among that, 24% of male population and 75% of female population with an age of 25 was participated. In that, 52% were interns and 47 was postgraduate students. The first question we raised was, ergonomics principle apply only to chair position but not to equipment. 69% of the students were disagreed the statement. Among that, 92% were MDS students and 49 was interns. The second question we raised was, do you consider that MSI are not related to wrong equipment ergonomics? 74% of the study population disagreed to the statement. Among that, 100% were MDS students and 50 was interns. The next question we raised was, dental chair ergonomics is not needed for maintaining operator's neutral position. 72% of the study population disagreed to the statement, in that 100% were postgraduate students and 46 were interns. This next question we raised was, should the operator chair height be adjusted so that hips are slightly higher than the knees? 73% of the study population said yes to the statement. Among that, 100% were PG students and 48 were interns. The next question we raised was, ergonomically designed operators tools such as saddle seats, tri-shape seats, etc. prevents back pain. 66% of the population said yes to the statement. Among that, 100% were PG students and 35 were interns. The last question we raised was, have you ever used chairside exercise in your clinical work? 42% of the population were not sure about the chairside exercise, what they have done. Among that, 75% were postgraduate students and 11% were interns. The next question we raised was, should equipment ergonomics be included as a separate entity in the syllabus before students enter the clinic? 86% supported the statement. Among that, 100% were postgraduate students and 66 were interns. Ergonomics is an applied science concerning the design or arrangement of things people use so that the things interact most efficiently and safely. It avoids occupational disease, decreases mental and physical stress, improves capacity and comfort of both dentists as well as patients. It found that the prevalence of MSI is remarkably high among dentists. Improper equipment ergonomics is responsible for the extended leave from their practice. The awareness of posters, operating chair positions, and equipment usage patterns helps to decline the progression of MSI. Improper usage of gloves leads to different types of syndromes like carpal tunnel syndrome. The chair height must be adjusted so that the patient's mouth should be at operator's elbow level. The distance between operator's eye level and patient's mouth should be approximately 12 to 16 inches. 80 to 100% of the day, a dentist is sitting in a chair with poor lumbar support and inadequate adjustability has more risk of developing lower back pain. Surgical magnification systems and lighting are powerful allies in maintaining proper ergonomic position of the operator with reduced stress. Keeping working edge sharp, taking adequate micro breaks and awareness programs, occupational health programs, relaxation, exercise therapy, intervention strategies like kineso tapping, Alexander techniques helps in reducing equipment ergonomics. To conclude my study, there is a statistically significant difference we found between both interns and postgraduate students. The knowledge of postgraduate students was far more than interns regarding equipment ergonomics. Practical application of equipment ergonomics found to be lacking in both the group. Improper importance of micro breaks with a chairside exercise should be emphasized, and training should be initiated at early stage before the onset of micro MSI, musculoskeletal injuries. Within the limitation of this study, we suggest improvising the scenario of an acquaintance of equipment ergonomics in the dental curriculum. These are my references. Thank you. Good morning, sir.
Good morning. Regarding incorporation of ergonomics, I agree with you regarding that. But what was so unique about the knowledge regarding postgraduate students and interns? Obviously, PG students will have more knowledge regarding ergonomics as compared to interns. So how will you justify it?
Sir, the thing is, it is not that mandatory that every dentist will go for a post graduation or like a higher degree to start with their practice. So the knowledge about ergonomics and posture is mandatory for a UG practitioner also, because it is like, what if they may not go for a higher education and they will start entering to a clinic soon, or they will pursue with their practice. So they should definitely have to have a knowledge of ergonomics. That was the reason behind my study. So which shows that they don't have much awareness, so that we can include the awareness of ergonomics in the UG curriculum also, sir.
Yeah, that's true. But you should have included the knowledge of clinical practitioners regarding ergonomics.
Clinical practitioners, sir. When it comes to clinical practitioners, definitely you have to get the. I agree with your statement, sir. It is exactly true. But the student population what I took is, I want to show, or I want to prove the fact that this is more focus is getting in post graduation, and these students which are not aware of it will start with their practice, and they will end up in posture difficulties and all.
Dr. Kamal?
Yeah. Dr. Sandra,
Yes, sir.
is there any difference between a questionnaire and survey?
Sir, this was a questionnaire survey what I was done.
I'm asking whether there is any difference between questionnaire based study and a survey.
Yes, sir. There is a
Or are they
difference
same?
between. No, sir. There will be there is a difference, sir, in between questionnaire study and a survey.
Yeah. So what is the difference?
Sir, in questionnaire studies, it will be of different types. Survey, so like it will be like different types of questionnaires we can use, like that. And like this in my study, I've used close-ended questions. But in surveys, it will be of it can include it of different types of.
Okay. Nice presentation.
Thank you, sir.
Thank you.
Hello everyone, my basic research topic is evaluation of CXCL10 levels in smokers and non-smokers of stage 3 and 4 generalized periodontitis. Moving on to introduction, CXCL10 is a pro-inflammatory cytokine that is secreted by various cells like PMN, that is neutrophils, keratinocytes, fibroblasts, endothelial cells, as well as monocytes. Based upon the chemical structure, chemokines are divided into two families, that is CXC type and CC type. And based upon the position of cysteine residues, that is CC, in this diagram we can see CC, which represents cysteine residues, and based upon that they are further classified into C, CC, CX3C and CXC subgroups. CXC chemokines primarily activates a PMN, that is neutrophils, whereas CC chemokines are mainly chemotactic in nature and play a role in class switching of macrophages from M1 to M2 during transition from that is acute to chronic inflammation. CC chemokines are also crucial in development of adaptive immunity as well. These are the proposed mechanisms of activation of CXCL10. Basically, CXCL10 is activated by many agents like a virus, LPS, that is lipopolysaccharide, which is secreted from oral pathogens, and cytokines like interferon gamma. Basically, these agents actually they come and contact this pathogen-specific receptor and activate JAK and STAT pathway. JAK and STAT pathway. Basically, JAK and STAT pathway is nothing but they helps in phosphorylation and activation of genetic gene level of any protein. Basically, this pathway, JAK and STAT pathway, helps in increasing or elevating the CXCL10 gene expression, which leads to CXCL10 secretion. The secreted CXCL10 helps in activation of T cells, that is, which increases the count of T cell as well. And this activated T cell further secretes TNF alpha and rankle, which leads to root resorption as well as bone resorption and leads to osteoclastogenesis as well. Smoking is considered as a significant risk factor for periodontitis, as smokers are 5 times more prone to develop periodontitis. Smoking increases the risk of periodontitis by elevating the periodontal pathogen levels, and also it alters immune inflammatory response by elevating mediators like NF-κB, PGE2, neutrophil elastase, and MMP, that is matrix metalloproteinase 8. Cigarette smoking is a modifiable risk factor, induced PMN respiratory burst and oxidative stress in periodontal tissues as well. Liney et al. Observed CXCL10 levels were elevated in mice when exposed to cigarette smoking. Similarly, Shimadi et al. Observed higher levels of CXCL10 level in GCFR periodontitis subjects. In a multiplex proximity extension assay, Penese et al. Observed elevated CXCL10 levels in serum samples of periodontitis subjects. Allavala et al. Observed elevated CXCL10 levels in all 3 samples, that is saliva, serum, and GCF of chronic periodontitis compared to gingivitis subjects. And CXCL10 levels were elevated. In this study, they have even seen the elevation of CXCL10 levels in smokers. But however, statistical results could not be generated in the study because of very less smoker subjects. And moreover, they haven't mentioned the frequency of smoking of the subjects. Thus, the aim of this present study was to evaluate the salivary levels of CXCL10 in non-smokers and smoker subjects, and also to check the correlation of clinical parameters with the inflammatory chemokine, that is CXCL10, in stage 3 and stage 4 generalized periodontitis subjects. Inclusion criteria include systemic healthy subjects of age group 20 to 50, stage 3, stage 4 generalized periodontitis subjects, according to AAP 2017 classification, and current smokers according to CDC classification were included in this study. Exclusion criteria includes age greater than 60 years. Systemic disease patients like diabetes mellitus were excluded from this study, and patients who underwent periodontal treatment are also excluded from this study. Healthy periodontium patients were also excluded from this study. 84 patients were recruited from outpatient department, and they are divided into 2 groups. First group consists of non-smoker stage 3, stage 4 periodontitis subjects, and the second group consists of 42 stage 3 and stage 4 generalized periodontitis smoker subjects. Current smoker, as per CDC classification, is defined as adult who smoked 100 cigarettes in his or her lifetime and who currently smokes even right now. So stage 3 and stage 4 generalized periodontitis subjects was based on the AAP classification 2017, that is PPD is of greater than or equal to 6 mm and 3 CL of greater than or equal to 5 mm in greater than 30% of the teeth, and tooth loss of lesser than or equal to 4 teeth, and radiological bone loss extending to middle third of the root, and vertical bone loss of greater than or equal to 3 mm. After recruitment and screening of the patients, saliva sample was collected. That is, I have collected saliva sample based upon Navazish et al. Protocol. That is, unstimulated saliva was collected in a tube and it was centrifuged at 3000 rpm for 10 minutes, and it was stored at -4 degrees for further ELISA analysis. In this study, I have used rebiotic ELISA analysis. Here in this picture, we can see the reagent all the reagents. These are the ELISA analysis. This is ELISA reader which shows the results. Statistician has used student t-test to compare variables between 2 groups and Pearson correlation test to correlate CXCL10 with clinical parameters. This is a graph which shows the mean level of both the groups of CXCL10. In smoker group, we can see the high elevated levels of CXCL10, whereas in non-smoker, very less, that is lesser than 100, we can see the value of CXCL10 in non-smoker group. CXCL10 was detected in both the groups and all periodontal clinical parameters were highly statistically significant. This table shows the clinical parameters and CXCL10 in both the respective groups. Here, both gingival index, plaque index, PPD, CL were not so different or almost similar, but a higher CXCL10 level was seen and observed in group 2, that is in smoker group. These two tables are which shows the correlation of clinical parameters with CXCL10 in group 1 and group 2 generalized smoker and non-smoker periodontitis subjects. All the clinical parameters, that is gingival index, plaque index, PPD, and clinical attachment were positively correlated and statistically significant with CXCL10 levels. Moving on to discussion, in Allah Wali et al. Study, they observed elevated levels of CXCL10 in all three samples, but statistical results could not be generated because of very less smoker subjects, and moreover, the smoker classification was not clear. In the current study, between the groups, the CXCL10 marker was found to be higher in smoking subjects with periodontitis, which are statistically significant. Moving on to conclusion, CXCL10 levels were detected in both the groups and were positively correlated with clinical parameters. Based on this study results and other literature evidence, we can conclude that CXCL10 can serve as biomarker in periodontitis. Good morning, sir.
Okay, good morning. Are there any other effects of CXCL10 on the human body?
Yes, sir. Actually, they have done in rheumatoid arthritis as well as cardiovascular diseases, sir. And they also, scientists also concluded that it acts as a biomarker in rheumatoid arthritis subjects as well, sir. So in medical, actually, they have identified a very defined pathway for the, osteoclastogenesis, but in dentistry, it is yet to be still proved, sir.
Right. Dr. Kamal?
Yes, what were the limitations of your study?
Sir, actually, I thought of taking one more group, sir. That is, gingivitis groups are healthy periodontium. But the main problem is that, because of my financial problem, I could not actually afford another group, sir. Actually.
Okay, nice presentation. Thank you.
Thank you, sir. Thank you very much, sir.
And all. My topic of paper presentation is a comparative analysis of different plaque detection methods. Coming to the introduction, dental plaque is a specific but highly variable entity resulting from growth and colonization of microorganisms on surface of teeth, restoration, and soft tissue consisting of various species microorganisms entangled in the extracellular matrix. Plaque deposition leads to inflammation of gums called gingivitis and further lead to periodontitis if left untreated. It can also cause halitosis, and if not removed regularly, it can be calcified into caliculus tightly adhering to the tooth surface, which can only be removed with the help of dental professionals. Blood sites serves as the entryways for pathogens into the bloodstreams, which may lead to conditions like stroke, cardiovascular diseases, atherosclerosis, endocarditis, and respiratory diseases like pneumonia. So there is a significant prophylactic value in detection and removal of plaque. Many forms of disclosing agents are available, but new technologies are introduced which makes the process easier and faster. Plaque in oral cavity can be detected by fluorescence, and it has been studied that fluorescence is produced by porphyrins that are present in certain bacteria. Porphyrins acts as pigment that are fluorescent with characteristic bands of absorbance between the wavelength of 390 to 425 nanometers, a strong solid band in the wavelength of 380 to 500, and weaker Q bands in the wavelength of 500 to 750 nanometers. In this device, the blue spectral light is focused on the teeth with the wavelength of 405 nanometers. Then a porphyrin present in the specific area rapidly absorbs the light with a strong solid band present, and the red fluorescence is emitted back, which can be clearly visible through the filter present on the device. Aim of this study is to find out whether the newly arisen plaque detecting techniques are better over the disclosing agents and to check their efficacy. The objectives of our study are evaluation of efficacy of fluorescent plaque detecting technique and the comparison of efficacy of both disclosing solution and fluorescent plaque detecting device based on the opinion of dental students after their personal experience. Materials and methods. The source of data were the students from first to fourth year BDS from People's College of Dental Science and the People's Dental Academy. The participant size was 520. The study variables included were the dental plaque, disclosing solution, and Q-scan plus. Dental plaque is an independent variable, disclosing solution, and Q-scan plus are the dependent variables. The inclusion criteria is healthy volunteers, subjects with age group of 16 to 25, subjects with minimum 20 natural teeth, excluding the third molar. Exclusion criteria includes the subjects with an systemic disease, subjects with periodontitis condition, and pregnant women. Apparatus and materials. Plaque disclosing solution, Q-scan plus, which is a fluorescent imaging device, tweezer, cotton pellet, mouth mirror, probe, mirror for self-assessment, questionnaire forms. This is the questionnaire form we have used. We have 6 characteristics of an disclosing agent mentioned in a table and asked every student to tick in the appropriate box, which are comfortable to use, faster results, specificity, ease of use, residual stains, and allergic reactions. Data collection procedure. Students from 2 dental colleges are selected and written consent was signed by each one of them after explaining the procedure. Each participant was examined first with the help of Q-scan plus, and they asked to observe the plaque in the area of red fluorescence emitted on the teeth. Then after a while, participant was examined with the help of disclosing solution and again asked them to observe the area of tooth that gets stained, that is plaque with teeth disclosed. After examination with both methods, participants were asked to fill the questionnaire forms. This is the device we have used versus the old disclosing method, that is a disclosing solution. This is the result obtained by the Q-scan plus, and this is the result obtained by the disclosing solution. This is a similar case, result obtained by the Q-scan plus and result obtained by the disclosing solution. We can appreciate the plaque disclosure. Statistical analysis was conducted using the chi-square test. The results revealed the fluorescent plaque identification technique had better grades in every positive feature that a disclosing agent should typically have. These are the results obtained for frequency of participant distribution. 25.4% from the first year, 23.8% from the second year, 23.8% from the third year, 26.9% from the fourth year. And these are the results obtained from the questionnaire. We can see the maximum number of participants have opted for Q-scan plus in every favorable aspect, except in the case of residual stains and allergies. In the case of comfortable to use, 4.2% opted for disclosing solution and 95% opted for the Q-scan plus. In the case of faster results, 2.3% for the disclosing solution and 97% for the Q-scan plus. In the case of high specificity, 22% opted for disclosing solution and 77% opted for the Q-scan plus. In the case of ease of use, 4% opted for the disclosing solution and 95% opted for the Q-scan plus. Any residual stains, 97% opted for the disclosing solution and 2% opted for the Q-scan plus. Any allergies seen with 1.5% opted for the disclosing solution and no one opted for the Q-scan plus. Coming to the question number 1, which is comfortable to use, the maximum number of participants are from the second year who opted Q-scan plus, and the p-value is significant. Coming to the faster results, the maximum number of participants who opted Q-scan plus are from the final year, and the p-value is significant. Coming to the high specificity, the maximum number of participants who opted for Q-scan plus are from the final year, but the results are not significant. Coming to the ease of use, the maximum number of participants opted for the Q-scan plus are from the second year, and the p-value is significant. Coming to the residual stains, the maximum number of participants here opted for disclosing solution are from the third year, and the results are significant. Any allergies seen with? Here, maximum number of participants did not opted any of the option, but 2.9% from the final year opted for the disclosing solution. Here, the p-value is not significant. Coming to the discussion, comparative studies on plaque disclosure are not found in any past literature, mainly in India. So we took up a step and did research on disclosing agent versus newly emerging techniques of plaque disclosure. Kate Angelino et al. Conducted a study in 2017 on 28 human subjects. They constructed a device with a 405 nanometer to examine the prevalence of red fluorescence compared with the white light illumination. Both the devices gave a comparable performance. They did not compare the efficacy of fluorescent technique over the traditional disclosing agent, which are currently in use everywhere. Catherine M.C. Wolligand et al. Conducted a cross-sectional study on 48 individuals. They concluded that red fluorescent plaque and blue disclosed plaque showed similar scores. Consequently, we can neither confirm nor reject the use of fluorescence device to screen the mature dental plaque. Although we have got favorable results using the new fluorescent technique, further studies on plaque disclosure may be needed to come into a conclusion. As this study has a limitation, the results are based completely on the view of participants over both methods used. Coming to the conclusion, it can be concluded that QScan Plus is superior to the disclosing solution in every aspect like comfort, ease of use, faster results, and residual stains are seen with the disclosing solution because of the dye used in it. There is no question of allergic reaction using QScan Plus because the light that is used for plaque disclosure is a blue spectral visible light with a wavelength of 405 nanometers, which is completely harmless to the tissues. These are my references. Thank you. Good morning, sir.
Good morning. Which disclosing solution you have used in your study?
Sir, erythrocin, sir.
Erythrocin.
Yes,
Regarding two-tone dye solutions, which are more popular as compared to erythrocin?
So I didn't use a two-tone dye, sir. I have used a single one, sir.
Okay. And what's the cost of this QScan Plus?
So it's around 25,000, sir.
Around 25,000.
Yes.
Okay. Any other study regarding the use of QScan Plus and analysis of plaque samples?
No, sir, I didn't
Previously?
find any study. According to me, so I searched everywhere. In India, there is no study, sir, for the QScan Plus. Sir. In foreign, they have done so, but regarding the only white light and the red light.
Okay. No study has been conducted till now.
No, sir.
Okay. Dr. Kamal?
Yes, Dr. Sai Shri.
Yes, sir.
Can this QCAN Plus used by patient at home also?
Yes, sir, it can be used.
Okay. Okay, good presentation.
Okay, sir, thank you.
Okay, thank you.
Thank you, sir.
Also, we will move to the next session.
Topic for my today's presentation is COVID-19 oral lesions detecting the pattern and topics which I am going to cover in this presentation is introduction, aims and objective, materials and methods, results, discussion, conclusion. The world has been seeing a sudden rise in cases of COVID-19 due to the second wave. 164 crore cases has been reported worldwide. India is no less. 25 crore cases has been reported in India, and in Madhya Pradesh, 7 lakh is alone reported. No one can ever imagine how much this number can increase. So, as a dentist, or rather I can say as a periodontist, I would like to tell and cover about the two aspects we need to look out for early diagnosis of COVID-19. First is being vigilant and checking out ulcers, erosions, papillae, macule, halitosis, spontaneous bleeding in cases or in patients, and the common sites such as tongue, labial mucosa as well as palate. And second aspect is checking the laboratory consideration and the clinical consideration in this COVID-19 cases. In recent months, survivors of COVID-19 cases who have had the disease for weeks to months, termed long haulers, describe oral problems they are experiencing such as teeth falling out, sensitive gums, teeth turning gray, and cracking. The mouth might be the most vulnerable area to this virus due to the abundance of ACE2 receptors in oral tissue. A new preprint study found that compared with the oral tissue, cells of salivary glands, tongue, and tonsils carry the most RNA-linked proteins that SARS-CoV-2 virus need to infect cells. These include angiotensin converting enzyme 2 receptor and the enzyme known as transmembrane protease serine 2, which allows the virus to fuse its membrane with that of the host cell and slip inside. Thus, the aims and objective of my study was to assess and evaluate the pattern of oral lesions found in COVID-19 patients, as well as to evaluate the clinical and laboratory characteristics in these patients. The study population comprised of patients admitted in COVID-dedicated hospital in Bhopal, ranging the age group of 20 to 80 years. Approval from Institutional Ethical Committee was taken. Sample size was 53. Informed consent was obtained from the participants of the study before the examination. Time period for my study was 15 days, that is May 1st, 2021 to May 15, 2021. Inclusion criteria included age 20 to 80 years, patient who are COVID positive, patient with underlying diseases. Exclusion criteria included patient with autoimmune diseases, immunocompromised patient, in oxygen therapy, pediatric patient. These are the oral lesions or oral findings which I saw in these patients. Result. Age. The median value was 45 and mean value was found to be equal to 45.86. 56.6% of cases or the participants were males, 43.4% of patients were female. Comorbidity. 30% of them were diabetic, 26% of the patients were hypertensive, 15% of them were both. 18.3% patients present in this study had lesion. Distribution of age for the patient suffering from oral lesion. This graph depicts the randomness of age who are suffering from oral lesion, as it does not depend upon the age. It neither depends upon the gender. Patient who are diabetic or who is suffering from hypertension does not have the program of oral lesion. Analysis of the patient suffering from oral lesion. The values such as D-dimer, CRP, WBC, RBC, MCV, MCH patient have been clustered into similar groups. These clusters were based on the similar observation findings. Cluster 1 included the patient whose D-dimer were greater than 0.5. Other values were approximately normal. P23, the D-dimer value was high, WBC was low, MCH was slightly higher than normal. P21, the content of CRP and WBC values were slightly higher than normal. The cluster 2, the person P13 had very high WBC content and low MCV and MCH content. Cluster 3 for the patient P14, except the CRP values, all the contents were abnormal. Cluster 4, the WBC content of all the patients in this cluster were found to be high. P2, the content of MCH, CRP and MCV is normal. So we can see that CRP and age of the patient are inversely related, and based on the facts, MCH and CRP values of the patient were positively related or directly proportional. The summary statistics of variable D-dimer, the standard deviation was found to be 3.47. The CRP values, the standard deviation was found to be 2.39. WBC, the standard deviation was found to be 20. RBC, the standard deviation was found to be 0.82. The standard deviation for MCV and MCH was found to be 24.03 and 5.21 respectively. Discussion. The median age of our study was 45 years. Several studies have reported an older median age of 50 to 57 years in patients with severe conditions. 30% of patients present in this study were diabetic, 26% of them were suffering from hypertension, 15% of the patient had both diabetes and hypertension. The variables age, gender, diabetes, and hypertension does not have any impact on oral lesion. The CBC finding of this investigation showed high level of CRP. This rise of CRP can be explained by the response of human body to the new COVID-19 infection. Zhang et al. Reported that increased leukocytes were commonly observed in severe cases. In favor to our observation, leukocytosis was observed in the groups present in with comorbidities. Conclusion. After slight lesions, herpetiform lesion, candidiasis, and oral lesion of Kawasaki-like disease are most common oral manifestation of COVID-19 disease. Lack of oral hygiene, opportunistic infections, stress, underlying diseases such as diabetes mellitus and immunosuppression, trauma secondary to incubation, vascular compromise, and hyperinflammatory response secondary to COVID-19 are the most important predisposing factors for the development of oral lesion in COVID-19 patients. This study demonstrates the importance of close link between SARS-CoV-2 and oral manifestation. However, there is no scientific evidence in the literature that certifies which oral symptoms SARS-CoV-2 can actually cause. In fact, from the analysis of our data, it was hard to notice that clinical conditions that patient manifested are due to SARS-CoV-2. The present study has shown CBC of the patient with oral lesion. The most likely laboratory findings in these patients were abnormalities in RBC, WBC, CRP, D-dimer, MCV, and MCH values. Clinicians should always consider these parameters when reading the CBC of COVID-19 patient for early diagnosis of the lesion, the early diagnosis of the disease, and for the better treatment planning for the patient. These are the references. Thank you so much.
Nice presentation, Dr. Ashwini.
Thank you, sir. Good morning, sir.
Good morning. Why the CRP levels are increased in COVID patients?
Yes, sir. Actually, the CRP level is increased because of the cytokine syndrome, which is caused. And the CRP level is a non-specific marker which can show where there is inflammation in our body or tissue injury in our body. So this was increased.
Okay. What's your opinion regarding mucormycosis in COVID patients?
So my opinion is that I'm seeing current rise in black fungus, white fungus, aspergillus, many things. So I think as a dentist, we should be vigilant. And when I went to see the patient, I saw one black fungus case, and I told that faculties over there that this guy must be having. He was a 70-year-old patient, and he was showing that black palate was whole black, and he was having problem. So he was not in incubation, but I don't know, sir, correctly, because research is going on still. So I don't know what is the correct cause and all, but we should be vigilant.
Yeah, usually it occurs in cases of systemic
With
problems. in
diabetes
patients with-
mellitus and
Yeah.
corticosteroids, they are taking dexamethasone, prednisolone. So that's why.
Dr. Kamal?
Yeah. Dr. Ashwini,
Yes,
you have
sir. Good
included
morning.
only those patients who are hospitalized for COVID-19.
Yes, sir.
So why didn't you include the patients which are not hospitalized?
Sir, I went to a COVID dedicated hospital, so there was only COVID patients there, and they were not serious patients, and they were not in incubation or in oxygen. They were normal
Okay.
patients with normal symptoms.
Okay. Okay, nice presentation.
Thank you so much, sir. Thank you, sir.
Hello everyone, I'm Dr. Ruqayya Ansari, presenting the paper on periodontal health of children with type 1 diabetes mellitus, a case control study. Contents includes introduction, objective, methodology, result, discussion, conclusion, and references. Introduction. Type 1 diabetes mellitus accounts for approximately 5% of persons with diabetes. Type 1 diabetes results from autoimmune destruction of insulin-producing pancreatic islet cells, leading to loss of insulin production. Excessive concentration of inflammatory markers such as tumor necrosis factor alpha, prostaglandin E2, C-reactive protein, interleukin 6, and interleukin 1 observed in patients with type 1 diabetes mellitus seem to play a role in periodontal damage. Patients diagnosed with diabetes mellitus are considered a high-risk group with greater susceptibility to severe form of periodontal destruction that may lead to tooth loss, among which gingivitis and periodontitis constitute the two main clinical forms. Objective of this study was to assess the periodontal conditions and oral health behavior of children with type 1 diabetes mellitus and compare them with systemically healthy children, and to explore the diabetes-related parameters that are associated with periodontal destruction in children with type 1 diabetes mellitus. This study is conducted during August 2019 to February 2020. 60 patients with diabetes, which were cases, were mainly recruited from pediatric and endocrinology department at the civil hospital, and 60 systemically healthy children, which were controlled, were mainly recruited from pedodontic department at the Government Dental College and Hospital Ahmedabad. Inclusion criteria are: children must be 4 to 14 years age, ability to undergo dental examination. For control group, systemically healthy children. For case group, type 1 diabetes mellitus already established at the time of study. Exclusion criteria: history of recent systemic antibiotic therapy and orthodontic appliance. All participants and their guardians were informed about the aim of the study and its voluntary nature. All the diabetic patients had their glycosylated hemoglobin test 1 to 7 days prior to their medical visit. Diabetic history includes age of diagnosis, date of diagnosis, duration of diabetes, latest reading of HbA1c. Periodontal examination was based on 6 Ramford Index 3. Plaque index were recorded
according to Silnas and Lu, which is given in 1964. And gingival index were recorded according to Lu and Silnas, given in 1963. Results. Table 1 shows socio-demographic characteristic and diabetic history. Table 2 shows dental history and oral hygiene practice in children with type 1 diabetes mellitus and the systemically healthy children. Table 3 shows clinical findings and periodontal characteristics between the type 1 diabetes children with type 1 diabetes mellitus and the systemically healthy children. Table 1 shows periodontal findings for diabetic children according to diabetic history, which shows diabetic duration and HbA1c level. Discussion. In this study, by comparing children with diabetes to systemically healthy children, demonstrated that diabetes significantly increases the risk for periodontal destruction earlier. There's no statistical difference was found between the diabetic patient controls with regards to gender distribution. Statistical difference was found between the last dental visit and the brushing frequency. There is also a significant difference were found at the first dental visit, which had a group never visited the dentist before. Children with diabetes had significantly higher plaque index and a higher gingival index. This statement is supported by Salvi et al. In 2005 and Smythe, McGull and Ewing in 2015. Poorly glycemic control in diabetic patients had a significant effect on increasing the mean plaque index and gingival index. This statement is supported by Lala et al. In 2007 and is not supported by the Chandal et al. In 1989. Longer diabetes duration and having been diagnosed with diabetes at an older age were the most significant variable associated with having periodontitis. Thorstensen and Hugoson in 1996 supported this statement. Diabetic children and their parents are unaware regarding knowledge about the effect of diabetes on periodontal health. Therefore, the attitude towards the importance of dental health and its integration within general healthcare system should be emphasized. Conclusion of the study. High prevalence of plaque accumulation and gingival inflammation in children with type 1 diabetes mellitus was more evident than in those without diabetes. This data showed that diabetes duration may play a significant role in progression of periodontal disease in diabetic children. These are my references. Thank you.
Participant is present or not?
I think she's not there. So we'll move to the next one.
Yes.
Good morning. My topic for paper presentation is the effect of brushing and flossing sequence on plaque control. Introduction. Periodontitis is an infectious disease resulting in inflammation of the supporting tissues of the tooth, progressive attachment loss, and alveolar bone loss. Definition itself gives the outline of the major clinical, etiological, and clinical manifestations of the disease, which are microbial plaque accumulation, periodontal inflammation, and progressive attachment loss along with alveolar bone loss. Periodontitis is one of the most prevalent diseases in the oral cavity. It is initiated by the pathogenic bacteria in the dental plaque. Dental biofilm formation is the main culprit for the pathogenesis and progression of the periodontal diseases. So that effective plaque control is crucial in controlling the periodontal disease pathogenesis and progression. Plaque control is the regular removal of the dental plaque and prevention of its accumulation on the tooth surfaces and on the gingival surfaces. Plaque control is achieved by two methods: mechanical plaque control and chemical plaque control. Among them, mechanical plaque control is the most widely and most commonly used method. Mechanical plaque control is commonly done by dentifrices along with toothbrushes. Dentifrices are the substances which helps in cleaning and polishing of the tooth surfaces. Dentifrices are available in form of paste, gels, and powders. Dentifrices increases the effectiveness of brushing, but they cause minimal abrasion to the root surfaces. Commonly, soft nylon bristle toothbrush is advised to the patient. There are different types of toothbrushes are available: manual toothbrushes and powered toothbrushes. Powered toothbrushes are indicated in patients who are unable to perform the brushing by their own. In that patients, we commonly advise power toothbrushes. And in some patients who are undergoing orthodontic treatment, in that cases also we advise power toothbrushes. And some interdental cleansing aids are also used for proper cleaning of the tooth, such as dental floss, interdental brushes, and plastic and wooden picks. And mechanical plaque control along with oral hygiene instructions are considered as the first step in the periodontal treatment. Chemical plaque control. In this method, chemical substances such as prescribed 0.2% chlorhexidine modulenses and unprescribed essential oils and some other substances such as triclosan are used. Chemical substances are very effective in plaque control along with wound healing in the periodontal surgery in patients who underwent periodontal surgery. There are various methods of there are various methods are described for the brushing of the tooth based on their effect and effectiveness, and also on the and they are categorized into the following types based on their motions when brushing is done. In the rolling motion, roll method or modified Stillman technique. In vibratory motion techniques, Stillman technique, Charters technique, and Bars techniques. In vertical motion, Leonard technique. In circular motion, Fons technique. In horizontal motion, scrub technique. Among them, scrub technique is the most easiest technique and most commonly used technique for adults and also child. But dentists advise the circular motion technique or Fons technique for the pediatric patients. The patients who underwent the periodontal surgery, they are generally advised the circular brushing technique, in which the bristles of the toothbrush are placed 45 degrees to the axis of the tooth, and the brush covers the 3 teeth at a time, and it moves in forth and back motions regularly, so that it takes time to cover all the teeth. Interdental cleaning aids. Any toothbrush, irrespective of their brushing technique, does not enter into the interdental and proximal areas, so that There are many tools are available for cleaning the interproximal areas. Interproximal areas are the mm, most commonly involved for the plaque accumulation and calculus deposits. So that the cleaning of the interproximal areas is very important in maintaining the periodontal health. So that there are various tools are available such as dental floss, interdental toothbrushes, wooden and plastic tips. Among them, dental floss is most commonly used interdental cleaning aid, which use when dental floss is hold in between the two index fingers of the hands with the 12 to 18 inches in length, which is sufficient for any patient. After holding the floss in between the two index fingers of the teeth, floss moves into the proximal areas, and it moves into the back and forth motions. Interdental toothbrushes are advised in patients. Interdental brushes are advised in orthodontic patients and patients who are not unable to perform in posterior regions where dental flossing is very difficult for doing. And sometimes wooden and plastic tips are also used. Some studies showed that a study conducted by Parvez Toxban et al. In 2012 conducted a study to compare the efficacy of brushing and flossing sequence on plaque control and gingival inflammation. They showed that flossing followed by brushing is more effective when compared to brushing and flossing on the plaque control. And there is no
Dr. Rahman,
Sir,
it was a bit lengthy presentation. I think it should be cut short, and it should, while presenting, it should be up to point of what you are going to present.
Yes, sir.
Actually, okay. Now, what are the various concentrations of chlorhexidine you are aware with?
So 0.01%, 0.012%, 0.0.
No. Which main two concentration of which main two concentrations of chlorhexidine are available?
So we are generally using 0.12% chlorhexidine mouthwash.
0.2% and 0.12% of chlorhexidine mouthwash are available concentrations. Okay. Which is more effective, 0.12% or 0.2%? Can you tell?
0.12%.
More effective.
0.12%, sir.
Why? So, majority of the mouthwash in India are available in 0.2% concentration. Okay, fine. Over to you, Dr. Kamal. Okay, thank you.
Good morning, everyone. Just as every individual are unique in their own way, fingerprints and lip prints are unique to them. Similarly, some studies have shown that Ruge pattern is also unique in individuals. Hence, this unique Ruge pattern led to interest in development of rugoscopy. The present study is about rugoscopy in periodontics and aid to periodontal disease evaluation. Palatal rugae is also called as plica palatine transverse and rugae palatine. The palatal rugae is present in the anterior third of the palate on either side of median palatine raphe behind the incisive papillae. Carey in 1937 demonstrated that development of palatal rugae occurs in 12th to 14th week of prenatal life and remains constant throughout the life. The anatomical position of rugae inside the mouth is surrounded by cheeks, lips, tongue, buccal pad of fat, teeth, and bones. All these structures protect the rugae pattern from high temperatures and trauma. Histopathologically, the rugae are stratified squamous parakeratinized epithelium on a connective tissue base similar to the adjacent tissue of the palate. Periodontitis is a multifactorial disease caused by specific oral pathogens and their metabolic products. It can also occur due to environmental factors as well as due to genetic susceptibility of the individuals. Myclovis et al. In 1991 conducted studies on dizygous twins and monozygous twins and reinforced that genetics seem to form the basis for familial aggregation of periodontitis. Whereas Hazel in 1995 conducted similar studies and finally reinforced that aggregation of chronic form of periodontitis in families strongly suggests genetic predisposition. The ectodermal layer helps in the development of skin ridges and different layers of the teeth, and any disturbances caused in the development of ectodermal layer leads to disturbances in the skin ridges and anomalies of the teeth, thus creating a link between dermatoglyphics and anomalies of the teeth. The main aim of this study is to evaluate the different rugae patterns in individuals with gingivitis, localized periodontitis, and chronic generalized periodontitis, and in completely edentulous and orthodontically treated individuals. A total of 175 individuals with an age group of 20 to 60 years were categorized into 5 types based on the diagnosis. The categories are gingivitis, localized periodontitis, generalized periodontitis, completely edentulous, and orthodontically treated individuals. Each group contains 35 sample size. Maxillary impressions were made using the alginate, and dental stone of type 3 were used for pouring the maxillary casts. The rugae pattern on the casts are seen as elevated impressions, which were marked using a fine lead pencil. The shape analysis of the rugae was done. Different authors have given different types of rugae pattern classifications. The first classification was given by Goria in 1911, which is based on number of rugae and extent of rugae. Lysel in 1955 had categorized based upon the length of the rugae pattern into primary, which is greater than or equal to 5 millimeters in length, and secondary, which is of 3 to 5 millimeters in length, fragmentary, which is of 2 to 3 millimeters in length. According to Lysel, less than 2 millimeters of length of rugae pattern is disregarded. Bossori have classified into simple and compound. Lima have categorized into punctate, straight, curved, and composite. Drogo have classified based upon the shape, number, size, and position. In the present study, shape analysis of the rugae pattern was done by the Drobo classification. According to Drobo, he categorized into 5 types: A, B, C, D, and E. A is of point type, B is of line type, C is of curved type, D is of angle type, and E is of sinuous type. The shape analysis of the rugae pattern was done and data collected was subjected to statistical analysis. The data was entered in MS Excel sheet and analyzed in SPSS V24 format. Descriptive statistics were represented with frequency with a percentage and calculated using chi-square test. Present study investigated the difference in the shape of rugae pattern in 175 stone models, and the results obtained are in line type of rugae pattern, they are predominantly observed in orthodontically treated individuals followed by generalized periodontitis, whereas the sinuous type of pattern is observed in predominantly in orthodontically treated individuals followed by gingivitis, and the point type is predominantly observed in gingivitis followed by localized periodontitis. Curved type is predominantly observed in completely edentulous individuals followed by orthodontically treated individuals. The angular pattern is very less prominently seen, of which only 2% of individuals and gingivitis and generalized periodontitis showed the angular pattern. And finally, the obtained results shows that gingivitis and localized periodontitis have a predominant rugae pattern of cineous type followed by line type, whereas the generalized periodontitis and completely edentulous individual shows a predominant rugae pattern of line type followed by cineous type, whereas the orthodontically treated individuals shows equal amount of line type and cineous type followed by curved type. My study hereby concludes that rugae pattern is unique in every individual and remains constant throughout the life. The rugoscopy could be used with other diagnostic methods like clinical and radiographic investigations in identifying the patients with periodontal diseases. Early detection can lead to early prevention in the disease progression. Individuals having similar frequency of rugae pattern as that of the individuals with chronic periodontitis can be susceptible to disease in the future and can take preventive measurements. Based on all these information, the rugae pattern can act as prognostic and diagnostic tools in evaluation and management of periodontal diseases and conditions. Thank you.
Okay. Nice study, relatively new study. So, any other studies done on the rugae pattern?
So, rugae pattern, other studies have done on orthodontically treated individuals before the treatment and after the treatment, if there any changes occurred due to the tooth migration. And in periodontitis also they have done, sir.
They have done. Okay. Have you differentiate the patient into male and females?
Yes, sir, I have differentiated, sir, but equal number of patients are not obtained, sir. So I have taken the sample as only one group, sir.
Okay. Any difference in the rugae pattern between male and female patients?
Sir, length of the rugae pattern there is difference, sir. And again,
It may lead to bias in the study.
what, sir?
It may lead to some errors in the study if there is some difference in the rugae pattern of male and female patients.
Yes, sir. It may lead to bias in the studies. But in my study, I have not taken the length of rugae pattern, sir. I have seen only shapes, sir.
Only shapes of rugae. Yeah. Okay. Over to you, Dr. Kamal. Your mic is. Please unmute your mic, Dr. Kamal.
Yeah, can you hear me?
Yes, sir.
Yeah, Dr. Akila.
Yes, sir.
What are the other factors which affects the rugae pattern other than periodontitis?
Any surgery or to the palate, there will be difference in the rugae patterns of before and after.
Okay.
If the patient is having a cleft lip or palate, there will be changes in the rugae pattern, sir.
Okay.
Any trauma to the maxilla also, there will be changes in the rugae patterns. After tooth extraction also, some studies have shown that there is difference in the rugae patterns, sir.
So, thank you. Nice presentation.
Okay. Do you know any other study? Yeah. Do you know any other study regarding the large sample size conducted?
Hello everyone. This is Dr. Atul Parasa, second year BG student from Government
Okay.
Intern College.
Let it be. Thank you.
Today, I will be sharing my study that is on comparative evaluation of alveolar bone defect pattern in patients with diabetes mellitus versus non-diabetic patients having chronic periodontitis. So, periodontal disease is a bacterial-induced chronic inflammatory disease, whereas diabetes mellitus, it is an endocrinal disorder, which is characterized by high plasma glucose level. The relationship between these two is bidirectional, and it is well established, like by Hugioson et al. And Taylor et al. These are some studies which signifies that. So hallmark of periodontal disease is the loss of clinical attachment level and loss of the alveolar bone, whereas various pattern of alveolar bone loss has been identified. So they can be classified like horizontal or vertical bone loss, percussion involvement, ledges or craters. So radiographic examination, it is of great importance in obtaining and detecting the amount of the alveolar bone destruction due to the periodontitis. So aim of my study is to evaluate and compare the pattern of the alveolar bone loss between diabetic and non-diabetic individuals having chronic periodontitis. My study, I have done a cross-sectional comparative study among the diabetic and non-diabetic individuals who are attending the OPD of our department. So ethical clearance was obtained, and I have selected the 50 diabetic and 50 non-diabetic individuals with age range of around 35 to 74 years who are diagnosed with chronic generalized periodontitis, and they were examined and then they are radiographically evaluated. So I have divided my samples into two, group 1 and group 2. Group 1 involves the patient with chronic generalized periodontitis having diabetes mellitus. Group 2 includes the patients without diabetes mellitus. Then their various radiographs will be they were collected for the evaluation. Horizontal bone loss, I have measured it if it is greater than 2 mm from the cement-enamel junction. Vertical bone defect is recorded till the most apical portion of the defect, and it involving the mesodistal portion of the root surface. Percussion radiolucency was noted. So these are the radiographs from my samples. Like this is the this is OPG of a diabetic patient with chronic generalized periodontitis, showing the vertical bone loss and percussion involvement in maxillary and mandibular arch. This is the radiograph of a non-diabetic patient with chronic generalized periodontitis, which shows the maxillary first molar with having a percussion involvement and vertical bone loss in mandibular molar. So inclusion criteria involves the references point in radiographs like cement-enamel junction, alveolar bone crest, and root apex. For diabetic patient must be diagnosed with diabetes mellitus and it should not have any other underlying medical illness. For non-diabetic patients, no symptoms of diabetes or RBS should be less than 200 milligram per deciliter. Exclusion criteria for the study include the patient with poor oral hygiene, having a patient is smoker or alcoholic, a pregnant or lactating mother, or patient having any other medical condition than diabetes mellitus, or there is a proximal overlapping, or if any crowding of the teeth is present, or which can hinder the CEJ location detection. So in the interior area, if there is any technical blurring or there is a superimposition of any natural anatomical landmarks, these are excluded from the study. So after evaluating the number of teeth with a specific pattern of the bone loss, and these were then tabulated. So mean value and standard deviation was calculated. These mean value were compared between the study group using the standard using a student independent t-test. So in this study, I have set the level of significance or the p-value less than 0.05. So in this chart, when all the we can from this chart we can appreciate the level or the involvement of the bone loss in maxillary and mandibular arch of a diabetic as well as a non-diabetic patient. So we can see that the horizontal bone loss, it is more in a diabetic patient than a non-diabetic patient. If we compare it among the two groups, then vertical bone loss, it is also involved. The diabetic patient has more vertical bone loss than a non-diabetic patient. Percussion involvement is found to be more in teeth of the diabetic patient than the non-diabetic patient. Then if you compare it arch-wise within the group, then diabetic patient in mandibular is found to be having more horizontal bone loss than a maxillary arch. Vertical bone loss is found to be more in mandibular arch for the diabetic patient than non-diabetic patient. And if we consider it diabetic among non-diabetic, then diabetic patient found to have more vertical and horizontal bone loss than a non-diabetic patient. Here, vertical bone loss, we can see that it is p-value in spite of mandible is being more involved than maxilla, but the significance is less. So periodontitis is referred to as the sixth complication of the diabetes mellitus. Similarly, a person having diabetes mellitus, it is found to be 2.9 times more for developing a periodontitis. So there is a considerable amount of evidences which indicate that the metabolic and endocrine alteration which is caused by a metabolic by the diabetic or diabetes, it affects the bone quality as well as the quantity. Thus, alveolar bone loss is due to periodontitis expected to be more increase in diabetic patient. So result of the present study, it shows statistically significant increased alveolar bone loss in diabetic patient as compared to non-diabetic one. The finding is in accordance with the Turvonen T et al. In 2000 study by Turvonen T et al. In 2000, indicating that more bone loss in diabetes mellitus is there. Animal study was done by Kim DS et al. Who concluded the same. So in our study, it was found that horizontal and vertical osseous defect, they are more in mandible than in maxilla, but statistically they are insignificant. So Richard, in the similar finding, he found that intrabony defect, they are frequent, but in the posterior region it is more frequent. In the present study, maxillary molars, they show a more significant or higher percussion involvement than mandibular molars radiographically, which is in accordance with the study by Wenstrom et al. In 1996. In our study, horizontal type of bone loss was common than vertical bone loss, and the Jayakumar et al. 2017, he has done a study which also concluded the same, that the prevalence of horizontal type of bone loss is more in a periodontitis patient. So concluding my presentation, periodontal disease, it is a more frequent in diabetic mellitus patient with more severity, and alveolar bone loss being an indicator of the periodontitis, it is found to be more prevalent in a diabetic patient. Horizontal osseous defect, it is found to be more common than a vertical alveolar bone defect or percussion involvement. Alveolar bone defect is found to be more prevalent in mandibular arch than maxillary arch. These are some of my references. Thank you so much.
Dr. Atul is present.
Sir, if Atul is not there, we can shift to Dr. Rakia Ansari.
He is
She
present.
was
I
not
think.
there because of some technical problem.
Hello.
So can we take her questions?
Okay,
Hello.
Dr. Atul. Yes.
Yeah,
Sorry for the inconvenience, sir.
Why there is more significant amount of bone loss in diabetes? Any specific reason behind it? What happens in
Sir,
diabetes?
okay, sir. Sir, in diabetes, actually, because of the higher sugar level or higher plasma glucose, there is a more amount of superoxide and oxygen radicals. Even and because of also there is means during when patient is having high sugar level. So what happens is that a patient is more prone to have more amount of aglycated products which isn't in the and which is lead to the osteoblast apoptosis. So there will be means osteoclastic what we can say activation of the osteoclast will be more, so and osteoblast apoptosis will be more due to MAP kinase pathways that will be present because of the higher sugar level.
Okay, have you excluded the patients with trauma from occlusion because one of the factors it may lead to angular bone loss? As you know,
Yes,
PFO
sir.
leads to angular bone loss. So have you excluded such patients? Because you
Yes,
haven't
sir.
written it in exclusion criteria.
Oh, okay, sir. No, sir. I have excluded those because even some other systemic condition they have been excluded too. Otherwise, they can interfere with the vertical bone loss and horizontal bone loss present in the patient. So I have taken secretly those patients only with a particular diabetes mellitus having history of diabetes mellitus.
Okay, thank you.
Thank you.
Okay, Dr. Atul,
Yes, sir.
have you excluded the patient with uncontrolled diabetes?
Means no, I have not excluded those uncontrolled diabetes. I have just considered that patient who are having who must be a diabetic patient before at least 3 months of my study.
See, whether the diabetes is controlled or not will affect the effect on periodontitis.
Yes, sir.
Right. So
Yes, sir.
if you have not excluded that uncontrolled diabetic patient, so it might affect the result of your study.
Okay, sir.
And what is the normal blood sugar level?
So normal blood sugar level, sir. Actually, I have taken the HbA1c as my consideration for the diabetic, so
Okay.
that I can. So I
Okay.
have considered. Yes, sir.
Okay,
Thank
any
you.
idea about fructosamine test, Dr. Atul?
Sir?
Fructosamine test.
No, sir. Sorry.
Okay, okay, thank you.
Thank you, sir.
As I said, there is a participant, Dr. Rakia Ansari. She has not done with the question and answer. So can we take the question and answer session? There is some technical problem. Dhaval sir, can you hear me?
Yes, yes, Dr. Girish.
Can we take question and answer session for Dr. Rakia?
Yes,
Because of some
yes.
technical problem, she was not there. Yes, Dr. Rakia.
Yes, sir.
The
She is the
topic
second
was
presenter to it.
yes, parental health of children with type 1
Type 1
diabetes mellitus.
Yes, sir.
Okay, what was the age group?
4 to 14 years, sir.
4 to 14 years. Okay, and how this diabetes mellitus will affect the periodontal health in children?
Sir, in a poor controlled diabetes mellitus, the glucose level are increased. So because of this, the glucose alter the extracellular and intracellular proteins in the and form the glycosylated advanced glycosylated end products (AGEs), and these AGEs are responsible for destruction of tissues.
That happens in normal individuals also. So what is the exclusive to children? Glycation end products are formed in normal individuals also.
Yes, sir.
Okay, in diabetes. So what is so specific about children?
Sir, in this study, my main object is, sir.
Any particular aspect which is more significant in children as compared to adults when you are checking the patients with type 1 diabetes? Any particular aspect?
No, sir. It only because there is no awareness in the patients who are having children with type 1 diabetes mellitus that diabetes can affect the periodontitis or periodontal health. So my survey is based on this. Okay, that the patients awareness. We are because it's an observational survey, and we are also explaining the patients or parents or guardians about the nature of this disease, how it affects the periodontal health or oral health.
What was your sample size?
So 60 because of 60 control and 60 cases because of COVID started in March 2020. So I have to stop my study.
Because it is very less considering the study. Your
Yes, sir.
study.
Yes, sir.
Okay, okay. Over to you, Dr. Kumar.
Yeah, doctor, what advice you will give to the patients, parents, what care they should take based on your study result?
So first of all, we are explaining the patient how it parents how it affects the periodontal health or oral health. Then we have to ask the patient to give us a follow up every 3 to 6 months, so we can check the or diagnose the oral condition. According to that, if they are maintaining their oral health and the HbA1c level is controlled, so there is we can prevent the major destruction in the future.
Okay, thank you.
Oh, sorry. Thank you, sir.
Thank you so much, Dr. Kamal sir and Dr. Dhamini sir, for your valuable time.
Thank you, Dr. Girish.
We extend
Thank you.
great
Thank you,
regards from Scientific Committee 19th PG Convention, and I declare that the session ends for session 3 and session 4 here. Thank you so much, sir.
Okay. Thank you. My pleasure.
Thank you.
To all
Thank
the
you.
participants and delegates, the hall A. Soon starting with session 5 and session 6. Very good afternoon to all. I, Dr. Girish Vidare, welcome you all for this scientific session, 19th ISP PG convention. Very good afternoon, Dr. Roshni ma'am and Dr. Himanshu sir. For this session, we have Dr. Himanshu sir as a chairperson. Dr. Himanshu sir is a native of Delhi and has graduated from Pune University and completed his master's in periodontics from Bapuji Dental College Hospital, Davangere in 2005. He is a certified fellow laser specialist from WCLI and has a keen interest in regenerative periodontics, local drug delivery system, and periaesthetics. He is currently working at Kalka Dental College, Meerut, as professor periodontology for the last 6 years and has a number of national and international publications to his credit, with an H index of 7, with more than 210 citations on Google Scholar. He is an executive member of Indian Society of Periodontology since 2014. We welcome you, sir, for this session. Next chairperson for our session, for this session, is Dr. Roshni Thakur ma'am. She has done her BDS and MDS in periodontology from Government Dental College Hospital, Mumbai. She has completed her master's in laser dentistry from Vienna, Austria. She has done PG diploma in hospital administration. She is currently a vice dean and head of the department at Saraswati Dhanvantri Dental College, Maharashtra. She has several publications in various national and international journals. Prestigious awards to her credit includes Best IDA Member by IDA Branch, Pune in 2007, Best Student Award and Best Sportsperson Award in 1993. Winner of Maharashtra Badminton State Championship in 1993, 94, 95, 96, which exhibits the academic excellence and remarkable active extracurricular interest. We welcome you, ma'am, for this scientific session.
Thank you, Dr. Girish.
So I will hand over the proceedings to both of you, and Dr. Himanshu, sir.
Can you hear me?
Yes, ma'am. Yes, ma'am. Himanshu, sir. I think.
Can you hear me now, Dr. Girish?
Yes, ma'am. Yes, ma'am.
Yes, yes.
You're audible.
So good afternoon, and thank you so much for your kind introduction. And our co-chairperson, Dr.
It's locked in, but now.
Dr. Himanshu, right?
Yes.
Okay. So we'll
some,
just wait for him to join, and then we have the first presenter who could be ready. This is Dr. Divya Lakshmi, right?
Yes.
Okay.
Good morning, everybody. Today, I would like to present a paper on the topic correlation between salivary pH and tissue glycogen in gingivitis and chronic periodontitis patients, a histopathological study. Gingiva is defined as that part of the oral mucosa that covers the alveolar processes of the jaws and surrounds the necks of the teeth. And the inflammation of the gingiva is known as gingivitis. Periodontitis is defined as inflammatory disease of the supporting tissues of the teeth caused by specific microorganisms or group of microbes, resulting in progressive destruction of periodontal ligament and alveolar bone with periodontal pocket or gingival recession, or sometimes both. The disease is characterized by loss of clinical attachment level due to the destruction of the periodontal ligament and loss of adjacent alveolar bone. The role of bacterial putrefactive process in the etiology of periodontitis has been discussed in many studies. To explore such possibilities further, investigation relationship between saliva and the adjacent pocket tissue on a chemical basis is essential. Glycogen is the storage form of the glucose in mammalian cells and is normal reservoir for most of the tissues. Glycogen is very large branched polymer of glucose that can be broken down to yield glucose whenever energy is required. Most of the glucose residues in the glycogen are held by alpha-1,4 glycosidic bonds. Any changes in the constituents of the tissue glycogen gives an insight of the metabolic activities within the cells. Saliva acts as a diagnostic fluid, and there are many studies in support of this fact. Here, salivary pH is determined as a biologic marker for inflammatory process. Therefore, salivary pH and tissue glycogen level can be correlated. Hence, the aim of the study is to compare the tissue glycogen level and the pH of the saliva in both gingivitis and chronic periodontitis patients. Materials and methods. A total of 20 patients were selected, of which 10 was diagnosed with periodontitis and 10 were diagnosed with gingivitis. The procedure was explained to all the patients and an informed consent was taken from all the participants before the procedure. The inclusion criteria for chronic generalized periodontitis are patients with poor oral hygiene, patients having a pocket depth of greater than 5 mm for at least 8 teeth, and the selection criteria for gingivitis is patients having gingival index score greater than or equal to 2 and plaque index score greater than or equal to 2. The exclusion criteria are patients with any systemic diseases, patients who have the habit of smoking, pregnant and lactating women, and diabetic patients. The basic armamentarium for the examination of the patient. The basic armamentarium for collection of the saliva, which includes saliva collection jar and salivary pH meter. The basic armamentarium for taking tissue biopsy, which include number 15 size blade, BP handle, local anesthesia, and a syringe. For the collection of the unstimulated saliva, the patients were asked to report early in the morning. Patients were asked to rinse their mouth, and after 5 minutes, they were asked to spit the whole amount of saliva. A total of 5 ml of saliva was collected in a sterile 10 ml beaker. The pH of the saliva was immediately measured in order to avoid any deterioration of the sample. Salivary pH was measured with the help of a single electrode digital pH meter. For the collection of the biopsy sample, the deepest pocket of the mouth was selected. After giving LA, the interdental papilla involving the pocket epithelium is excised with number 15 blade. The tissue excised should be 2 into 2 mm in size. It is thoroughly rinsed in water to remove saliva as it contains salivary amylase, which breaks down the glycogen present in the tissue. It is later fixed in 10% formalin for 24 hours, and the sample was sent to histopathology staining. Postoperative precautions were taken at the biopsy site where bleeding was controlled and periodontal dressing was given, followed by medication for the next 3 days. Histopathology analysis, hematoxin, eosin, and periodic acid strip staining are done for the tissue after processing of the tissue into sections. Hematoxin, eosin examined the presence of absence of inflammation, and the periodic acid strip staining was used for the presence or absence of glycogen. The results conclude that the amount of glycogen in gingivitis is greater than the amount of glycogen in periodontitis, and that the salivary pH of the gingivitis patients is basic than the salivary pH of the periodontitis patients. When said in one word, it can be said that the pH of the saliva in gingivitis patients is basic and the tissue glycogen levels are high, and the pH of the saliva in periodontitis patients is acidic and the tissue glycogen levels are low. Discussion. Saliva has a normal pH of 6.2 to 7.6. A saliva pH of 7 usually indicates a healthy dental and periodontal situation. At neutral pH, there is low incidence of caries with little or no local factors such as plaque and calculus. If salivary pH falls below the 7, it indicates the incidence of caries, acidemia, and its teeth are susceptible to decay, halitosis, and periodontitis. A salivary pH of 7 usually indicates alkalinity. There are 2 key factors to induce the plaque formation. First, there must be presence of the oral bacteria to attack the food particles and to elevate the pH. Second, the pH must be elevated above 7.6 to grow for the dental plaque crystals, and this causes the periodontal tissue. Thus alkaline pH is essential for the plaque growth. As the gingival crevice deepens, the environmental factor in the subgingival plaque becomes stable, and that is neutral and anaerobic. According to Takahashi et al., they concluded in their study that the periodontopathogens grow in a mildly acidic pH. This is in accordance to our result of pH for chronic periodontitis patients. The present study is in correlation with Sharmila et al., in which they concluded that salivary pH in patients with gingivitis is more alkaline and pH is acidic in periodontitis patients. Glycogen is synthesized in the form of free glucose by glucose 6-phosphate and glucose 1-phosphate. Glycogen is stored in injured cells whenever the metabolism is impaired. According to Fouchers et al., it has been suggested that both putrefaction and glycolysis are mutually antagonistic processes. A depletion of tissue glycogen may predispose gingival tissues to periodontitis, and similarly, increase in the putrefaction may inhibit glycolytic process that dictates the amount of tissue glycogen in periodontitis patients. Within the limits, it can be concluded that whenever the pH is acidic, there is depletion of glycogen in gingival tissues, and when the salivary pH is basic, then the amount of glycogen increases in the gingival tissues. Thank you.
Okay, Dr. Divya, right?
Yes, ma'am. Right.
Thank you so much for your presentation.
Thank you, ma'am.
So, what new have you added? Why have you picked up this as a study topic, as a short study topic, or what new have you added to review of literature in this particular short-term study?
Ma'am, actually, every cell needs glycogen or glucose in some form or the other for the metabolism of the activity to occur. So it is more common and in a regular way where we can assess if any where the cells have undergone any injury or whether any malformation or any inactivity has occurred, because all the cells need the energy to function, and glucose or glycogen is the primary storage.
I got your point. Yes. Since we have dearth of time, 1 minute for me and 1 minute Dr. Himanshu will be asking you.
Sorry.
What I wanted to ask you is that what new have you? So this is already proven, right? That the pH is low in periodontitis. And
yes, ma'am.
So what new have you added, or why did you want to pick up this study? Anyways, over to you, Dr. Himanshu. We have just 1 minute to ask question. Unmute, please.
Dr. Divya, so finally the correlation was proved, and to what extent?
Sir, it was proved that the amount of glycogen in gingivitis is greater when compared to that of periodontitis patients.
Right. Okay.
And the acidic
what we have a take-home message regarding the patient studies?
As the severity of the inflammation increases, sir, the alkalinity or the alkalinity of the salivary pH decreases. So acidic pH is more in action. So which is in favor of the bacterial pathogens to act and destroy the tooth tissue. And compared to periodontitis patients, the gingivitis patients have more amount of the glycogen content, which gives a message that the inflammation content is more in gingivitis.
Okay, Dr. Divya, thank you so much. And we'll move on to the next presenter now. This is Dr. Lynette.
Thank you, ma'am.
Yes, please.
Dear respected judges, this is Dr. Lynette Fernandez. As we all know, in the current COVID-19 scenario, the most important factor involved in the spread are the aerosols. Hence, my topic for today is Don't Miss the Mist, Minimizing Aerosol and Splatter Contamination. So, what is aerosol and splatter? Mr. Kenny's colleague defined aerosols as having particle sizes less than 50 micrometers in diameter and splatter having a larger particle size greater than 50 micrometers. What are the sources of aerosol? That is the equipment, which is the coolant water, and the patient, which is the blood and the saliva, which when combined with aerosols forms bioaerosols. Bentley et al. Suggested factors which could influence the aerosol distribution. That is, the type of procedure where the high volume evacuation was used, the position of the tooth in the mouth, and the level of microorganisms. As we know, periodontitis has increased number of microorganisms, thereby increasing the risk of infection. Hence, Harrell and Molinari suggested protective measures for aerosols, which include use of pre-rinses, use of PPEs, and use of high volume evacuation devices, that is the HVEs. Why is it essential that we minimize aerosol contamination? As we know, recent evidence suggests that the saliva of an infected individual can contain the SARS-CoV-19 virus, and its viability in the aerosols is for a longer duration. Hence, if an infected person receives dental treatment due to the droplet and aerosol spread, it can cause transmission to the individual. Also, the Maury et al. Suggested that there are more than 38 types of microorganisms present in the aerosols which can cause various diseases like hepatitis B, HIV, SARS-CoV-2, etc., which can have a potential risk to the dentist as well as the dental hygienist. So we use the HVEs. What is the difference between the HVEs and the LVEs? That is the normal saliva ejector. As we can see, the HVEs have a larger diameter, that is more than 8 mm, and the AD recommends that the HVEs suck up to approximately 100 cubic feet of air per minute. Let's come to our study. What is the aim of our study? It is to compare the high volume evacuation device efficacy versus the low volume evacuation device efficacy on the amount, the duration, and the distance of aerosol and splatter contamination. How do we do this? We have materials, that is the fluorescent dye, filter paper, transparent grid, the LVE, the HVE, and the ultrasonic scaler. Resorcinol phthalate, fluorescent dye, 1 gram of it added to 1 liter of distilled water and attached to the pipeline. Study design, we have groups, HVE versus LVE. Ultrasonic scaling is performed. Values are compared immediately post scaling and 30 minutes after scaling. This is the study setting. Mannequin in a dental operatory, filter paper disc arranged at 4 o'clock, 6 o'clock, 8 o'clock position and at a distance of 1 feet to 6 feet. And also on the operator face shield, operator chest, assistant face shield, assistant chest. Mock ultrasonic scaling is performed using the dye for 15 minutes using the low volume evacuation device and using the high volume evacuation device. Results are obtained, which is the splatter contamination with the fluorescent dye observed on the filter paper, calculated under the grid as area per 1 centimeter square. We see the values, the amount post scaling where the maximum contamination is obtained. We find out that it is at the operator chest, assistant chest, 4 o'clock 1 feet and 6 o'clock 1 feet. Now we compare intergroup comparison values for the operator and assistant, whereby we see that the HVE has lower contamination values compared to the LVE, as well as the right side face shield of the operator has higher contamination and the left side face shield of the assistant has higher contamination values. We compare values at 4 o'clock, wherein we see as the distance increases, the HVE use has caused no aerosol contamination at 4 feet. Same with 6 o'clock, as the distance is increasing, HVE values are showing no contamination at a higher distance. Also at 8 o'clock, we can see HVE has lower values compared to LVE. Thereby, when we compare the HVE and LVE for the distance and the amount of contamination, it shows a statistically significant difference. For the time, when we see 30 minutes after scaling, we see the presence of the aerosol still in the operatory at 30 minutes. Yet, we see a statistically significant difference between the use of the HVE and the LVE. Discussion. We as periodontists should know that the ultrasonic scalers are the maximum source of contamination. Hence, we must take maximum precaution. Discussion. We realize the area of contamination in our study was maximum on the operator and the assistant, also supported by other studies. A systematic review by Johnson said it is the operator's head and the body. This all indicates that we need to wear protective gear to protect ourselves. According to the time, we realized that the aerosol cloud was present in the operatory up to 30 minutes, which was also suggested by Veena et al. We need to indicate that we need to have at least a minimum gap of 30 minutes between the two dental procedures and not be in a haste to discard our protective gear immediately. Distance, we realized that a contamination was up to 13 feet in our study. Kaur et al. Suggested 9 feet in their dental study. But we also come to the conclusion that lesser spread was present using the HVE, thereby necessitating the fact to use PPEs and HVEs. We have various studies which support the use of HVE, whereas we have various studies which say that the HVEs are not as effective. We have newer rates in the market now, which is the HEPA filters, the negative air pressure rooms, the extraoral suction devices, the acrylic chambers. Yet, we have a cheaper alternative to all this, and that is the HVE. The limitations of my study is that it is an in vitro study, thereby there is no plaque, calculus, saliva, blood, and microorganisms present. Hence, the exact estimation of the spread and contamination is limited. We conclude saying that in the era of the coronavirus, despite the fact that we know that the HVE are a potential benefit, very few people are using it. My study aims to reinforce the use of the HVE in particularly these situations. Thank you.
Thank you, Dr. Lynette, for your presentation. Thank you so much. Can you hear us?
Yes, ma'am.
Okay, okay. So one thing is that in the conclusion, so do you have a questionnaire or a survey which suggested that in this particular era, of course, the HV use is limited with dentists?
Ma'am, I had done a survey on a different project, like on the coronavirus situation, wherein it was there was a thing wherein the dentists had realized that now in the situation they will use it, but in the previous scenario they were not using it. So that was the thing.
So what is the concentration of the SARS COVID virus in the aerosol?
The studies are presented now that it remains viable up to 3 hours. In the 3 hours, the virus remains this thing, and it is around 100 nanoparticles, 100 nanometers. And, yeah, that is the particles of this thing.
And any studies? Studies, I'm sure you must have gone through that. Studies that kind of suggested aerosol contamination and occurrence of COVID virus, occurrence of COVID-19 amongst dentists. So what was the prevalence?
Ma'am, there is a study by Bang et al. In 2020, wherein he suggested that it is highly associated with the prevalence. It's like a high duration because of the presence of the aerosols. The aerosols cause the have the virus, and since the saliva contains the ACE receptor, which is a contributing factor for the presence of the virus, and saliva being associated with the dental locality in the maximum amounts, we had Wang et al. In 2020 suggested that it is highly prevalent.
Okay, over to you, Dr. Himanshu. I'm so sorry. I've just taken up the time. Doc, unmute, please.
We'll start with the next presentation now.
No, it's okay, Doc. Please, and we'll cover up one or two questions.
No worries.
Okay. Thank you so much. May we have the next presenter, please?
Presenting study on the effect of topical application of honey-based gel containing gingival officinale for non-surgical periodontal maintenance. The periodontium consists of investing and supporting tissue of the tooth. Also, periodontal ligament, cementum, and alveolar bone. Gingiva protects the underlying tissue and attachment apparatus. Coming to the periodontitis. Periodontitis is a chronic inflammatory disease which results in destruction of the supporting structure of the tooth. And the etiology is multifactorial, with the periodontal forming a major role in initiation and progression of the disease. Due to this multifactorial etiology and complex disease process, the herbal remedies have been sought to achieve a antimicrobial, antioxidant, antiseptic, and anti-inflammatory properties. Gingiva officinale has abundant, it has shown that an abundant constituent of phenolic and the terpene compounds. Phenolic, specifically glycerol and chevol and paradol, have an anti-inflammatory properties in this herbal medicine. Honey has been used since ancient time against the infectious disease caused by the microorganisms. However, some research shows that the effect of honey on the level of dental plaque and inflammation has been shown that antibacterial effect and its anti-inflammatory effect. Periodontal therapy includes both surgical and non-surgical therapy for the management of this process, and these various antimicrobial and chemotherapeutic agents such as chlorhexidine, other agents also been shown as effective for the management of this periodontal disease. But it has some local side effects which were associated with the unpleasantness, altered taste, and costly to the patient. One of the studies have shown this gingiva officinale as an adjunct for the mouthwash, but none of the literature have shown the combination of gingiva officinale and honey on the dental plaque level and gingival grades been used as a gel. Hence, the aim of my study is to compare the effectiveness of honey with the gingiva officinale extract on the dental plaque levels and the gingival gills with the chlorhexidine gel. The patients were divided into the two equal groups. 15 patients were there. In the test group, that is group 1, which has gingiva officinale and honey-based gel applied to the 15 side, and control group had even chlorhexidine gel for this application. We evaluated the clinical parameters for the full mouth gingival index, low and stillness, and plaque index were evaluated given by the stillness and low. Methodology of this preparation: the rhizomes were sun-dried for the 7 days, and after which they were washed with the tap and distilled water, and they were sliced into the uniform slice pieces using the sterile knife, and they were dried in micro oven at the 37 degrees Celsius for 24 hours. These dried pieces were crushed using the electric grinder to form a powder. We got 100 gram of ginger powder in this procedure, and the extract were obtained by oxalate extraction of 20 gram of ginger powder in 100 ml of 95% ethanol at 78 degrees Celsius using this oxalate apparatus. The honey ginger mixture were prepared by mixing 1 ml of ginger extract and 1 ml of honey extract, and they were diluted in 2 ml of distilled water to obtain honey ginger extract solution, which were from 50% of concentration. For both the groups, the SRP was done, and patient was instructed to wash the hand and apply a peanut amount of gel gently on the index finger with the index finger to the gums after regular brushing, and to leave it for 5 minutes before rinsing. They were also asked to refrain from all the other unassigned form of oral hygiene aids like dental floss, chewing gum, or oral rinses during the study. Results showed that the plaque index for baseline for group 1 was 0.23, whereas for group 2 it was 0.29. It was then increased for group 1 by on 7th day by 0.36, and for group 2 it was 0.37. However, the mean at the baseline was increased on the at the baseline was 0.30 for group 1 and 0.34 for group 2. Whereas on 7th day it was increased to 0 for group 1 it was 0.38 to 0.43 on the group 2. Coming to the discussion, Mary et al. Has conducted a study by using the polyherbal mouthwash containing hydroalcoholic extract of Gingiva officinale, Rosmarinus officinale, and Calendula officinale of 5%, which was effective in treatment of gingivitis. It was found that the efficacy was better than chlorhexidine mouthwash. They were evaluated at baseline, 7th day, and 14 days of the trial. Singhal et al. In 2018 stated that the honey-based mouthwash were divided in the 3 type of mouthwash having Manuka honey, raw honey, and chlorhexidine gel mouthwash. And these results showed a promising antimicrobial effect on dental caries, plaque, and gingival score as compared to the chlorhexidine mouthwash. They were evaluated at the baseline, 22nd day after the discontinuation of this mouthwash, and 28th day after means 1 week after the discontinuation of this mouthwash. Hence, to conclude the study, although the chlorhexidine gel is a gold standard in non-surgical periodontal maintenance, but this trial concluded
Okay, I think Dr. Rashmi. Yes. Dr. Rashmi, thank you so much for your presentation. Over to you, Dr. Himanshu, for the questions.
So for this particular type of ginger, studies have been conducted and also correlated to be helpful in the treatment of type 2 diabetes mellitus in patients having periodontal conditions. So could you possibly tell us the mechanism of action for that?
Yes, sir. There is a action of this is a 6-hydro dihydroshivon is there, which inhibit or you can say it as acts as a to reduce the activity of pro-inflammatory mediators, and the prostaglandin E2, which are responsible for the anti-inflammatory action of the potential of the.
Okay. Dr. Roshni, please.
Yes. So when you mentioned that it is the chlorhexidine gel, that was like the proven gold standard, you would have probably one more group of that. So you had 2 groups, right?
Yes, ma'am.
So one was.
But in a single patient.
So you had 2 quadrants in one patient, a split mouth study.
Not we cannot say that it is quadrant type of study. We can say it as a site specific study. Means it depends upon the site, which maybe or single or double or triple.
Oh, so you picked up cases of okay. So maybe you could have included the gold standard and then compared your novel gel system.
Yes, I have compared it in 2 groups.
You compared it with the chlorhexidine only, na? Yeah, okay.
Yes, ma'am.
Okay. Rashmi, thank you.
Thank you.
I, Dr. Vaibhavi Nandgaonkar, would like to present a paper on tetracycline-coated sutures, a suture for the future. These are the contents of my presentation. Starting with introduction, surgical site infection is considered to be the second most common nosocomial infection according to the data from CDC. According to the studies done in India, the prevalence of surgical site infection ranges from 23% to 38%. Staphylococcus aureus is considered to be the most common pathogen, causing approximately 23% cases of surgical site infection. Suture material is considered to be one of the risk factors of surgical site infection. As it is foreign body at the wound site, it causes plaque accumulation since it is continuously bathed in saliva containing 7.5 into 10 raised to 8 microorganisms per ml. This results in continuous wicking of microorganisms around the suture, leading to pro-inflammatory response causing surgical site infections. To combat this problem, newer suture materials were developed to fight against surgical site infection, which is most commonly caused due to conventional non-coated sutures. These sutures are divided into 4 groups: antimicrobial sutures, drug-eluting sutures, stem cell-seeded sutures, and smart sutures. Giving emphasis on drug-eluting sutures, there are various advantages described by Greenberg et al. And Parekh et al. First is better wound healing and tissue regeneration capacity. Second, it has amplified drug loading and sustained drug delivery because of its porous nature. It also causes discharge of antimicrobial, anti-inflammatory, pain management drugs, cytokines, and extracellular matrix proteins as well, which are favorable for better wound healing. Lastly, the mechanical properties of these sutures are not at all compromised because of any amendment procedures. When we compare tetracycline with triclosan, we can obviously say that tetracycline has better efficacy to fight against surgical site infections as it is bacteriostatic, while triclosan can be bacteriostatic or bactericidal. Tetracycline acts by inhibiting protein synthesis. Triclosan acts by inhibiting Fab1 protein, which is responsible for cell viability of bacteria. Tetracycline is a broad spectrum antibiotic which has activity against all the microorganisms, including gram-positive as well as gram-negative, while triclosan has a specific target activity against E. coli according to McMurray et al. In 1998. But evidence also shows that triclosan has cross resistance with various antibiotics. It also shows potential selection of bacteria, and it can cause wound breakdown, which is seen in cases of breast reduction surgeries. Thus, the aim of this study is to evaluate and compare the efficacy of tetracycline-coated, triclosan-coated, and non-antibacterial coated sutures on bacterial load reduction to prevent surgical site infection. The methodology of this study includes the collection of fresh human saliva from 20 individuals. Then the sutures were divided into one of the 3 groups. After that, agar diffusion test was performed to calculate zone of inhibition. Patients with chronic periodontitis with pocket depth of more than 5 mm and age range between 18 to 45 years were included in this study. While the patients taking antibiotics for the past 3 months, smokers, immunocompromised patients, pregnant and lactating women were excluded from the study. The armamentarium required for preparing tetracycline-coated suture includes 1% sodium hydroxide, 2% acetic acid, 2 gram of sodium alginate, 8 gram of chitosan, and non-coated bifill suture. The laboratory procedure for the same includes as follows. First, the suture material was dipped into 1% sodium hydroxide for half an hour, followed by washing it by using distilled water. This process is called as scouring of the suture, which is a very important step in order to remove all the impurities present on the suture. Then the chitosan solution was prepared by mixing 8 gram of chitosan in 2% acetic acid and heating it at 60 degrees Celsius for 1 hour, followed by mixing it with 2 gram of sodium alginate powder and stirring it for 10 minutes. Then the suture material was dipped into the prepared polymer coating solution and then dried and cut into 20 pieces. The tetracycline solution was prepared by mixing 250 mg of tetracycline in 10 ml of distilled water, and then these polymer coated sutures were dipped into this solution for 24 hours, followed by drying at room temperature for 2 days. The collected saliva was then incubated on the agar plate at 37 degrees Celsius for 24 hours, and the agar diffusion test was then performed by using all the three types of sutures. The results showed that intergroup comparison of zone of inhibition is 14.45 mm, which is maximum in group 1. In group 2, it is 1.4 mm. In group 3, which is the control group, it is 0 mm. From this, we can easily predict that statistically highly significant difference was seen among all the 3 groups. As there is statistically highly significant difference seen for all the 3 groups, higher zone of inhibition was seen with respect to tetracycline coated sutures. All the research studies have its own pros and cons. Starting with the pros of these studies. First is tetracycline coated suture is having better antibacterial efficacy against salivary microflora to fight against the surgical site infection. As we have included chitosan in the polymer coating solution, it has its own antibacterial, anti-inflammatory, better wound healing and hemostatic properties. It is also a cost-effective procedure. The cons of these studies include microbial profile of the collected saliva was not checked, and physical characteristics as well as the drug release rate was not determined for the tetracycline coated suture. There are various RCTs and systematic reviews done on triclosan coated sutures. All of these studies have concluded that triclosan coated sutures significantly reduced the chance of surgical site infection when they are compared with conventional non-coated sutures. While only few in vitro studies have been done on tetracycline coated suture, which also showed that tetracycline coated suture is significantly reducing the chance of occurrence of surgical site infection. Till date, there is no study done to compare triclosan coated suture with tetracycline coated suture. So this study can be one of its own. I would like to conclude my session by saying tetracycline coated suture is a better alternative to triclosan coated suture due to its higher antibacterial efficacy against salivary microflora. But in vivo clinical trials should be done to evaluate the physical characteristics as well as antibacterial efficacy in periodontal surgeries. These are my references. Thank you so much for.
Okay, thank you, Dr. Vaibhavi.
Dr. Vaibhavi, you are live?
Yes, ma'am.
Thank you for your presentation. Yes, please.
So for these sutures to be clinically used, they need to be sterilized post these coatings. So all these coatings would be stable once they are used for after the sterilization, like with the ETO or any other mode.
Sir, actually the first FDA approved suture, which is triclosan coated suture, it is sterilized by using ETO, and it also has the antibacterial coating. And the various studies have shown that it has proved to be a better alternative than the non-coated suture in order to reduce the site infection. So I am not checked actually the sterilization of my suture. I will go ahead and I'll check, but I think and I hope that it will survive by sterilization also by using ETO and gamma radiation.
Right. Dr. Roshni, please.
Yes, Dr. Vaibhavi, would you want to continue this study to then have as an in vivo study where you could?
Yes, ma'am. Yes. So actually, this is just a first
Is it
step
your
I've started.
dissertation topic? Is it like a pilot study of your dissertation topic?
No, ma'am. This is not my dissertation. This is I've started as a short study only, but I really look forward to getting it ahead and putting in vivo clinical trials as well to evaluate the tetracycline coated suture if it is better than triclosan coated.
Thank you so much.
Thank you so much, ma'am.
We'll have the next presenter.
My name is Dr. Tanya Sanadit. Today, I shall be presenting a paper on evaluation of glycolated hemoglobin levels in patients with chronic periodontitis. The oral cavity is considered to be as an open window of the body. Many bodily disturbances are first observed in the oral cavity. Systemic health of an individual plays a vital role in not only other parts of the body but also the oral cavity, as they may have a negative impact on them. Diabetes mellitus, which is a metabolic disorder which leads to impairment in regulation of insulin, is one such kind of systemic diseases which may in turn cause host barrier function impairment and immune defense response to be impaired against periopathogen, which thereby may create an opportunity for the destructive periodontal diseases progression. Diabetes is classified as either type 1, which is insulin dependent, or type 2, which is non-insulin dependent. In the year 1996, Orphan Banger brought out the concept of periomedicine, which is a relationship between systemic diseases and periodontal health and disease. So various studies were conducted in the late 1990s with Pima Indians to prove a two-way relationship between diabetes and periodontal diseases, and health were successful in establishing so. Diabetes may cause impairment in the periodontium by the following proposed mechanism by Ray and Aubin in 1950, where they stated that there is degeneration of tissues and the presence of calcified bodies in and around small vessels in the gingiva, which may cause the basic structural changes, which may which is all this phenomena is known as the formation of diabetic periodontium. There is a decrease in level of CEMP. There's impairment of the PEM chemotaxis. There's decrease in antibodies production, and also there is an interference in bactericidal action in the blood. Also, prostaglandin level, that is mainly PGE, there has been an increase in that level, and such kind of changes which are present due to diabetes in the body may cause an increase in the periodontal disease progression. Likewise, periodontal disease, which is now considered as a sixth complication for diabetes, causes a dent in glycemic control, which results in the further worsening of the diabetic condition. Now, glycolated hemoglobin is a time-tested method in estimating these glycemic control in diabetic patients. Now, since as I've stated earlier, that there is an impairment of glycemic control caused due to periopathogens, there are various studies which have shown that HbA1c level, which is the glycolated hemoglobin levels, are increased in patients who are diabetic but or non-diabetic but have chronic periodontitis. So the aim of my study was also to evaluate the glycolated hemoglobin levels in systemically healthy individuals with chronic periodontitis. How we conducted this study is that we selected 40 patients from the OPD of our dental college who are fulfilling the inclusion criteria, which were patients with moderate to severe chronic periodontitis according to the AAP 1999 classification. Patients with no use of antibiotics or anti-inflammatory therapy in the past 6 months, patients with no history of oral antiseptic or mouthwash in the past 6 months, and also patients who had compliance and were willing to participate in the studies. And we excluded patients with the history of tobacco uses, which were either in the smoked or smokeless form, and patients with alcohol or substance abuses. Along with it, we also considered to keep patients who have undergone periodontal therapy in the past 6 months from the study. After we took a proper written consent from them, we classified these patients into 4 categories, where group A was patients who were diabetic with periodontitis. Group B were non-diabetic patients with periodontitis. Group C were diabetic individuals with chronic periodontitis, and Group D were healthy individuals. Once the patients were classified, a detailed case history was recorded. Clinical parameters such as plaque index, which is given by Stillness and Low in 1964, and Low and Stillness's gingival index of 1963, Russell's periodontal index, and Crockett probing depth were recorded. Blood samples were taken and sent to the pathology lab for HbA1c testing, which was estimated by turbic metric inhibition immunoassay. And the classification base of the diabetes, we enroll patients who have had type 2 diabetes. After statistical analysis, we concluded the following results. In case of plaque index, patients who had periodontitis, which were group A and group B, had slightly higher plaque index. With the similar results were seen for gingival, pocket probing depth, and Russell index. But when we observed patients for the glycolated hemoglobin level, it was statistically different for all 4 groups. Where group A and group C were diabetic patients, they had higher level of glycolated hemoglobin count, as their glycemic control was not appropriate. But group B, which was our main control group, we observed that the levels were not as low as group D, which were healthy individuals, but somewhere between 6.8, which is basically under the pre-diabetic lesions. So pre-diabetic levels. So what we have concluded with our study is that we have observed that glycolated hemoglobin levels in patients who have chronic periodontitis but are not diabetic were very close to the pre-diabetic level, which ranges between 5 to 7, and our levels were 6.8. So with limitations of the study due to less sample size collection, we would say that more studies are needed to assess if HbA1c can be identified as a risk indicator for not only diabetes but also patients with chronic periodontitis. Thank you.
Thank you, Dr. Tanya, for your presentation. Dr. Himanshu, you could ask.
Very good presentation. No questions from my side.
Okay. So what is the clinical implication of this study?
Ma'am, that we in this study we could conclude the fact that there is a loss of glycemic control in patients with chronic periodontitis, and also because of the levels that are present, we can see a relationship between the presence of it in diabetes as well as patients with periodontitis through
What would be the pathophysiology? Why do you think in chronic periodontitis, HbA1c levels would be elevated to a pre-diabetic level?
Ma'am, it's because periopathogens affect in such a manner that there is loss of glycemic control, as a result of which there is an inflammatory cascade, which is because of the loss of glycemic control, ma'am, due to the periopathogen.
Okay. Okay. Thank you so much, Dr. Tanya. We have the next presentation, please.
I would like to thank the organizing committee for selecting my scientific paper and giving me the opportunity to present. I am Major Prabhav Jain, second year resident at Army Dental Center Research and Referral, will be presenting a basic research paper titled Comparative Evaluation of Root Surface Biomodification on Extracted Tooth using Citric Acid, Erbium YAG laser, and Photodynamic Therapy, a field emission scanning electron microscopic study. The ultimate aim of periodontal therapy is regeneration of periodontal tissue lost by periodontal disease. Root biomodification is the therapy to form conducive root surface for formation of new connective tissue on denuded root surfaces. Various methods for root conditioning have been attempted. These include mechanical methods, chemical methods, growth factors, and lasers. Root biomodification altered the diseased root surface, creating a more acceptable surface that can influence events in wound healing. The aim of this study was to evaluate the surface morphological changes and presence of smear layer after irradiation with Erbium YAG laser, photodynamic therapy, and citric acid on extracted human tooth using field emission scanning electron microscopy. The null hypothesis was set. There is no impact of various modalities of root surface biomodification on the diameter of dental tubules and presence of smear layer. The objective of study was to evaluate and compare the diameter of dentinal tubules at electron microscopic level that occur by using citric acid, erbium YAG laser, and photodynamic therapy. To assess and compare the presence and absence of smear layer at electron microscopic level that occur by altering the root surface using citric acid, erbium YAG laser, and photodynamic therapy. 30 samples were evaluated in this study. Tooth loss due to chronic periodontitis were selected for the study. The root surface was mechanically treated by hand scaler to obtain a smooth, clean surface. Then segmental grooving was performed on radicular surface and divided into 3 equal parts, that is cervical 1/3, middle 1/3, and apical 1/3. Subsequently, roots were sectioned longitudinally using low-speed diamond burr under copious water irrigation. Randomization and blinding was done and divided into 4 groups. Group 1 treated by photodynamic therapy for 10 seconds and then rinsed with water. Group 2 treated by erbium YAG laser for 10 seconds in non-contact mode with copious irrigation. Group 3 was treated by citric acid of pH 1 for 2 minutes and then rinsed with water. Group C, another part of longitudinal section of tooth, has been taken as a control, divided into 3 segments. All these specimens in each group were treated with the respective root biomodifiers for respective time intervals, followed by washing with distilled water. Samples were prepared for FE-SEM. Specimens were mounted on stuffs by using conductive carbon tape. As the biological samples have a very low electron density, hence it will lead to absorption of the electron beam. So platinum powder coating was done for making specimen surface conductive. Specimens were transferred in electron microscope and high vacuum was created. A uniform electron microscope scanning has been performed at 5,000, 10,000, 25,000 and 50,000 resolution, and diameter of dentinal tubules was evaluated. Following images of group 1 that is treated by photodynamic therapy were achieved. Image at 5,000, 10,000, 25,000 and 50,000, and smear layer and the diameter of dentinal tubules were assessed. Similarly, in image 2, in group 2 that is treated by erbium YAG laser were achieved. Image at various resolution 5,000, 10,000, 25,000, 50,000. The diameter of dentinal tubules and the smear layer were assessed. In image of group 3 that is treated by citric acid were achieved. Various resolution, the images were taken. In group C, that is control, various images were achieved at various resolutions. Statistical analysis were done by using Systate 13 software for both the parameters. Non-parametric test, that is Kolmogorov-Smirnov test, was performed. P-values for presence of smear layer for all the 3 biomodifiers were more than 0.05. That is, test is statistically not significant. Comparative graphs were plotted in between all the 3 biomodifiers and control groups. Graphical representation of mean diameter of dentinal tubule show skewed distribution. To assess the normality of simple distribution, the normalized graphical representation was adopted. It shows a positive skewed because of a small sample size. To reduce the outlier effect, a post-hoc analysis using Lellefer's probability criteria were executed. P-values for photodynamic therapy and erbium YAG laser is less than 0.05. That is, test is statistically significant. The results were a statistically significant change in the diameter of dentinal tubules using photodynamic therapy and erbium YAG laser was obtained. However, removal of smear layer was statistically not significant in any of group, but a maximum amount of smear layer removal seen in erbium YAG group. Erbium YAG has a greater effect on dentinal tubules, followed by photodynamic therapy and thereafter citric acid. Periodontitis produces substantial alteration on the root surface. These alteration on root surface includes contamination of root surface by bacteria and endotoxins, alteration in the mineral density and composition. Also, the pathologically exposed root surface may lack the necessary chemotactic stimuli for migration of cells capable of producing periodontal regeneration. Studies has been done by various authors and concluded that biomodification of root surface is having potential to promote new attachment. Similarly, a substantial change in the root surface morphology was seen in electron microscope treated by erbium YAG and photodynamic therapy. A skewed distribution was seen when the diameters of dentinal tubules were compared. Samples treated by erbium YAG having greater effect on dentinal tubules, followed by photodynamic therapy and thereafter citric acid. However, removal of smear layer was statistically not significant in any of group, but maximum amount of small layer removal seen in erbium YAG group. Similar effect was seen by Yamaguchi when samples were treated by erbium YAG. To conclude, the erbium YAG and photodynamic therapy alter the disease root surface, creating a more acceptable surface that can influence events in wound healing. The present study was conducted on a smaller sample size. Further studies with larger sample size and histological studies to be carried out to substantiate the current findings. These are my references. I would like to acknowledge Commandant ADC R&R, the Faculty Department of Periodontology, Army Dental Center R&R, Dr. Pankaj Srivastava, Head of Central Research Facility, IIT Delhi, Mrs. Kumud Arora, Senior Project Scientist, Central Research Facility, IIT Delhi, and my colleagues and PG residents. Thank you.
Thank you, Major Prabha, for your presentation. Can you hear us?
Please unmute Prabhu Jain. Yes.
You hear us, Prabha? Okay. Are you there, Major Prabha? No, he's not able to hear us, right? You're the next presenter.
At the outset, I must thank the organizing committee for providing me an opportunity to present my paper on basic research on this forum. The topic for my research is comparative ex vivo evaluation of the expression of vascular endothelial growth factor in LPRF, IPRF, and stored blood. The platelets are small granulated non-nucleated bodies which secrete the growth factors. Various growth factors, including the platelet-derived growth factors, insulin-like growth factors, the epidermal growth factors, vascular and vascular endothelial growth factors. These growth factors, they initiate wound healing by attracting and activating the macrophages, thereby initiating healing and regeneration. In our study, we have studied vascular endothelial growth factor. The aim of the study was evaluation of the levels of vascular endothelial growth factor in platelet concentrates and in stored blood. And the objectives were assessment of the VEGF levels in LPRF, IPRF, and stored blood. And quantitative assessment of comparison or the quantitative comparison of the expression of VEGF levels among different samples. The study was conducted at Army Dental Center R&D Research and Referral among the patients who attended the central OPD. Due ethical clearance was sought from the ethical committee and the consent from the subjects was sought. The autologous blood samples were collected from 10 healthy subjects and the samples were divided into 3 groups. The whole blood group, which was processed after 24 hours, it was processed, and plasma as well as code, both of them were extracted. The groups B and group C, which is the PRF groups, they were processed as per the Cochrane's protocol when IPRF was processed at 700 RPM for 3 minutes and LPRF was processed at 2700 RPM for 12 minutes. The platelet pool plasma, it was derived from the supernatant, which was remaining after the LPRF group, LPRF was formulated. Following which, the samples were subjected to the ELISA procedure, wherein the standards were prepared, the antigen VEGF samples were added, and VEGF antibodies were added, and enzyme conjugate was added to initiate the ELISA reaction. Following which, this plate was incubated and the procedure was completed. Following which, after the completion of the procedure, the plate was introduced to the ELISA reader for assessing the optical density and the values of the VEGF levels. The results revealed, on quantitative analysis of the results, they revealed higher vascular endothelial growth factor levels in PRF group in comparison to the PPP group. The statistical analysis revealed, which was done using a SysStat 13 software, and peer testing t-test was done for testing the hypothesis, and intergroup analysis was done. And a done-stack adjustment was done for the adjustment of the p-value. The intragroup adjustment analysis depicted that both LPRF and PRF groups had statistically significant levels of VEGF in comparison to the PPP levels, and the comparative graphs are plotted between the variables. Platelets, they are extracts from the blood which are processed, generated by processing the blood at various levels, mainly by centrifugation. The platelet concentrates, they have evolved over a period of time from the initial fibrin glue, which was introduced in 1970s by Matras, to the PRPs, which were introduced in the dentistry by Whitman et al., to the second generation platelets, which we have PRF products, which were seen present. The first generation product, or the platelet poor plasma, they had certain or the platelets, it has certain inherent problems which was associated with the cumbersome procedure and the chances of any infections owing to being a bovine origin. So subsequently, in 2006, doctors they modified this procedure and removed the xenogenic factors, and thereby, and the second generation product PRF was the platelet concentrates were formed, which was termed as platelet-rich fibrin. PRF as such comprises of three main parts, which is the red blood cell, the fibrin clot, and the acellular plasma. And the various other PRFs can be generated by using the Cochrane's protocols. The PRF as such comprises of a fibrin matrix, the platelets, leukocytes, and stem cells. Fibrin matrix, it is the main supporting matrix which holds the cells. The platelets, they are rich in growth factors. Leukocytes and stem cells, they are responsible for their antibacterial and neovascularization and regenerative properties. In a study done by Dohan Ernest et al., it was observed that the growth factors are released slowly or initially and over a period of time, and the vascular endothelial growth factor is released initially at day 0 and subsequently it is peaks up to the day 7. Thereby, it is reduced. The secretion is reduced. Another study was done by Dr. Anirban Chatterjee and co-workers, wherein they have observed the growth factors, they continue to be secreted up to the 23rd. In our study, what we observed, there is an alteration in the expression of the pattern of vascular endothelial growth factor levels. The quantitative analysis, they reveal higher vascular endothelial growth factors in the LPRF and IPRF groups in comparison to those of the stored blood groups. The vascular endothelial growth factor was weakly expressed in platelet poor plasma, and the levels of vascular endothelial growth factor in both PRF and PRP groups were statistically significant in comparison to the PPP group. The statistical analysis revealed the mean values which were ranged between 134 in the platelet poor plasma and to the highest of 1330 in case of LPRF groups. The intergroup analysis depicted a statistically significant levels of vascular endothelial growth factor levels in the LPRF and IPRF in comparison to the PPP groups, wherein with the p-value less than 0.05%. A post-hoc analysis which was done using Duns-Pack adjustment for the adjustment of p-value, and the comparative graphs were plotted. Now, for healing process to occur, the presence of hemos blood supply is a prerequisite, because healing being a dynamic state process which includes various steps of hemostasis, inflammation, proliferation, as well as maturation. In a routine healing procedure, the leukocytes, they are introduced at the 7th day. However, with the introduction of the platelets or the PR platelet-rich fibrin, the leukocytes, they are introduced in the wound and at day 0, thereby speeding up the regenerative process or the healing process. To conclude, the quantitative regarding the quantitativeness is revealed higher vascular endothelial growth factor levels in the LPRF groups. The comparative vascular endothelial growth factors level was observed in the IPRF groups. The stored blood also is a viable option for vascular endothelial growth factor. This biomaterial, that is the PRF, has an enormous potential which can be utilized in clinical situation for enhancing regeneration and tissue healing. These are my references. I must acknowledge my sincere gratitude to the Kumran faculty, Army Dental Center Research and Referrals faculty, the Department of Periodontology, the staff from the Department of Laboratory Sciences and Molecular Medicine, Army Hospital Karandar, my colleagues and PG residents who supported me through this study. And thank you.
Thank you, Colonel Naveen, for your presentation.
Thank you, ma'am.
Okay. So, any particular reason why you took up only VEGF and not include the entire array of? Was it because of the ELISA kit, that would have been
that was the main reason, because
okay.
that was the main reason, because what we had been since the study was started, we had initiated the study somewhere in the month of March, but immediately after that the lockdown thing happened, and we were not reagents were very difficult. So far, difficult to procure the reagents. The only reagent which we initially, that was our initial plan, that we'll study all the growth factors.
All the growth factors.
But since this we could get our hands only onto VEGF as at that point of time, so that is our future plan, that we'll study all the growth factors at different levels, because over a period of time, with the slow speed centrifugation concept coming in, wherein it is being said that the with the slow speed the growth factors are released slowly and in a better manner. So, but in our study, what we have observed, since we have studied only one growth factor and the sample size was lesser, maybe we may have a similar situation. However, there are studies which have been clearly mentioned that the PRF group as such, it has a different, it is secreted at a higher levels, the higher growth.
Okay, Dr. Colonel. So, Colonel, Dr. Himanshu, if you may ask, please. Unmute, Dr. Himanshu.
So what's the take-home message, what we should be doing clinically for all these comparisons that you have shown us?
So the take-home message for us is that the PRF as well as the vestibular endothelial growth factor, it is a very viable option for us. So it can be utilized for all our regenerative process. Another process which in our study also we have observed that we had used the platelet poor plasma. Generally, when we prepare the PRF, that superintendent would discard that also. That we can use that also, because that also has some growth factor potential.
I think we have to stick to the time limit, and thank you so much.
Thank you.
Sorry to interrupt. If Prabhav is there, can we take his question and answer?
Yes, Prabhav, we were looking out for you after your presentation.
Ma'am, because of some headphone issue. Good afternoon, ma'am. Good afternoon, sir.
So, your presentation was also very good, and
thank you, ma'am.
as far as I wanted to ask you one or two things. One was that. So did you think of including, so you had 4 groups, right? One was PDT, the erbium YAG laser,
then citric acid, and
the control.
Yes, ma'am.
So what about our gold standard for root biomarker? So I'm sure the material will not be available. So Emdogain is something that you didn't get.
We are having Emdogain, but because of this study, I just want to put across my point regarding biomodification. And biomodification is a concept. It's a learn and relearn type of concept now. So that's why I did this study in our department. And I have done field emission scanning electron microscopy, and I have chosen scanning electron microscopy over field emission scanning electron microscopy over scanning electron microscopy, because because in field emission scanning microscopy there is an electron beam which is bombarded on the tissue surfaces, and
so between PDT and erbium YAG, which was give you better results?
Ma'am, erbium YAG, I found better results in erbium YAG.
Was it statistically significant?
Ma'am, because of skewed distribution of curve, ma'am. So we have applied post-hoc analysis criteria.
Okay,
and
thank you so much, Dr. Himanshu, please, if you may.
So which one is easy to use in a clinical setting, PDT or the erbium?
Sir, more easier is the PDT. More easier is PDT, but erbium YAG we can also use, sir. If availability of erbium YAG is there in department, we can use erbium YAG.
It's more affordable also, PDT.
Yes, ma'am. PDT is more affordable.
Okay, thank you so much, Major Prabha. Thank you.
Thank you, ma'am.
May we have the next presenter, please?
Good morning, I'm Dr. A. Sukanya, and the topic for my paper presentation is reduction of stains and bitterness associated with chlorhexidine mouth rinse in conjunction with hydrogen peroxide mouth rinse. Introduction. Periodontitis is considered as one of the most prevalent diseases occurring in the oral cavity, and it is initiated by the pathogenic bacteria that are present in the dental plaque. The main pathogenic bacteria that are associated with periodontal disease are Porphyromonas gingivalis and Aggregatibacter actinomycetum comitans. Effective plaque control is very much crucial in preventing the progression of periodontal disease. This effective plaque control can be achieved by mechanical and chemical plaque control. The mechanical plaque control includes the use of toothbrushes, that is the manual and the power toothbrushes, and several interdental aids such as the dental floss and interdental brushes. Oral irrigation devices such as supragingival irrigation devices and subgingival irrigation devices can also be used in performing mechanical plaque control. These irrigation devices helps in rinsing out the dental plaque from the tooth surfaces and thereby preventing the periodontal disease progression. Adequate mechanical plaque control needs patient's ability and also motivation. Most of the patients were unable to perform adequate mechanical plaque control. Thus, chemical plaque control using a variety of chemotherapeutic agents can be used as an adjunct to the mechanical plaque control to prevent periodontal disease progression. The chemical plaque control can be accomplished by using several chemotherapeutic agents, which include antimicrobials, including the antibiotics, several enzymes, metallic salts, natural products, quaternary ammonium compound, and amine alcohols. Of all the chemical plaque control agents, chlorhexidine is considered to be the most effective one and is the commonly used chemical plaque control agent. And the American Dental Association have approved chlorhexidine as the effective chemical plaque control agents due to its advantages such as superior substantivity and prolonged anti-plaque effect. Chlorhexidine has several disadvantages too, which include unpleasant bitter taste and altered taste sensation, and also discoloration of the teeth and also the restorations. Apart from these, the other disadvantages that are seen with chlorhexidine are oral mucosal lesions, unilateral or bilateral parotid gland swelling, and increased supragingival calculus formation. Hydrogen peroxide, which is an oxygenating mouthwash, has been widely used in treatment of necrotizing periodontal disease, and it is also known to be an effective agent in reducing the tooth discolorations. Several studies done by Grundemann LJ in the year 2000 and Dona BL in the year 1998 have stated that using an oxidizing agent as an adjunct to chlorhexidine was more effective in decreasing the plaque scores and also in preventing the tooth staining compared with chlorhexidine mouth rinse alone. The objective of my study is to evaluate the use of hydrogen peroxide mouth rinse as an adjunct to chlorhexidine in reducing the stains and removal of dental plaque from the tooth surfaces, materials and methods. The study included a total of 60 participants, and all the 60 participants were directed to use 0.2% chlorhexidine mouth rinse for 7 days, followed by mouth rinse containing chlorhexidine and also to 1.5% hydrogen peroxide for further 7 days. Simplified oral hygiene index and circular bleeding index were recorded at baseline 1 and after 2 weeks. Bitterness was also assessed after rinsing with each mouth rinse solution. Statistical analysis. All the data were collected and the data were entered in MS Excel and analyzed in SPSS V24 software. ANOVA test was performed to determine the statistical significance for the study. The results of the study were as follows. Regarding the oral hygiene index simplified, the mean value at the baseline was found to be 2.1, which was reduced to 0.6 for chlorhexidine alone, and the mean value of oral hygiene index simplified was about 0.5 for the combination of chlorhexidine along with the hydrogen peroxide. Regarding the circular bleeding index, the mean value of circular bleeding index was 11.09 at baseline, which was reduced to 9.02 with chlorhexidine alone, and the mean value of circular bleeding index was about 10.2 with chlorhexidine and hydrogen peroxide. Assessment of bitterness. Bitterness in chlorhexidine alone. In this, about 56 out of 60 participants have stated that there is bitterness associated with chlorhexidine mouth rinse alone, and only 4 participants have stated that there is no bitterness with chlorhexidine mouthwash. Bitterness regarding the combination of chlorhexidine along with hydrogen peroxide. For this, a total of 50 patients were stated that there is bitterness associated with this formulation too, and about 10 participants have stated that there is no bitterness seen when hydrogen peroxide is used along with chlorhexidine mouth rinse. Results. To sum up, the significantly highest levels of satisfaction were recorded after rinsing with the 0.2 chlorhexidine along with 1.5% hydrogen peroxide mouthwash. To conclude, hydrogen peroxide mouth rinse used as an adjunct to chlorhexidine mouth rinse reduces the bitter taste and stain formation that are usually seen with the chlorhexidine mouth rinse. But the hydrogen peroxide can be used only as an adjunctive agent along with the chlorhexidine, but it cannot solely used as a mouth rinse to the periodontitis patients because it may not be as effective as the chlorhexidine mouth rinse, which is almost demonstrated as a gold standard chemical plaque control agent. Thank you.
Thank you, Dr. Sukanya.
Good afternoon, ma'am. Good afternoon, sir.
And now tell me, the difference. So the results between the two groups were statistically significant as far as bitterness and staining was concerned.
Yes, ma'am.
Because so the graph that you showed, those results were very close, right?
Yes,
Amongst the two groups,
both
but
the groups.
it was still statistically significant.
Yes, ma'am.
Okay, so did your patients, so from compliance point of view perspective, from the perspective of compliance with use of 2 rinses?
Yes, ma'am. Both mouthwashes for 2 weeks, ma'am. Yes, ma'am.
No, so
they were compliant, ma'am.
Compliant with using 2 different mouthwashes, and they did not find it very cumbersome or?
Yes, ma'am. They are very compliant, ma'am, with using both combination and chlorhexidine alone, ma'am.
Okay. Dr. Himanshu, over to you, please.
Good afternoon, sir.
Good afternoon. No questions.
Thank you so much, Dr. Sukanya.
Thank you, ma'am. Thank you, ma'am.
Have the next presenter.
A very good morning to one and all present here. Today, I am here to discuss my short study on the topic antibacterial efficacy of commercially available disinfectant versus traditional formaldehyde fumigation. I'll be discussing my topic under the headings introduction, objective, materials and methods, statistical analysis, results, discussion, and conclusion. Coming to the introduction, we all know that a potential transmission of the disease to personnel during dental procedures has become a source of increased concern to the dental profession and the public. Most of the procedure which we have done will create aerosols. To control the spread of pathogens in dental environment, a good hygienic routine based on cleaning and disinfection of surface contaminated with biological materials are the obligatory requirements. Various engineering solutions are available for the removal of bioaerosols, such as ultraviolet germicide irradiations, photocatalytic oxidation, ozonolysis method, and engineering nanomaterials. In the study, I have performed the disinfection with ozone and activated hydrogen peroxide with silver nano against formaldehyde fumigation, since it is a traditional and widely used method of disinfection for operation theaters and dental clinical setup. Hence, an attempt was made to assess and compare the efficacy of newer disinfectant that are hydrogen peroxide with activated silver nano and ozone treatment with formaldehyde fumigation on microbial colony reduction. The primary objective of my study was to assess and compare the efficacy of disinfectant, hydrogen peroxide with activated silver nano and ozone treatment. And I also assessed and compared the longevity of disinfectant hydrogen peroxide with activated silver nano and ozone treatment versus traditional formaldehyde fumigation. The study was performed in the Department of Periodontology at Dayananda Sagar College of Dental Science, Bangalore, over a period of 1 week. The study was divided into 3 groups. In Group A, ozone disinfection were done by using ozonator. In Group B, the disinfection with hydrogen peroxide with activated silver nano was done by using fogger. Group C, formaldehyde fumigation was done with the help of fumigator. The study was spread across a week with an interval of 48 hours gap between each disinfection. 5 blood agar plates were exposed in the air for 20 minutes to collect the samples in minor surgery room. 4 plates were kept in all the corners of the room, and 1 plate was kept at the center, maintaining a minimum distance of 6 feet between the plates. Samples were collected 20 minutes prior to the start of each disinfection, is labeled as T0, and the post-disinfection samples were collected at 45 minutes, then followed by 3 hours interval and labeled as T1 and T2 and T3 respectively. All the collected samples were incubated at 30 degrees Celsius for 24 hours in an incubator. The growth was identified by counting colony-forming units. Statistical analysis was done by SPSS software. Intergroup comparison was done by one-way ANOVA followed by Tukey's post hoc test. Intragroup analysis was done by repeated measures of ANOVA followed by Bonferroni post hoc test. This is the colony. This is the colonies which we are obtained before and after the disinfection. Comparison of mean CFU between 3 study groups at different time intervals showed a statistically significant differences at the interval T1, T2, and T3. Multiple comparison yield, there is a statistically significant differences in T1 intervals between group A and group B. In T2, there was a statistically significant differences between the group A and B and A and C, and then the T3 between AC and A and C, B and C. Mean colony forming units between different time interval in each study groups showed there is a statistically significant differences between each group. Multiple comparison yield, there was a statistically significant differences in group A in all the intervals except T1 versus T2. In group B, the statistically significant differences was noted in between T0 versus T2 and T0 versus T3 and T2 versus T3. And in the group C, the statistically significant differences was found between T0 and T1, T0 and T2, T1 and T3, and T2 and T3. Coming to the discussion, counting microbes in the air is not an easy task, but through air and surface sampling, it is possible to evaluate the bacterial contamination of environment. It was observed that the bacterial count is in the range of 700 to 1800 per cubic meter, which is related to significant risk of infection. In our study, we obtained a range between 90 to 900, which showed a significant risk of infection. Apart from that, human activity and the related factors have more influence on the colony forming unit. Chemicals such as hydrogen peroxide, gas plasma, and hydrogen peroxide liquid were found that they have the capacity to kill all the microorganisms, including spores, after prolonged exposure times. Pedeser and co-workers reported that 60 minutes of exposure to a combination of silver and hydrogen peroxide results in 5-log reduction of E. coli. Silver nanoparticle, when combined with hydrogen peroxide, the bactericidal hydroxyl radicals are generated by a Fendon reaction. This combination was highly potential in the minimal concentration in reducing the microbial load. In our study, also showed a gradual reduction in colony forming units due to the bactericidal action of the hydroxyl ions. Black in 1963 demonstrated the efficacy of the ozone in inactivation of bacteria, viruses, and protozoa, and in the destruction of biofilm. And Perez et al. In 2008 also observed the efficacy of ozone water in disinfection of operation theatre. In our study, the ozone disinfection also exhibited reduced microbial count at 3 hours post disinfection. According to CDC guideline 2012, a sufficient formaldehyde should be vaporized to produce an airborne concentration of at least 50 milligram per meter cube with a minimum of 6 hours. 6 hours. In our study, the duration of disinfectant action of formaldehyde was found to be 6 hours when compared with other two disinfectants. It was also found that there was a reduction in CFU at the 8 hours of post disinfection in ozone and hydrogen peroxide with activated silver nano 40. Coming to the conclusion, the use of hydrogen peroxide with silver nano in this combination may be realistic and applicable because of the high potency and cost effectiveness of such a simple combination. The ozone generated by ozonator equipment was also able to reduce the microbial.
Okay, thank you, doctor, for your presentation.
Good afternoon, ma'am.
Good afternoon. Amidst the ozone and the H2O2 plus silver nano, which one was statistically significant and something that you conclude should be suggested for clinic disinfection?
Ma'am, actually, we have done the study to compare three disinfectant, and first two disinfectant is newly commercially available disinfectant. We found that it's a pilot study first of all, and we found that we can use it as a disinfectant as an effective alternative to traditional formaldehyde fumigation.
Which one do you recommend? What is the conclusion of your study?
Ma'am, all the three groups showed a statistically significant difference, ma'am. But according to this study, we can use this as an alternative. These two as an alternative for formaldehyde fumigation. Since the formaldehyde fumigation, it's time consuming. So in this situation, we can recommend these two. That is activated silver. Hydrogen peroxide with activated silver nano and ozone.
So you have used post hoc, 2K and Bonferroni both in your statistics.
Yes, sir.
Right?
Yes, sir.
So significance of using these two tests?
Sir, in the first, we have done this by ANOVA test. Sir. In ANOVA test, we found there is a statistical significant differences there. So to confirm where is exactly the difference, we have done the post hoc tests. In that, we found that, sir.
Bonferroni?
Bonferroni also we have done to assess the intergroup analysis, sir. Intragroup analysis, sir. So intragroup analysis between the time interval.
Okay, thank you.
Thank you, sir. Thank you, ma'am.
Thank you, Dr. Mridula.
Good morning to all the delegates here. I am here to present my topic, estimation of prostaglandin E2 levels in gingival clavicular fluid in periodontal health, disease, and after treatment. Moving on to the introduction, periodontal disease is an inflammatory process involving an innate and adaptive immune responses characterized by irreversible loss of connective tissue attachment and supporting alveolar bone. Sequential steps of the periodontal disease progression includes bacteria gets colonized on tooth surface and gingival sulcus, release of various cytokines and arachidonic acid derivatives like prostaglandins and leukotrienes, and various other inflammatory mediators which come into play, finally leading to osteoclast production, breakdown of connective tissue and alveolar bone resorption, finally leading to the periodontal disease progression. Subjects who had reported to outpatient wing of periodontics department were selected randomly and categorized into group. Healthy subjects, patients suffering from chronic periodontitis, age group of 20 to 55 years based on the probing pocket depth and clinical attachment loss, radiographic evidence of bone loss, free from any acute or chronic systemic diseases, subjects who had not received any surgical or non-surgical periodontal therapy for the past 6 months were included. patients with any habit of smoking, patients with history of taking any anti-inflammatory, antibiotics, or immunosuppressive drugs in the last 6 months, female patients with a pregnancy or receiving any oral contraceptives were excluded. Smoking is a major risk factor for periodontitis and increases the severity and prevalence of periodontitis, hence it is excluded. History of taking any anti-inflammatory drug or antibiotics or immunosuppressive drugs alters the alveolar bone metabolism, like suppression of bone formation and suppression of bone resorption, and thus leading to alteration in the prognosis. Female patients with pregnancy or any oral contraceptive intake are also having any impact either directly or indirectly on the bone metabolism. Thus, these were excluded. Extraclavicular method of GCF collection was used, and gingival index, probing pocket depth, clinical attachment loss were the parameters which were used to evaluate the periodontal condition. Coming to the groups. In this study, there were 3 groups, Group 1, Group 2, Group 3. Group 1 contains 10 subjects, Group 2 contains 15 subjects, and this study is with 25 subjects. 10 in the Group 1, that is clinically healthy group, no redness of the gingiva, no bleeding on probing, no bone resorption, and probing pocket depth will be less than or equal to 3 mm. Group 2, the 15 subjects with chronic periodontitis group, chronic gingival inflammation and generalized bone resorption, probing pocket depth is greater than or equal to 5 mm were included. The same Group 2 patients, the 15 subjects of the Group 2 were included in the Group 3, that is after treatment group, chronic periodontitis group that received non-surgical periodontal treatment and reviewed after 8 weeks. Principle of the assay used is concentration of prostaglandin E2 in the sample combined with fixed amount of horseradish peroxidase labeled PGE2 that leads to mouse monoclonal antibody and anti-mouse antibody which was coated onto the microplate following a wash to remove excess conjugate and unbound sample which finally gives a color, and intensity of color is inversely proportional to concentration of PGE2 in the sample. Statistical analysis for obtaining results was done by using the following tests, that is Spearman's rank correlation test, Wilcoxon signed rank test, Kruskal-Wallis test. Spearman's rank correlation test to evaluate the correlation among the PGE2 levels. Wilcoxon signed rank test, significance were assessed before and after treatment. Kruskal-Wallis test, significant differences between the study groups. It is known that prostaglandin E2 concentration in the chronic periodontitis group have been increased gradually, and after treatment they were decreased, and significant reduction in all the parameters like periodontal index, gingival index, probing depth, clinical attachment level have been noticed. It is known that in healthy gingival tissue, GCF contains a few inflammatory cells. They are macrophages and mononuclear leukocytes. To some extent, these will lead to production of some inflammatory mediators even in the healthy conditions. In chronic periodontitis group, there will be significant reduction of PGE2 concentration levels and significant improvement of all the clinical parameters after 2 months of the treatment. Finally, we can see the significant reduction in mean PGE2 concentration in chronic periodontitis group after treatment. And I conclude that prostaglandins are inflammatory markers, and increased levels of prostaglandins in the periodontal disease conditions will be elevated, and there is a need to treat periodontal disease condition as the increased levels of prostaglandins will affect the systemic health too. I'm very proud that as a periodontist, maintaining the periodontal health will directly or indirectly helping to attain the systemic health of an individual. These are my references. Thank you. Thank you for giving me this opportunity.
Thank you, Dr. Kiran.
Good afternoon, ma'am.
Presentation. Okay.
Thank you, ma'am.
Yeah. So you did not include gingivitis as one group, right?
Yes, ma'am.
only included healthy controls and
healthy condition and chronic periodontitis
chronic
group and
perio
after
and
treatment.
post-treatment. Okay, okay. What would be the effect of gingivitis on PGE2? Would it affect or cause elevated levels of PGE2, or would it be as
Yes, ma'am. It will cause elevation, ma'am. But significant amount of increase in PGE2 concentration will be noted only in the periodontitis group, ma'am. As a reason is PGE2 is having its action on osteoclast, ma'am, mainly, and it leads to bone resorption, ma'am.
so still you feel that in gingivitis there would be elevated?
Yes, ma'am. Yes, ma'am.
Okay, okay. So what would be the clinical relevance or application of your study? Quickly, then I would ask, request Dr. Himanshu to ask you.
Good afternoon, sir.
Yeah. Over to you.
Okay, so you have chosen one inflammatory marker, PGE2.
Yes, sir.
The same study could have compared the other inflammatory markers also on the same parameters. Why
Okay,
they were
sir.
not included? Anything specific?
As it is a short study, just I included one of the markers, sir. And due to the current pandemic situation, keeping into the mind, I just had a short study, sir.
Right. Okay.
And in few further studies, I'll include, sir.
Right. Thank you.
Thank you, sir.
Good morning. Topic for my paper presentation is assessment of knowledge regarding dental floss and flossing technique in the clinical and non-clinical dental students. It's a questionnaire study presented by Dr. Anita Pothaneni, Narayana Dental College. My abstract ID is 1766. Coming to introduction, dental plaque or biofilm is the main etiological factor in the causation of periodontal disease, and effective removal of bacterial plaque is a gold standard for its prevention. The mechanical method of plaque control is indisputably the easiest and most effective measure to prevent periodontal diseases. It has been reported that toothbrush alone is inadequate for effective removal of dental plaque, and hence use of other oral hygiene aids such as dental floss has been emphasized. Aim of the study: to assess the knowledge, awareness regarding dental floss and flossing technique in the clinical and non-clinical dental students. Methodology: a cross-sectional questionnaire study was conducted in Narayana Dental College, Nellore. Minimum of 300 participants, that is 150 in each group, were included in the study from non-clinical and clinical dental students, and the data was analyzed. Inclusion criteria: only clinical and non-clinical dental students. Exclusion criteria: other than dental students are excluded. Coming to the results. Coming to the knowledge regarding the dental floss, awareness of dental floss. In this question, 87.3% of clinical dental students are more aware than the non-clinical dental students, which is 58%. And coming to usage of dental floss, 66.7% of clinical dental students are more aware than the 42% of the non-clinical dental students. Types of dental floss: 40.7% of clinical students are more aware than the non-clinical dental students. And frequency of dental flossing: 40% of clinical dental students are more aware than the non-clinical dental students, which is 18%. Flossing technique: 54% of clinical dental students are more aware than the non-clinical dental students, which is 38%. These are the pie diagrams showing some results. Coming to the question, does dental floss massage the interdental area? 68% clinical dental students are more aware that it massages the interdental area, whereas 38% of the non-clinical dental students are aware. 56% of clinical dental students are aware that dental floss reduces gingival inflammation, whereas 46% of non-clinical dental students are aware that dental floss reduces gingival inflammation. And 76.5% of clinical dental students are more aware that the dental floss helps in reducing the halitosis, whereas 59.3% of non-clinical dental students are aware that dental floss helps in reducing the halitosis.
And this research shows that clinical dental students are more aware regarding floss and flossing technique than the non-clinical dental students. And coming to the overall knowledge regarding the floss and flossing technique and the questions regarding aware of the flossing and frequency of the flossing and length of the floss, and does floss massage the interdental area, and with the floss aid in the identification of subgingival deposits and overhanging restorations, and does flossing reduces gingival inflammation, whether floss helps in reducing dental halitosis, and does floss harm the interdental gingiva. These are all these questions are compared between clinical and non-clinical dental students. The knowledge in dental student, clinical dental students is more than the non-clinical dental students. And p-value shows that there is statistical significant difference between the clinical and non-clinical dental students. This clearly explains that clinical dental students are more aware than regarding floss and flossing technique than the non-clinical dental students. Coming to the discussion, even though the use of dental floss along with regular toothbrushing has been recommended routinely for prevention of dental gingival diseases, the statistics throughout the world is not encouraging, and hence it is essential to find the knowledge regarding dental floss and flossing technique, which would be helpful to plan corrective measures. The main oral hygiene aids used in India are toothbrushes, toothpastes, and tooth powder, along with indigenous aids like neem stick, babul, charcoal, brick powder, ash, etc. The percentage of dental floss users is significantly less when compared to toothpaste and toothbrush users. It has been reported that only 15.8% of the population in India use dental floss, which could be attributed to lack of awareness among people and prescription practices of the dentist. This was the first study done regarding knowledge of floss and flossing technique and comparing between clinical and non-clinical dental students. In the present study, 87% of clinical dental students had awareness among flossing, while only 58% of non-clinical dental students are aware. 40.7% of clinical dental students had knowledge regarding the types of dental floss, whereas only 17.3% of non-clinical dental students are aware of the types of dental floss. According to the study conducted by Swami Ramanatha et al. In 2019, 36.7% of students who flosses, among which 20.9% of students started flossing only after joining the dental school. Coming to the conclusion, the study concluded that knowledge regarding the dental floss and flossing technique was more in clinical dental students when compared to the non-clinical dental students, and the results were statistically significant. Recommendations. Health education programs regarding dental floss and adequate training for non-clinical dental students is essential to improve the oral health status of an individual. These are the references.
Thank you, Dr. Anita, for your presentation.
Good afternoon, madam.
Good afternoon. And thank God for your conclusion. It is the clinical group of students and not the non-clinical.
Yes, madam.
Disastrous if it was the other way around. So what have you done about it? So have you converted this 40-50% to 100% in your college? Have you did you spread the awareness of use
Yes,
of
madam.
cleaning methodology?
After the results had obtained, I went to some their classes, ma'am, and they told that use floss, it is important for your health.
Maybe you could have done a small presentation to show them in detail the types.
No, yes, madam. Now the college has been closed, ma'am, for the UG students. After that, I will take this and I will go and I'll present, madam.
Okay, okay. Over to you, Dr. Himanshu, for your question.
So how was the study? How did you calculate that? That was
Statistical analysis only, sir. By obtaining a p-value and frequencies, we calculated first, sir. Using that frequencies, chi-square test was done with to show the statistical significant differences between the two groups, sir.
Any calculation for that?
No, sir.
I think she's left.
Okay.
Anita? Yeah.
Sir, ma'am, signal lost. I have lost this.
Okay, thank you so much, Anita. And with this, I think we come to an end of session 6 also, Dr. Girish.
Yes,
Yes?
yes, ma'am.
We're well within time and
Yes, well within time, and we are ready to start the next session. Thank you so
nice,
much,
nice.
Roshni ma'am.
So,
Please, regards to Dr. Roshni ma'am and Dr. Mansi sir.
thank
Chairing
you.
this
Thank
session
you,
on
Dr.
especially Sunday
Girish.
afternoon.
Thank you, Dr.
Thank you
Girish.
so
Thank
much.
you, Dr. Roshni.
Thank you,
all
Dr. Himanshu. It was a pleasure chairing it with you. Time just flew by. I would also like to take the opportunity to thank the ISP head office once again, the entire team of the 19th PG convention. Thank you so much.
Thank you, Mansi sir.
Right. Thank you.
Thank you. Bye-bye. Bye.
So here we come to the end of session 6, and then we starting with session 7, session 8 now. We are having Dr. Kamal Kishore sir and Dr. Dhawan Modi sir as a moderator for this session. Welcome Dr. Kamal Kishore sir and Dr. Dhawan Modi sir, the last 2 sessions of this scientific event. Good afternoon, Kamal sir. Dhawan sir joining shortly. Kamal sir, am I audible to you?
Yes.
Okay, sir. afternoon, Mohan. Good afternoon, Girish. Dr. Girish.
Good afternoon, Dr. Girish.
Good afternoon, sir. Very good afternoon to all the participants and all the delegates who are present for the Hall A session 7 and 8. We have Dr. Kamal Kishore Mankar sir and Dr. Dhaval Modi sir as a chairperson for this session. Dr. Kamal Kishore sir has completed his BDS from SPDC Savangimege Vardha, passed his MDS from GDC Nagpur. He is currently working as a reader in the Department of Periodontics and Implantology, VSPM Dental College and Research Center, Nagpur. Sir has an experience of 8 years in academics and having several publications to his credit. I welcome you, sir. Dr. Dhaval sir has completed his BDS from SPDC Savangimege Vardha in 2008 and passed his MDS from GDC Ahmedabad in 2012. He is currently working as a reader in the Department of Periodontics and Implantology, VSPM Dental College and Research Center, Nagpur. Sir has an experience of around 9 years in academics and also owns a private practice in Nagpur. Currently, he is an EC member of Indian Society of Periodontology. Sir, I welcome you for this session and I hand over the proceedings to you. So can we start with first presentation? Yes, sir.
Respected chairpersons, delegates, and all the dignitaries, today I'm here to present my paper, Serum Vitamin D Level and its Association with RBC Indices in Patients with Periodontitis, a double-blind case-controlled study. The contents include introduction, research hypothesis, aim, materials and methods, results and discussion, conclusion, and reference. As we all know, periodontitis, an inflammatory disease, is no longer perceived as a local phenomenon. Instead, it is a disease that can lead to numerous systemic changes. One such systemic change that has been reported in studies is its effect on erythrocytes, leading to what is called as anemia of inflammation. The host responses to microbial antigens in periodontitis include actions of both innate and adaptive immunity, which are known to be partly modulated by vitamin D. And research of late has brought to light a link between vitamin D and anemia as well. So, we hypothesize that the periodontitis patients can present with lower serum levels of 25-hydroxy vitamin D than periodontally healthy patients, and the lower vitamin D levels could be associated with increased risk for anemia in periodontitis patients. To the best of our knowledge, no studies have been attempted to link serum vitamin D levels and RBC indices in periodontitis patients. Hence, the aim of the study was to estimate the levels of serum vitamin D, hemoglobin, hematocrit, mean corpuscular volume, mean corpuscular hemoglobin, and mean corpuscular hemoglobin concentration in patients with generalized stage 3 grade B periodontitis and healthy controls, and to evaluate the association between serum vitamin D levels and red cell indices in periodontitis patients. Moving to the materials and methods, a sample of 60 individuals belonging to the age group of 30 to 60 years visiting the outpatient department of periodontology, Government Dental College, Raipur, were randomly enlisted for the present study after obtaining their written informed consent. The subjects were categorized into case, that is periodontitis group, and a control group of 30 each based on the classification criteria proposed by the 2017 World Workshop. Subjects with systemically healthy subjects with generalized stage 3 grade B periodontitis were included in the case group, and systemically healthy individuals exhibiting periodontal health were included in control group. Subjects with diabetes, cardiovascular or renal diseases, diseases associated with vitamin D deficiency, history of tobacco use, pregnant or lactating women, postmenopausal women, patients under medication including vitamin and nutritional supplements and who have undergone periodontal treatment during previous 6 months were excluded from the study. Participant characteristics like age, sex, BMI, and duration of sun exposure were elicited during the patient interview, and clinical examination included gingival index, oral hygiene index simplified, mean ratio of bleeding sites, probing depth, and clinical attachment level. Biochemical analysis was done after collecting a fasting venous blood sample of 5 ml under complete aseptic precautions using venipuncture. And serum vitamin D level was estimated by fully automated chemiluminescent immunoassay, whereas red cell indices assessed by fully automated bidirectional analyzer. Finally, statistical analysis was done using appropriate statistical tools. Now let's move on to the results. Participant characteristics did not show any significant difference between the case and control group, whereas clinical parameters had all shown a significant difference between the healthy and case group. Now comparing the vitamin D levels between the case and control group, it was significantly lower in the case group as compared to the control group. And also the percentage of patients with vitamin D deficiency was higher in the periodontitis group. This finding is in conformity with the results of the studies conducted by Bhargava et al. 2019, Jagalavizine in 2018, Kamiza et al. In 2018, which establishes the link between periodontitis and low serum vitamin D levels. A comprehensive review by Osher et al. Has concluded that low concentrations of vitamin D are most likely an effect of health disorders rather than the cause of illness. Similar substantial reduction in vitamin D levels has been reported during acute health episodes and also in chronic diseases including hypertension and diabetes. It is hypothesized that intracellular bacteria can modulate cytokine production, which can lead to marked inhibition of 1,25-dihydroxy vitamin D or vitamin D receptor gene transcription. Excess 1,25-dihydroxy vitamin D is produced in an effort to upregulate the VDR gene. 25-hydroxy vitamin D is rapidly metabolized in this process, resulting in its lower serum level. Now, while comparing the RBC indices, all the RBC indices except for MCV and FCH showed significantly lower levels in the case group as compared to the control group. The results indicated definite tendency towards anemia in patients with periodontitis as compared to the healthy group. And the findings are in line with the previous studies done by Agarwal et al. 2009, Pradeep et al. 2011, Anamolu et al. 2016, Nibali et al. 2019. Pro-inflammatory cytokines such as interleukin-6 could stimulate hepcidin production and lead to elevated iron traps in macrophages and liver cells, leading to anemia in periodontitis patients. Now, the correlation of vitamin D with RBC indices showed that vitamin D was significantly and positively correlated with the RBC index MCHC in periodontitis patients. Now, the disease predictors like age, gender, BMI, and sun exposure did not show any significant association with low MCHC and low vitamin D levels found in the periodontitis group. Also, the risk of developing vitamin D deficiency and low MCHC was found to be 3 times higher in periodontitis patients when compared to the healthy group. Meta-analysis of observational studies by Liu T et al. Indicate that compared with non-vitamin D deficient individuals, individuals with vitamin D deficiency could be associated with an increased risk for anemia. There is congruence among many of these reports suggesting that vitamin D deficiency is directly associated with anemia of inflammation. The results of our study corroborate the findings of these previous studies. Vitamin D could be important in the maturation and proliferation of erythroid progenitor cells, and anti-inflammatory effects of vitamin D could also downregulate the expression of hepcidin levels. So, vitamin D is very important in prevention of anemia, and its deficiency can lead to anemia. And our study further shows that MCHC can be one of the most important RBC index in low vitamin D induced anemia of inflammation. However, the sample size of the present study was minimum, so an evidence-based firm conclusion can be arrived at only based on a larger study with a far bigger sample size. And the design of the present study also does not entail to infer causality or to establish the mechanism behind the observed association. Prospective interventional and longitudinal studies are warranted to confirm the relationship between periodontitis, vitamin D deficiency, and anemia. It can be inferred from the study that periodontitis impacts serum vitamin D level and causes anemia, which suggests that effective management of periodontitis can help maintain sufficient vitamin D levels and may be important in preventing anemia. These are the references that were taken. Thank you for your patient listening.
Yes, nice presentation, Dr. Galsala. Dr. Kamal sir, any questions?
No questions. Nice presentation.
Okay, thank you.
Good evening to one and all. I am Dr. Pranay here in front of you to present my study titled as Evaluation of Papillary Portions in the Maxillary Anterior Dentation, a Cross-Sectional Study. These are the contents which I am going to deal with. Coming to introduction, multidisciplinary therapies in aesthetic restorative treatment has become commonplace in the dental profession. The perception of dental aesthetics varies significantly among dental professionals, although efforts have been made to establish common standards. It is the interdental appearance of the papilla in an apicocoronal direction that is critical during smiling that results in positive gingival architecture aesthetics. By mathematically quantifying the papilla length from gingival zenith as papilla proportion, dental professionals can enhance the treatment outcome and also can transfer aesthetic data more proficiently. Papilla proportion is a percentage of papilla height to the crown length. For example, let's say the clinical crown length here, it is 10 millimeters from the gingival zenith and mesial papilla height is 4 millimeters. When we calculate the mesial papilla proportion, it is 40%. That means mesial papilla occupies 40% of the clinical crown length. The purpose of this study is to quantify the interdental papilla location mathematically as a percentage ratio of clinical crown length. Materials and methods are a sample population of 10 in number, which included 6 female and 4 male persons of age group 19 to 26 years was studied. The sample population were included on the basis of non-restored maxillary anterior teeth, no loss of interdental papilla, no anterior crowding or spacing, no incisal attrition, periodontal diseases, and gingival recession. Initially, alginate impressions were made and cast was poured in dental stone. Later, crown length, mesial papilla height, and distal papilla height were recorded using vernier calipers from the level of gingival zenith. Finally, papilla proportion was calculated by using the formula papilla proportion is equal to papilla height by crown length multiplied by 100%. These are the images which depict how the measurements were made. The green line over the image shows clinical crown length. The yellow dot indicates gingival zenith, and the red arrow marks indicate the length of the papilla measured mesially or distally. Coming to the results, the mean absolute interdental papilla height by tooth of central incisors is 4.4 millimeters plus or minus 0.6. Lateral incisors, it is 3.9 millimeters with a variation of 0.7, and canines, it is 4.5 millimeters plus or minus 0.6. The mean mesial papilla proportion is 41%, and mean distal papilla proportion is 42%. When a graph is plotted between papilla height and tooth number, we find that the average papilla height for tooth is 4 millimeters. At the same time, when a graph is plotted between papilla proportion and tooth group, we find for central incisors, mesially and distally, it is 40% and 41%. For lateral incisors, it is 40 and 40%. For canines, it is 45 and 43%. Similarly, when a graph is plotted between papilla proportion and tooth number, we find that all of the values which we obtain are above 40%. So, gingival aesthetics has always been an important component of a beautiful smile. The ideal gingival architecture has been described as one that consists of knife-edge gingival margins tightly adapted to the teeth, interdental grooves, and cone-shaped interdental papilla. In a study conducted by Coyles, interdental papilla heights from the pregingival margin to the osseous crest was reported in a range of 3 to 4.5 millimeters. A study conducted by Spear estimated that average maxillary interproximal papilla height would be around 4.5 to 5.5 millimeters from central incisors when measured from facial zenith. A study conducted by Martengani et al. Found that the interradicular distance and the distance between the contact point and the alveolar crest have independent and also combined effect on the presence or absence of interdental papilla. So in my study, the mean absolute interdental papilla heights by tooth of central incisor, laterals, and canines were found to be 4.4 millimeters, 3.9 millimeters, and 4.5 millimeters respectively. The average mesial papilla proportion and distal papilla proportion for centrals, laterals, and canines were measured as 40 and 41%, 40 and 40%, 43 and 45% respectively. Coming to the clinical implications, for aesthetic anterior restorations, papilla heights must be proportional to the clinical crown length. Hence, mathematical equations were presented as proportion calculations, which accounted for variability in a clinical crown length. These values could be helpful for periodontists and implantologists in planning surgeries concerning vertical soft tissue height in aesthetic zone. Gingival zenith and papillary position act as reference point and also would aid in diagnosis, treatment plan, and reconstructing a natural smile. I say by concluding, the calculated standard deviation of all papilla proportion measurements was less than 7%, which equaled aesthetic natural appearance of papilla within a range of 36 to 49%. The percentage ratios of papilla heights and crown length demonstrated almost equivalent papilla proportion for all tooth groups of approximately 40%. There were no clinically relevant differences in mesial versus distal papilla heights in the anterior maxillary dentition. Hence, it's not only a white aesthetics, but also pink aesthetics is essential for a happy smile. Thank you.
Yes, Dr. Pranay, your topic
Good afternoon,
is
sir.
good. Good afternoon. Your topic is good, but your sample size is too small.
Yes, sir. I have taken less number of samples. I'll update it, sir.
Very less. I think 10 only samples you have taken. No?
Yes, sir.
It is very less to determine such confusion. And again, you haven't differentiated between male and female patients.
Sir?
Regarding male and female patients, you haven't differentiated how many male and how many female patients were there.
Sir, it was written in my inclusion criteria, sir. 6 female patients and 4 male patients were taken into consideration, sir.
So any difference between that particular male and female patients regarding that gingival zenith height and papilla?
I haven't found much difference, sir.
Okay. Okay. You should include higher sample size.
Yes, sir. I will take it into consideration, sir.
Okay. Yes, Dr. Kamal, sir.
Yeah, the point that has been made by Dr. Dhaval that the number of patients are so small, so less,
Yes,
that
sir.
the result can't be generalized. And is this the first of a kind study in India?
Sir, actually, when I was searching for literature, I found study from Korean study, sir.
Okay, not any Indian study?
Not many, sir. Very few studies. 1 or 2 I have found, sir.
I think some studies are available from Indian population.
Because region-wise also, the ethnicity also make changes in the height of the papilla.
Yes, sir.
So if Caucasian have more papillary height, same height can't be compared with the Indian population.
Yes, sir. Yes, sir.
Right?
Yes, sir.
Okay. So you didn't find any Indian study?
I did not find, sir.
Okay, okay. Okay, nice presentation.
Thank you, sir.
Thank you.
Hello, everyone. I'm Dr. Sindhura, second year postgraduate. I'm here to present my study titled Field Emission Scanning Electron Microscopy of Subgingival Dental Plaque Biofilm and Ex vivo Study. These are the contents which I'll be dealing in the next slides. Dental plaque is a complex biofilm which has been known to be a reservoir of microorganisms. A comprehensive knowledge of the content, structure, and function of the biofilm matrix is of paramount importance in dawning of new methods of biofilm control. Electron microscopes have been a preferred method for visualizing biofilms, which provides information about the spatial structure and the details of the presence of extrapulmonary substance. The novel field emission scanning electron microscope employed in this study helps to obtain clearer, high quality, and less electrostatically distorted images with a high spatial resolution down to 1 nanometers, which is 3 to 6 times more when compared to the conventional scanning electron microscope. The aim of the study is to explore the ultrastructure of subgingival dental biofilm at different resolutions using field emission scanning electron microscope. Patients were selected who require extraction of the teeth with radiographic horizontal bone loss of over 50% and mobility of grade 2 and grade 3. Following informed consent, teeth were extracted using atraumatic method. The extracted teeth were sectioned using a dental aerator handpiece under water cooling without touching the lateral root surface. The samples were fixed in 2.5% glutaraldehyde, post-fixed in 1% aqueous osmium tetroxide, dehydrated in a series of graded alcohols, dried to critical point drying, mounted over the stubs with double-sided carbon conductivity tape. Gold sputter coating is done using automated sputter coater and scanned under field emission scanning electron microscope. The results are as follows. Dense layer of short rods, fusiform bacteriae embedded in thick extracellular matrix can be seen in this picture. This image shows cocoid and short rods arranged in clusters showing seaweed appearance with intricate microcanalicular system between the bacterial towers. These images shows mixed microflora from the surface with cocci and rods, and the hyphal structures are seen at a higher magnification. This picture shows short rods emerging from the extracellular matrix and a thick sweater-like mats of extrapolymeric substance that envelops the cells. This arrow indicates the degenerating cells. Long hyphae-like structures and thin strands of extracellular matrix can be visualized in this picture. Early concave appearance is seen here. Early concave appearance at a higher magnification of 65,000 and 1,20,000 are seen with thick sweater-like mat of extracellular matrix enveloping the bacterium. These images shows cocoid cells arranged in chains in dense extracellular matrix at different magnifications. These images shows a mat of oven filaments and bacilli making up thick plaque. Here we can visualize multi-species biofilm with short rods, cocci arranged in clusters in the extracellular matrix. These are the long rods and the hyphal structures. Short rods and cocci arranged in clusters are seen along with the hyphae-like structures and the long rods. This image shows spirochetal organisms. These are the shrunken cells which are due to the dehydration during sample preparation. Septa and vesicles on the bacilli can be visualized at a higher magnification of 65,000 and 1,20,000. This image reveals short rods and cocci arranged in a dense extracellular matrix. Shrunken cocoid cells are embedded in the extracellular matrix in the picture. Electron microscopic analysis reveals a clearer images using field emission scanning electron microscope when compared to the conventional scanning electron microscope. It is often difficult to visualize extracellular matrix with confocal laser scanning microscope and scanning electron microscope because of the limited resolution. Field emission scanning electron microscope uses field emission gun that provides extremely focused high and low energy electron beam, which greatly improves spatial resolution, which aids in enhancing specimen contrast for biological samples. This helps in visualizing very small topographic details of the dental plaque biofilm. The level of magnification and resolution of the images obtained in this study are much higher, showing significant structural features like extracellular polymeric material, vesicles, septae, long hyphal structures, early concave appearance, seaweed appearance, and the degenerating bacterial cells. The extracellular matrix is a significant structure of the dental biofilm. It shields the native microorganisms from effect of host immunity or antimicrobial drugs. This study reveals the novel insights into the structure of the extracellular matrix at a higher resolution. Coming to chemical implications, we find that field emission scanning electron microscope assists in better understanding of the intimate details of biofilms ultrastructure, their 3D organization, cell population behavior, and reactions after drug treatments. Also, to design antibiofilm molecules that act on extrapolymeric matrix that effectively minimizes biofilm-related infections. Hereby, I conclude, unlike other microscopic techniques, novel field emission scanning electron microscope enables us to locate the structure of dental biofilm at a higher magnification and resolution. Following are the references provided. Thank you.
Good afternoon, sir.
Good afternoon. Very nice presentation, Doctor.
Thank you, sir.
The images you clicked were really very nice and in detailed presentation. Can you tell me what are the bridging species?
Sir, Fusobacterium nucleatum, sir.
Yes, yes.
As we have already seen in the samples, we can find that at a very higher magnification, sir. The early concave appearance and.
Yeah, what is the role of this bridging species?
Sir, these bridge between the initial species and the climax species, sir. And they have all the adhesins which can adhere, like they help in co-aggregation of this bacteria, sir.
Fine. Over to you, Dr. Kamal.
Nice presentation. Good afternoon. So, any similar study from India or abroad?
No, sir. As for as the literature in India, this is the first study, sir. But abroad in 2015, one study has been done, which is the key study for my this study, sir.
Okay. So, what are the clinical implications of the result of your study?
Sir, as we can see, ultra structure of the plaque or the dental biofilm, so that we can assess further, like even after treatment, what are the structure of the plaque or the any remnants, and even on the extracellular matrix also. Nowadays, extracellular matrix is being considered more important in the dental plaque biofilm, sir. So we can see more insight into that extracellular matrix and even the structural features of the bacteria, so that we can provide or develop new methods of biofilm control, sir.
Yeah, okay. Thank you. Nice presentation.
Thank you, sir.
Good morning. My topic is, are the dentists prepared to work in the new normal conditions after COVID-19 infection, and can saliva be used as a diagnostic tool? A questionnaire study. Coming to the introduction, COVID-19 epidemic started in Wuhan in mid-December 2019. Soon in January, WHO declared it as a pandemic. The virus is an enveloped single-stranded RNA genome. Diagnosis is made by clinical, radiological, vital parameters and or laboratory tests. The oral cavity is the major source of microorganisms to enter the human body. The spread of COVID-19 mainly occurs through saliva droplets or nasal discharge. The common features are fever, reduced oxygen levels, and radiopacity in the chest. Saliva, it has a normal pH of 6 to 7.6, secreted majorly from the major and minor salivary glands. The diverse functions are lubrication, initiation of digestion, immunity, etc. It can help in contribution of early detection of coronaviruses. Salivomics is the study of microorganisms and their metabolites present in saliva. The SARS-CoV-2 may be present in saliva from 3 different sources. That is, virus entry in mouth from lower or upper respiratory tracts, access to oral cavity through outflow of gingival clavicular fluid, and release of viral particles in saliva through infected salivary glands. The clinical signs are ambiguostasia, which is a diminished sensitivity to taste, dry mouth, ulcerative or blistering, erythematous rash, vesicles, urticaria, and trunk. The materials and methods used were an online questionnaire was generated through Google Forms. Survey link was sent to academicians, clinicians, postgraduate students, interns, Vidarbha region, Maharashtra only. The survey was open for 3 weeks from 29th November to 18 December 2020. Questionnaire asked questions like common diagnostic test used for COVID-19. Can saliva be used as a diagnostic aid and its advantages and disadvantages? Pathways for virus entry and receptors for virus, biological decay. The other questions asked were symptoms of COVID-19 in oral cavity, its duration in saliva, pre-procedural mouth rinses, surface disinfectants for inactivation of virus, safe position of the operator, and tips for safe working. From the questionnaire, objective of the author were to know whether dentists who are at the highest risk of developing COVID-19 infection are prepared to diagnose COVID-19 and get their tests done with the signs and symptoms, protect themselves from encountering the pandemic, and can saliva be used as a diagnostic aid? In a nutshell, are dentists prepared to work in the new normal conditions? Coming to the results, 308 out of 500 participants answered the online survey. Data was analyzed using SPSS V23 software and the level of significance was at 5%. Correct responses were compared using frequency distribution tables and statistically by the chi-square test. According to the occupation, academician contributed to the highest of 65.3%, followed by practitioners and then both. Statistically, Table 1 compared correct responses among academicians, practitioners, and both. Table 2 compared knowledge of academicians, practitioners, or both about COVID-19 spread. So, the results are, in Table 1, 4 out of 18 questions showed statistically significant differences in correct responses, and in Table 2, no statistically significant differences were found in knowledge about COVID-19 infection spread. Coming to discussion, early disease detection of COVID-19 is beneficial for the working professionals. Saliva by RT-PCR can be a substitute for nasopharyngeal and oropharyngeal swabs, and early detection of COVID-19 is beneficial for a periodic disease monitoring can also be done. Table 1 again shows that the differences were insignificant in correct responses in 80% of the question asked, and only 20% of the questions had significant differences. Table 2 showed no significant differences. 70 to 80% of the 308 participants were cognizant with the protocols to be followed for safe dental practice. It shows that the dentists were similarly aware of practicing in the new normal situation. Coming to the benefits of salivary diagnostic technique, it is attributed to the ample biomarkers present in the saliva. It has the benefit of easy process, safety, cost effectiveness, and non-invasiveness. Coming to the prevention, saliva forms aerosols and reach distant hosts through airflow. So to prevent this, 6 feet distance around the dental chair should be maintained. The 10 o'clock or 11 o'clock position minimizes the risk of splatter, whereas 8 o'clock maximizes the risk. Now, the precautions while performing dental treatment, especially the procedures which are aerosol generating, are patient placement, hand hygiene, personal protective equipments, and precautions to avoid splatter. The general tips for safe dental practices include extractions to be done in supine position, dental processes or impressions to be disinfected, suction should be carefully carried out to prevent gag reflex, mucosal anesthesia before impressions if needed to be given, proper size of tray should be used, use of N95 mask and extraoral imaging to avoid gagging. Coming to the conclusion, COVID-19 pandemic creates worries in practicing dentistry, especially after advent of post-COVID complication, mucormycosis. Therefore, adequate knowledge of transmission and prevention is important. The new normal conditions are adapted by the dentist after the COVID-19 pandemic. Therefore, saliva can be a diagnostic tool which can ease in the chairside investigation. These are the references. Thank you.
Nice presentation, doctor. Over to you, Dr. Kamal sir. Any questions?
Good evening, sir.
Good evening.
Dr. Dhanashree,
Yes, sir.
have you validated the questionnaire before sending it to or emailing it to the respondent?
Yes, sir.
Yes. How you have validated?
Sir, validated in what sense? I did not get the question.
See, before starting the study, questionnaire study or questionnaire survey,
Yes, sir.
you have to validate the questionnaire with the help of your peers.
Yes, sir. So,
Yeah.
yes, sir.
Go.
I've done that. Yes, sir.
Okay. Okay. So, aware about the saline gargle test by NIRI for COVID-19? No? Okay. Okay, nice presentation.
Thank you, sir.
Thank you. Thank you. Thank you. I'm done. Next
Hello?
presenter, Puneet.
Sir, am I audible now?
Yeah, you are audible.
So because of some personal problems, Dr. Puneet is not there. So
I am there.
he's the
I am
last-
there. Hello.
Yes, sir. He's
I
the
am
last
there.
presenter for today's session. Yes, Puneet, sir.
Good
Yes.
evening. Good evening, Doctor Sir.
Yeah, good evening. Good
Good
evening.
evening.
We'll be
First,
taking
before
his
before
presentation.
starting my presentation, I should thank the ISP, Dr. Abhay Kolte sir and Dr. Nimpia madam, for taking special consideration on my request. I am currently in home isolation. My dad, my wife, and myself are all COVID positive. Today is the 10th day, so I couldn't record the video. So I need your permission to go live with my presentation.
Go ahead. Go ahead.
Just a moment, sir.
Thank you, sir.
Sorry?
You can start.
Yes.
Yes.
I'm sharing my screen, sir. Is this visible, sir?
Yeah.
Okay.
Yes.
Good afternoon, panelists, sirs, and with a warm regards. This is my clinical research presentation with the paper presentation ID 738-696. Myself, Dr. Puneet Kalra, final year PG from Surendra Dental College, Shri Ganganagar. This presentation is actually the dissertation work that I carried out last year, submitted in November. This is inspired and dedicated to my mother, who retired as professor and head obstetrics and gynecology from Government Medical College, Bikaner. It is a comparative evaluation of the concentration of bisfatin in GCF and serum in women suffering from periodontitis with or without polycystic ovary syndrome, that's PCOS, before and after NSPT. This is a randomized controlled clinical trial. I had registered it with the CTRI number given below. This was the institutional ethical committee that I took the clearance from. Now, as we all know that periodontal disease is now considered to be an immunoinflammatory disease as a result of interaction between microbial attack and host inflammatory response. PCOS, which will be referred to as in the short form, is a complex metabolic disease, the most common gynecologic and endocrine condition among women in reproductive age. Both of these are associated with systemic inflammation and insulin resistance, thus they may be linked to a common pathophysiologic pathway. Recently, the association between periodontal disease and PCOS has been established and has been revealed that bisfatin levels increase in both of them. So this study was carried out with an aim to establish a relationship between the serum and the GCF levels of bisfatin in women suffering from periodontitis with or without PCOS, and also the effect of NSPT on bisfatin levels. So all the data that, all the studies that previously have been done, they have established a relationship between periodontal disease and PCOS. They have established a relation that in both these, periodontal disease and PCOS, bisfatin levels have increased. The previous studies have established that NSPT decreases the visfatin level. But this was the first study as far as our research goes, our search engine goes, which has connected the triad, periodontal disease, PCOS, visfatin level, and the effect of NSPT on the visfatin level in both the cases. So, brief introduction, periodontal disease is an inflammatory disorder caused by pathogenic microbiota present in the oral biofilm that trigger innate inflammatory and adapted immune response. They have the altered vascular response, increased level of adhesion molecules, and higher expression of local and systemic inflammatory cytokines, resulting in impaired endothelial function. So we know that bacteremia in periodontitis has been reported after oral examination, and the periodontal pathogens have been shown to colonize distant sites. Additionally, the different bacterial components such as major outer membrane proteins and enterotoxins may be disseminated. In response to this systemic bacteremia, white blood cells as well as tissue cells at locations where the antigen are relocated, such as endothelial cells and hepatocytes, may produce pro-inflammatory immune mediators. Locally produced pro-inflammatory mediators such as interleukin-1 beta, tumor necrosis factor, IL-6, prostaglandins may spill into the circulation and exert systemic or distant effect. These relation has been validated by the relation of the periodontal disease to the systemic disease or vice versa. Now, PCOS, a little brief introduction about PCOS, also known as Steen-Leventhal syndrome. It has a prevalence of 9.13% in Indian women of the childbearing age. There are various pathological mechanisms as given by King et al. Altered secretion of the gonadotropin releasing hormones, defect in the androgen synthesis, and development of insulin resistance, which is one of the main link between the periodontal disease and the PCOS. In the year 2004, the most accepted Rotterdam criteria, which we also used in our study, was used to diagnose the PCOS, which states that at least two of the following three features to be present in the lady to diagnose her of PCOS. That is, first is oligoamenorrhea, clinical or biochemical hyperandrogenism. Third is polycystic ovaries on ultrasound. Then, Thurston et al. Was the first to report an association between periodontal disease and PCOS. This cascade of pro-inflammatory events has been postulated as the possible link. There is also a relation between the two diseases by the local or the periodontal oxidant status. I'll go in short. The insulin resistance is also increased in both. There is systemic low-grade chronic inflammation in both these diseases. So the PCOS increases by 28% the risk of having periodontal disease, and vice versa. Periodontal disease increases by 46% the risk of having the polycystic ovary syndrome in such kind of women. Now, what is visfatin? Visfatin, white adipose tissue, is an energy storage organ with some metabolic activities participating in the endocrine and secretory system. It secretes several immune modulator adipokine molecules such as adiponectin, leptin, visfatin, resistin, chimerin. So it is also known as nicotinamide phosphoribosyl transferase protein that increases the free B cell colony release from lymphocytes. It is also released from lymphocytes, dendritic muscles, and studies have found out that it is locally released from the periodontal ligament and bone marrow cells. This was very important factor in our study, which will be discussed in the results section. So visfatin is increased under inflammatory conditions such as rheumatoid arthritis, cardiovascular disease, type 2 diabetes, and periodontal diseases. Synthesis of visfatin in the periodontal ligament and gingival fibroblast cells could be stimulated by periodontal pathogens and some pro-inflammatory cytokines like interleukin-1 beta. Now, higher visfatin levels in both these two diseases indicates the possible role of visfatin as a link of association between these two diseases. What I want to stress is that we have been talking about the link, the bidirectional link of periodontal disease and diabetes and other diseases. And definitely we have been talking that the female sex hormones have a detrimental influence on the periodontal status. But in our clinical practice, we have seen that whenever we see a patient, our first systemic history is that do you have diabetes, do you have cardiovascular disease, do you have hypertension, and XYZ all. If there is a lady patient, I have come to know because of my mother's clinical practice of around 35 to 40 years now, and my own this study. I chose this topic specifically as my dissertation because I wanted to do something with a gynecological touch in my periodontal post-graduation. So I found out that it is not just talking about diabetes and other systemic disease. If we have a lady patient, we should talk about the menstrual history, any other gynecological irregularities which can definitely have a detrimental effect on our periodontal disease, and it can have a detrimental effect on the periodontal treatment outcome also. Now, so the rationale I discussed it. This was the objective to estimate the serum and the GCF levels of vispatin in periodontitis patient without PCOD before and after NSPT. Similarly, in periodontitis women along with PCOS before and after 3 months of NSPT, and the effect of NSPT on the clinical periodontal parameters as well as the vispatin levels. So inclusion criteria was age group was 20 to 35 years, and the general inclusion criteria like the periodontal parameters. Then the BMI I had fixed in my study was that females with BMI more than 30 kg per square meter were excluded. So I didn't include the obese woman. That is one of the limitation of my study, because it narrows down to only one particular set of females with a low BMI only. Because obesity, again, it can become a confounding variable as far as the periodontal disease and PCOS is concerned. So the diagnosis was made by, confirmatory diagnosis was made by the gynecologist taking into consideration the polycystic ovarian image on ultrasound. This was the study design. Group 1 had 25 patients of chronic periodontitis without PCOS. Group 2 had chronic periodontitis patients without PCOS. And by random coin selection, I divided them into group 1A and group 2A, 15 patients each. All the periodontal parameters were recorded, serum and GCF sample collected for the estimation of vispatin, NSPT performed, and 3 months after this, again these patients were recalled, again periodontal parameters recorded, serum and GCF sample collected, and then the comparisons were made. These are the results. The mean value showed that there is a statistical significant difference between patients who do not have PCOS and periodontitis patients with PCOS. There is a statistical difference between the periodontal parameters. Then the serum and GCF levels also were significantly different, but the GCF levels were more in the group 2A, which had PCOS and periodontitis. Why? Now that study comes into being that the vispatin is locally secreted by the periodontal ligament. So the GCF concentration of vispatin was more as compared to the serum. Then comparison was done. The effect of NSPT was done. It was found significant that when the NSPT was done and the periodontal parameters were reduced, concurrently the vispatin levels were also reduced. But in the case of the patients who had PCOS, the decrease was not much because the NSPT only worked on the decreased concentration of vispatin in the GCF. But the serum component of the vispatin in women who had PCOS was not reduced much because of the NSPT. Hence, it proves that PCOS and periodontitis are linked by many pathophysiological pathways, and one of the biomarker can be was shown to be vispatin, and it was reiterated by some of the past studies, which in brief I will cover up in the discussion. Rahimnejad, he showed that the prevalence of PDs was higher in women with PCOS related to the role of chronic systemic inflammation. The higher bleeding on probing rates with PCOS compatible with the known impact of hyperandrogenism on the vascular flora, and also the increased clinical attachment loss in patients with PCOS might be attributed to the increased susceptibility to the activation of inflammatory process. A very recent study in 2017 by Nair et al. They showed that there is a statistically significant difference in the prevalence of periodontal disease in the PCOS group because the gingiva becomes hyper responsive to the mildest of the microbial deposits, because the increase in the steroid levels in women with PCOS alters the gingival response. Abol Fazli et al. Showed a direct relationship between the periodontal tissue status and the serum and salivary levels of vispatin. Past studies, there are many studies which had been done on the salivary levels of vispatin. We chose GCF. Definitely, I found it difficult because of the collection of the GCF and the amount to be, which I could collect was very less, but still the ELISA kit that I used, it was sufficient enough to do the ELISA reading. Then our results were consistent with the study of Tudor CC et al., who observed that NSPT resulted in the significant reduction in the GCF and serum vispatin levels. The concentration of vispatin in the GCF was found to be greater than the serum. This was a very important result that we found out, that the GCF concentration was more than the serum. This may be due to the localized secretion of the vispatin. Dickman et al. Showed that the serum vispatin in non-obese was similar to that of the healthy participant. So this was the limitation in my study, where I had excluded the woman with BMI of more than 30 kg per square meter. Then a meta-analysis revealed that vispatin levels can be biomarkers for PCOS. The association between the vispatin levels and the advanced CP was evaluated, and these studies showed that the advanced chronic periodontitis patients have higher vispatin levels, which was consistent with our results. These are another few of, this is not a very old concept, but it is a recently studied, what should I say, inflammatory marker, vispatin. As it is visible that 2012, 2011, not very deep in the history, but a very recently researched molecule, creating a, what should I say, relationship between the other systemic diseases and periodontal disease. These are all references and reiteration that my study, the results was similar to what the past researchers have carried out. So the results obtained are in concurrent with the past studies, authenticating the positive association of PCOS and periodontal disease, the impact of PCOS on periodontal parameters, vispatin as a possible link between the two diseases, and lastly, the significant effect of NSPT on the reduction of inflammatory markers in serum and GCF. Finally, the gingival inflammation and periodontal loss of attachment was significantly higher in women with PCOS. Mean GCF and serum levels of vispatin decreased after NSPT in both the study group. However, the decrease is more significant in the group without PCOS that responded better to periodontal treatment in terms of decrease in the infection burden, because the PCOS has a systemic component, and we are dealing with only when performing NSPT, we are doing only the reducing the local inflammatory component. So the GCF concentration of vispatin was decreased more as compared to the serum after NSPT in the second group of CP plus PCOS. Considering the above discussed literature, we can extrapolate that as an underlying systemic endocrine condition, PCOS might exacerbate the periodontal condition through various pathophysiological links, exerting a compounding role in resulting gingival inflammation and periodontal health. So the healthcare professionals, gynecologists and endocrinologists, because not just gynecologists, in treating a patient of PCOS, a lady of patient, rheumatologists and endocrinologists are also involved, because it has a huge factor of hirsutism involved. So those are also involved, because the hormonal balance has to be created to get the polycystic ovary syndrome ka symptoms relieved from that lady, which seriously leads to infertility in the reproductive age of the woman. So it is a combined role of a gynecologist and an endocrinologist. So they should get familiar with the periosystemic link and risk factors, and need to refer to the specialized dental or periodontal care, need to proactively motivate patients diagnosed with PCOS to maintain good oral hygiene at all times, and refer to dentists to avoid periodontal implications, as this hormonal disorder can worsen the vulnerability to plaque-induced periodontal disease. This I already said, the one of the major limitation was the BMI selection, and it could have been on a larger sample, and also the duration could have been more than 3 months post NSPT. Conclusions, I've already repeated so many times, I won't go. This is the data that I collected for few pictures, the gynecological consultation, the sonographical examination, which led to the confirmatory diagnosis of PCOS in the woman. These are one of the few of the armamentariums. This is the ELISA kit that I used for the human vispatin ELISA kit. This was the standards and the standard calibration after adding the stop solution, the various stages of the ELISA after adding streptavidin and substrate solutions, I also used occlusal stents to measure the clinical attachment loss pre and post NSPT. Then these are the micro GCF collection tubes that I used for the GCF collection. A few clinical pictures for the microcapillary pipette collection of the GCF. Then group 1A patients before NSPT, group 2A patients before NSPT, then the pre and post NSPT OPG views of one of the patients. I couldn't put the pictures of many patients. Thank you so much, sir. Thank you so much, and thank you the entire ISP office PRS.
Yes, very nice presentation, Dr. Puneet.
Thank you, sir.
So what according to you is the key factor in the pathogenesis of polycystic ovarian syndrome and periodontitis?
The common link is chronic low-grade systemic inflammation, sir.
Right, which leads to elevation in
The chemical mediators of inflammation, specifically interleukins and TNF, and bisfatin is one of the adipokines. That's why the periodontitis and PCOD both are more in obese patients because of the more of the adipocytes. So bisfatin has been found to be a major chemical mediator in obese patients who have periodontal disease along with PCOD.
Okay, so during case selection, what were the age groups? Because age groups of the female patient will also influence.
Yes, definitely, sir. Definitely. Yeah. So I didn't go for a higher age because there again the female sex hormones leading to menarche or menopause could adversely affect the the parameters, and not it was beyond the pubertal age, just at the reproductive age, 25 to 35. That was the age group.
Okay. Over to you, Dr. Kamal.
Yeah, nice presentation, Dr. Puneet.
Thank you, sir.
So, any last word on clinical implication of the result of your study?
As I said, sir, we all as clinicians and periodontists, we all like to take a history of diabetes, cardiovascular disease, any medications, any hypertension, all those things. But as far as my clinical practice and my experience says, we always neglect talking to the lady patient about her menstrual problems, menstrual cycle, or any other gynecological treatment she might have taken for infertility. She might be on oral contraceptives. She might be on hormone replacement therapies. She might be on something that could influence our periodontal status and definitely the outcome of our periodontal treatment.
Right.
Okay.
Okay. Thank you.
Thank you. Thank you so much.
Thank you very much.
Sir and Dr. Kamal Kishore, sir, for your
Thank you,
valuable
Dr.
time
Girish.
sharing this session and
Thank you.
the extended part of the session. Thank you, all the participants, and sincere regards to all the delegates for their active participation and we acknowledge their important role in the success of this scientific event. We hereby end with the scientific sessions for this PG convention. The results will be declared in the valedictory function. So see you soon at the valedictory function. Thank you all the participants and thank you, Sir. Thank you, Puneet. Stay safe, stay healthy. Goodbye.